Bonjour, bonjour professeur.
Bonjour.
Bonjour, ça va, vous allez
Voilà.
bien?
J'allais, j'avais pas trouvé le. Oui, oui. J'ai essayé déjà
Le partage d'écran, oui, on a
le
vu, on a
partage
vu.
d'écran et ça marche bien.
Ça
Mais
marche
je
très bien.
pense que je vais enlever la vidéo lorsque je commence à parler parce que sinon ça va perturber, je pense, non?
La vidéo qui tourne maintenant,
Disons la caméra de l'ordinateur, je vais l'enlever lorsque je.
c'est quand vous voulez, c'est quand vous voulez. En tout cas, on a
Ouais.
un bon débit, donc ça gêne pas.
Oui, oui, je vois, c'est parfait, c'est
Hmm.
parfait. Et, et puis
Vous
après,
allez,
quand,
vous allez présenter en français ou bien en anglais?
en français, mais les diapositives en anglais.
D'accord, ok, pour prévoir la traduction ici.
Donc, c'est pas, en principe, c'est pas la peine.
Non, c'est-à-dire, c'est pour nos invités qui ne comprennent pas le français.
Ah, vous préférez que je parle en anglais?
Bah, si c'est possible.
Oui, 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 c'est possible. Moi, je
Si,
peux
si,
parler même en anglais. Mais j'avais pensé à le faire en anglais, mais en français.
Test,
Mais
test, test.
bon, enfin, si c'est possible en anglais, on le fait en anglais. Parce que
ah,
l'idée, c'est que la conférence se veut majoritairement
très
en
bien.
anglais.
Alors, je vais traduire tout de suite le titre que j'avais changé. Et puis oui, parce qu'il n'y avait que le titre en anglais. Et puis, donc, je vais parler en anglais.
Ok,
Test, test.
ok,
Parfait.
parfait, parfait. Merci.
Je vous en prie.
À tout à l'heure.
À tout à l'heure.
les présentations. Bon, directement le هيك. عبدي محمد روح.
Test, test.
Possível.
Good morning, everyone. Welcome all to the second edition and the second day of Algiers International Conference on Nuclear Medicine, AICON25. Thank you all for being here today. We will be beginning our program with our first topic of the day, Hodgkin lymphoma in Algeria, which will be presented by Professor Sabrina Akhruf. Is Sabrina Akhruf here? Thank you.
Donc, bonjour à tous. Tout d'abord, je remercie l'Association algérienne de médecine nucléaire et particulièrement le professeur Amimour pour l'invitation. Donc, je me présente. Donc, je suis professeur Akhruf, donc hématologue, clinicienne, donc au service d'hématologie greffe de moelle osseuse du Centre Pierre-Marie Curie d'Alger. Et là, je vais vous parler du lymphome de Hodgkin en Algérie. Donc, le lymphome de Hodgkin est une hémopathie maligne décrite en 1832 par Thomas Hodgkin, caractérisée par une infiltration ganglionnaire au sein d'un tissu réactionnel par de volumineuses cellules, donc tumorales, appelées cellules de Reed-Steinberg. Donc, ces dernières ont été décrites d'abord par Carl Steinberg en 1898 et Reed Dorothée en 1902. Ces cellules tumorales donc, proviennent d'un processus lymphoïde B du centre germinatif. Le lymphome de Hodgkin est une néoplasie rare, donc elle représente 10 à 15% des lymphomes, 1% de toutes les tumeurs malignes. Donc environ, donc son incidence est de 2,5 à 3 pour 100 000 habitants, avec une large variation géographique qui va de 0,5 à 4 pour 100 000 habitants. Il existe une légère prédominance masculine et un âge médian à 34 ans avec une incidence qui est bimodale. Donc il y a un premier pic chez l'adulte jeune, donc vers 30-40 ans, et un deuxième pic chez les individus qui sont un peu plus âgés, vers 60 ans. Il y a des cas familiaux qui ont été décrits. En Algérie, donc il y a la dernière étude qui a été faite sur 6 ans, donc de 2019 à 2024, donc qui vient d'être publiée dans le dernier congrès national d'hématologie. Donc le nombre de nouveaux cas, donc il est aux alentours, c'est une moyenne de 600 cas par an. Pour l'incidence, elle varie entre 1,22 et 1,55 pour 100 000 habitants. En ce qui concerne le diagnostic, donc tout d'abord la cytoponction à l'aiguille fine, donc elle est de moins en moins pratiquée, donc peut néanmoins fournir une orientation utile et rapide. Si le diagnostic de lymphome est fortement suspecté et du fait de la chimiosensibilité du lymphome, toute corticothérapie peut modifier l'aspect anapathe et l'imagerie métabolique, donc à éviter avant de procéder à la biopsie ganglionnaire. En ce qui concerne la biopsie diagnostique, donc il faut enlever le ganglion entier. Donc l'idéal c'est de faire une exérèse complète du ganglion et éviter les microbiopsies. Et ainsi que le curage ganglionnaire, il n'est pas indiqué dans les lymphomes comme dans le néo du sang. Donc ça ne sert à rien de faire un curage ganglionnaire. L'idéal c'est de faire une congélation rapide du tissu tumoral pour essayer de faire des études complémentaires si nécessaire après. La dernière classification OMS 2022 et ICC aussi 2022, donc classe le lymphome, elle sépare le lymphome de Hodgkin en deux parties. Donc il y a le lymphome nodulaire à prédominance lymphocytaire selon l'OMS et nodulaire à cellule B à prédominance lymphocytaire selon ICC et le lymphome de Hodgkin classique. Donc maintenant on ne parle plus de maladie de Hodgkin, on parle de lymphome de Hodgkin classique. Et ce dernier, donc on a 4 types histologiques. Donc il y a le déplétion lymphocytaire, il y a le cellularité mixte, il y a le scléronodulaire qui est le plus fréquent et le riche en lymphocytes. Le lymphome de Hodgkin classique donc, est défini histopathologiquement par la présence, comme on a déjà dit, de cellules de Reed-Steinberg. Donc ces dernières, elles sont CD30 positives sur un fond de cellules inflammatoires. Le CD30, c'est un biomarqueur qui est très important pour le lymphome de Hodgkin. Il est fortement exprimé à la surface des cellules de Reed-Steinberg. Et cette expression, elle est limitée à la surface des cellules de Reed-Steinberg. Donc, on ne le retrouve pas dans les cellules normales, ce qui en fait une cible thérapeutique très importante dans le lymphome de Hodgkin. Dans une étude rétrospective donc, qui a colligé plus de 1200 cas de lymphome de Hodgkin, c'est une étude allemande, elle a révélé que 98,4% des patients étaient positifs pour le CD30. Diagnostic posé, on fait un bilan d'extension. Donc, c'est normal. Donc, le bilan diagnostique, donc, il est intriqué avec le bilan d'extension. Donc, il y a l'examen clinique, les examens radiologiques. Donc, et parmi les examens radiologiques, il y a l'imagerie qui est très importante. Donc, il y a d'abord ce qu'on faisait standard. On garde toujours la radiographie pulmonaire. La TDM cervico-thoraco-abdominopelvienne aussi, on la garde. La biopsie médulaire, donc qui était systématique avant, maintenant on tend à ne pas faire la biopsie si on fait un TEP scan. Le TEP FDJ, donc il permet d'améliorer la qualité de la stratification de l'atteinte ganglionnaire en complétant les données des autres examens diagnostiques d'imagerie. L'intérêt de la TEP FDJ dans le lymphome de Hodgkin, donc il y a 3 TEP idéales à faire. Donc, il y a la première TEP, c'est avant traitement. Cette dernière, elle modifie le stade dans 20% des cas et la stratégie thérapeutique dans 10% des cas. La TEP intermédiaire, qui est en général faite après 2 cures de chimiothérapie, donc elle juge la chimiosensibilité et le résultat de la TEP 2 est corrélé à la survie sans progression. L'intérêt de la TEP de fin de traitement, c'est distinguer des reliquats fibreux des masses évolutives. Avant, avec le scanner, on avait des masques résiduels qui restaient, donc on mettait un traitement de rattrapage, 2e ligne, 3e ligne, et la masse ne bougeait pas. Après, on jugeait que c'était une RCU ou réponse complète non confirmée. Et on surveillait les patients, 10 ans, 20 ans après, ils n'ont jamais rechuté. Donc, le TEP et tout ce bilan d'extension, donc il permet de classer les patients, donc selon la classification d'un arbore, en 4 stades. Donc, il y a le stade 1, donc quand on a une seule atteinte ganglionnaire, en sus ou sous-diaphragmatique. Le stade 2, c'est quand on a 2 atteintes tumorales du même côté du diaphragme, soit en sus-diaphragmatique, soit en sous-diaphragmatique. Le stade 3, quand il y a une atteinte en sus et sous-diaphragmatique. Et le stade 4, quand il y a une atteinte viscérale. Analyser les facteurs de risque et définir les groupes pronostiques thérapeutiques sont une étape obligatoire pour décider du traitement adapté au risque. Les différents groupes de risque, donc selon la classification, le groupe ORTC et le groupe allemand, donc ils classent les stades 1 et 2 localisés, donc en sus-diaphragmatique, selon la présence ou non de facteurs de risque. Donc s'il y a présence de facteurs de risque qui sont, selon l'ORTC, donc il y a l'âge qui est supérieur à 50 ans, les aires ganglionnaires qui dépassent les 3, l'existence de symptômes B avec une VS accélérée à 30 ou l'absence de symptômes B avec une VS qui dépasse les 50 et une masse ganglionnaire volumineuse, soit 10 cm, soit un indice médiothoracique qui est supérieur à 0,35. Quand on a un seul facteur de risque, c'est un stade 2 qui est défavorable. En absence de ces facteurs, c'est un stade 2 qui est plutôt pas 2, c'est un stade 1, 2, c'est les stades localisés favorables. Et de même pour les facteurs de risque allemands, c'est pratiquement les mêmes facteurs. En ce qui concerne les stades étendus, donc les stades 3-4, donc il y a une autre classification. Donc c'est le score pronostic international IPS qui prend aussi 7 paramètres. C'est pratiquement les mêmes. Il y a un peu plus des paramètres biologiques. Donc il y a le sexe, l'âge qui dépasse les 45 ans, le stade 4, le taux d'hémoglobine quand il est inférieur à 10,5, taux de globules blancs supérieur à 15 gigalitres et taux de lymphocytes inférieur à 600 et l'albumine inférieur à 40. Et là, l'IPS, donc s'il y a un ou deux facteurs, c'est un risque standard. Au-delà de 3 facteurs, donc 3 jusqu'à 7 facteurs, c'est un lymphome de Hodgkin étendu de haut risque. En ce qui concerne l'épidémiologie selon le groupe de travail algérien, vous voyez, donc on a les stades 3-4 représentent plus de la moitié de la série. Donc on a beaucoup plus de stades étendus. Les signes généraux sont présents aussi dans pratiquement 60% des cas. La forme bulky, donc forme volumineuse, masse tumorale volumineuse et IMT supérieur à 0,35 est retrouvée chez un quart des patients. Et les stades 4, les atteintes extranodales sont retrouvées chez un tiers des patients. Toujours en Algérie, donc la dernière étude épidémiologique sur 6 ans, donc vous voyez dans les stades localisés, donc pratiquement 3 quarts, 75% des patients sont localisés mais défavorables. Dans les stades étendus, donc 52% des patients sont étendus au risque. Donc, on a des patients qui sont vraiment défavorables, localisés et étendus au risque. L'accès au PET scan en Algérie. Donc, c'est une étude, comme je vous ai dit, une étude récente, ça fait 6 ans, c'est en 2024, la dernière année. Donc, le TEP initial, donc, il a été réalisé chez 35% des patients. La TEP intermédiaire, donc, chez la moitié, et la TEP terminale, donc, en fin de traitement, chez 36% des patients. C'est un peu mieux par rapport aux années précédentes, mais il faut encore faire un peu plus. On va rentrer dans le chapitre du traitement de première ligne. Donc, le traitement de première ligne est le traitement de référence des rechutes. Plus on tape en premier, mieux on évite les rechutes. Donc, la maladie de Hodgkin est une maladie qui est curable avec un excellent pronostic. Donc, la guérison, donc, on peut l'avoir dans 90% dans les formes localisées et 80% dans les formes étendues. Mais malgré les avancées thérapeutiques du lymphome de Hodgkin, il y a 10% des formes localisées qui rechutent et 10% des formes étendues sont réfractaires, 20 à 30% rechutent. Deux régimes de chimiothérapie classique, donc il y a la BVD avec un meilleur rapport efficacité et toxicité et le BACOP escaladé qui a un meilleur contrôle tumoral avec une toxicité quand même qui est non négligeable. À l'échelle internationale, donc l'ABVD représente le gold standard pour les patients atteints de lymphome de Hodgkin avec un taux de réponse complet d'environ 70 à 80% dans les lymphomes étendus. Donc l'ABVD, donc il associe la doxorubicine, c'est des anthracyclines, la bléomycine, la vinblastine et la dacarbazine, c'est JRJ15, c'est des cycles tous les 28 jours. Le deuxième protocole, c'est le BACOP. Le BACOP par rapport à la BVD, il a une efficacité qui est supérieure chez les patients toujours dans les lymphomes de Hodgkin avancés, mais présente l'inconvénient d'une toxicité qui est accrue à court et à long terme. Les toxicités décrites, donc c'est essentiellement donc des événements hématologiques aigus, donc qui sont beaucoup plus importants avec le BACOP par rapport aux chimiothérapies standards qu'on utilisait, c'est le COP et la BVD. Et les événements aussi non hématologiques de grade 3-4, donc à savoir donc la chute de cheveux, les nausées, les mucites, l'atteinte respiratoire et l'atteinte du tractus digestif. C'est pour cela, donc pour cette toxicité importante du traitement de première ligne, donc il y a eu, on a essayé de changer les protocoles, donc à savoir pour la toxicité pulmonaire de la bléomycine, donc jusqu'à 25% des patients traités par ABVD développent une toxicité pulmonaire. Et si vous voyez la survie à 5 ans, pour les patients donc, qui n'ont pas reçu la bléomycine est de 90% versus 63% pour les patients qui ont reçu la bléomycine. Deuxièmement, donc il y a la cardiomyopathie des anthracyclines. Donc les anthracyclines sont utilisées dans les deux protocoles, la BVD et le BACOP. Troisièmement, donc il y a l'augmentation des néoplasies malignes secondaires et essentiellement donc les syndromes myélodysplasiques et les transformations en leucémie aiguë myéloïde qui sont beaucoup plus importants dans les traitements intensifiés par rapport aux traitements qui sont non intensifiés. L'hypofertilité du BACOP escaladé, donc elle est connue. Et c'est pour cela, donc, par exemple, dans le BACOP, donc il y a le BACODE. Dans le BACODE, donc on a remplacé pour éviter la toxicité de la procarbazine, donc on a remplacé la dacarbazine par la procarbazine. Et dans l'objectif de réduire cette toxicité, sans compromettre bien sûr l'efficacité, l'identification précoce, donc après 2 cures, des bons et des mauvais répondeurs grâce à la TEP FDJ, a ouvert la voie donc des stratégies dites adaptées à la réponse TEP guidée. Donc on parle maintenant de stratégie TEP guidée. Donc chaque patient, donc c'est un traitement à la carte. Chaque patient, il a son traitement personnalisé de préférence, donc avec la TEP. Par exemple, en cas de TEP négatif, on fait, bien sûr, en cas de TEP 2, donc après 2 cures de cycle, donc on fait une désescalade. Si la TEP est positive, on fait une escalade thérapeutique. Donc on peut commencer par un traitement qui est moins intensif. Si TEP négative, on continue. Si elle est positive, là on escalade, donc on évite la toxicité. L'arrivée de l'immunothérapie dans le lymphome de Hodgkin a complètement bouleversé le traitement du lymphome de Hodgkin, d'abord dans le traitement de rattrapage, et après, donc l'immunothérapie maintenant, elle vient en première ligne. Donc, à savoir, donc le brentuximab vedotin, qui est un anticorps anti-CD30. On a vu que le CD30, il est pratiquement jusqu'à 100% exprimé par les cellules de Ritz-Stenberg. Donc là, c'est une thérapie ciblée, donc c'est un anti-CD30. Et deuxièmement, donc il y a les inhibiteurs de checkpoint essentiellement, donc les inhibiteurs de PD-1, donc le pembrolizumab et le nivolumab. Donc l'immunothérapie en première ligne, donc il y a l'étude échelon, donc qui a comparé, donc dans la BVD, donc on a enlevé la bléomycine qui avait une toxicité pulmonaire, on l'a remplacé, bon l'adcétrice c'est le nom commercial du brentuximab vedotin, donc on a fait le AAVD et on a comparé les deux. Et en comparant les deux, donc on a eu une réduction du risque de progression et de décès de 32%, donc comparé par rapport à la BVD. La toxicité pulmonaire qui était plus fréquente, donc elle est devenue, on a moins de toxicité pulmonaire, donc on a moins de décès. Il y a eu moins d'hémopathies malignes qui ont été apportées par le AAVD versus ABVD. Et par contre, on a eu plus de neuropathie périphérique parce que le brentuximab vedotin donne une neuropathie périphérique et la vinblastine qui était anciennement dans la BVD donne aussi une neuropathie périphérique. Donc l'association des deux a un peu aggravé la neuropathie périphérique. Donc la deuxième étude, donc on a vu pour la BVD, et là on voulait améliorer le BACOP. Donc le BACOP, donc qui était très toxique aussi déjà par rapport à la BVD, donc a été amélioré par le BRICAD. Le BRICAD, c'est quoi? Donc c'est la bléomycine aussi qui a été remplacée par le brentuximab vedotin. Et le D, donc la procarbazine aussi qui était toxique, a été remplacée par la dacarbazine qui est un peu moins toxique. Et là, avec le BRICAD, donc on a eu donc meilleures réponses, donc des meilleures survies sans progression, 90,9% pour les BACOP et 94,3% pour le BRICAD, avec une différence qui est significative, mais il n'y avait pas de différence en termes de, il n'y avait pas de non-infériorité par rapport à la survie globale. Les lymphomes de Hodgkin réfractaires, on a vu les traitements de première ligne. Là, les réfractaires ou en rechute. Donc, différents traitements de rattrapage peuvent être utilisés. Donc, comme vous voyez en haut, donc les premiers, c'est la chimiothérapie, donc le AICE, le GVD, le DHAP. Et depuis l'introduction, comme vous voyez le BV, c'est l'immunothérapie, c'est le brentuximab vedotin, donc associé à la chimiothérapie. Donc, il a amélioré les réponses. Donc, on a jusqu'à 79% de réponses avec le BV DHAP. De même pour l'association des chimiothérapies avec l'immunothérapie. Donc, on a eu les meilleures réponses métaboliques, donc après avec PET scan, donc avec jusqu'à 95% de réponses métaboliques avec le pembro-GVD. Et on a pu amener, parce que le traitement de rattrapage, c'est pour essayer d'avoir une meilleure réponse et autogreffer les patients. Donc, on a pu amener facilement les patients à l'autogreffe après une ligne thérapeutique, parce qu'avant, pour arriver à l'autogreffe, on faisait 3 lignes, 4 lignes, 5 lignes, parce que l'autogreffe, il faut avoir la meilleure réponse possible. Donc là, avec l'immunothérapie, on arrive à avoir une meilleure réponse rapidement et autogreffer les patients. Et comme vous voyez là, avec le pembro-GVD, la PFS après autogreffe, elle est à 100% à 13,5 mois. Un petit mot, je vais vous donner le référentiel algérien dans le lymphome de Hodgkin pour le traitement. Dans les stades localisés favorables, donc on a fait deux attitudes, soit la non-disponibilité de la TEP, ou avec disponibilité de la TEP. Donc l'idéal, c'est de travailler avec de la TEP pour essayer d'avoir le moins de toxicité possible. Donc quand c'est un stade localisé favorable, on commence TEP initiale, on fait 2 ABVD. Si la TEP est négative, on continue par un ABVD et autogreffe. Et radiothérapie. Si la TEP elle est positive, là on escalade. Donc l'ABVD n'a pas été efficace, donc on escalade vers le BACOP, on fait 2 cures. Si la TEP elle est négative, on complète par la radiothérapie. Si elle est positive, là on passe au traitement de rattrapage. Pour les stades localisés qui sont défavorables, donc aussi on commence par l'ABVD. Bon, je vous donne juste l'attitude avec la TEP, donc l'idéal. Hein. Donc, 2 ABVD, si TEP négatif, on complète aussi par 2 ABVD et radiothérapie. Si la TEP elle est positive, on escalade 2 ABVD, TEP négatif, radiothérapie, sinon traitement de rattrapage. Pour les stades avancés, c'est un peu plus compliqué. Donc, il y a 2 attitudes. Donc, il y a ceux qui commencent par la BVD, ceux qui commencent par le BACOP. Donc, la différence, par exemple, si j'ai un sujet jeune, de Hodgkin, il y a beaucoup de sujets jeunes, 17 ans, 18 ans, donc qui n'est pas, c'est un stade étendu, vrai, mais c'est pas un bulky important et tout. Je me dis, je vais essayer de préserver la fertilité, moins de toxicité. Je commence par la BVD et je vais voir. Donc, l'idéal, 2 cures d'ABVD, je fais ma tête. Si elle est négative, je continue avec la BVD ou avec le AVD, c'est-à-dire l'immunothérapie et l'AVD. Si la TEP elle est positive, là, j'ai pas le choix, je suis obligée d'escalader, je pars vers le BACOP et je fais une TEP de fin de traitement. Si elle est négative, c'est une surveillance. Si elle est positive, on passe dans le traitement de rattrapage. Quelques mots sur les recommandations de l'ESMO 2025. Donc, dans les stades 1 et 2, donc soit c'est un stade favorable, donc ça, ils font 2 cycles d'ABVD et radiothérapie. Quand c'est un stade défavorable, localisé mais défavorable, donc les moins de 60 ans, donc on fait 4 cycles d'ABVD et radiothérapie. Sinon, BACOP, 2 cycles d'ABVD et là où ils font la PET, c'est pour la fin de traitement. Donc PET négatif, surveillance, PET positif, la radiothérapie. Pour les stades 2B et les stades étendus, donc moins de 60 ans, donc ils commencent par lubricade. Donc l'immunothérapie en première ligne avec c'est l'équivalent du BACOP avec l'immunothérapie et ils font le PET scanner. S'il est négatif, ils continuent avec 2 cycles de bricade. S'il est positif, ils complètent par 4 cycles de bricade et si c'est négatif, c'est la surveillance. Si c'est positif avec des stades qui sont un peu localisés, on fait la radiothérapie. Si c'est un sujet qui est âgé entre 60 ans et 80, donc là, on fait du niveau AVD, 6 cycles directement, c'est moins toxique, c'est l'immunothérapie avec l'AVD. Pour les rechutes, donc comme vous voulez, est-ce que c'est un patient qui est éligible à l'autogreffe ou non éligible à l'autogreffe? S'il est âgé, il n'est pas éligible à l'autogreffe, on fait du pembrolizumab, c'est l'immunothérapie. S'il est éligible à l'autogreffe, on fait un traitement de rattrapage. On peut faire la radiothérapie, elle peut se faire soit avant, soit après l'autogreffe. Et il y a même des indications quand il y a des rechutes post-autogreffe de faire des allogreffes. Et l'indication, c'est l'immunothérapie en maintenance post-autogreffe. En conclusion, donc le lymphome de Hodgkin est une hémopathie maligne qui est potentiellement curable, qui affecte l'adulte jeune. Les formes défavorables représentent plus de 80% des patients. Assurer un diagnostic précoce, c'est très important, c'est la formation médicale continue. Comme vous voyez en Algérie, on a des stades très étendus parce que les patients donc, ne consultent pas, parce qu'ils traînent pour faire des biopsies, pour faire des cytoponctions, ils sont mis sous corticoïdes, antibiotiques et ça retarde le diagnostic. Donc éviter la rechute par l'optimisation de la première ligne de thérapeutique. Le BACOP escaladé est le traitement le plus éradicateur, mais au prix d'une toxicité immédiate et retardée qui est significative. Le TEP scanner, il est incontournable et décisionnel dans le lymphome de Hodgkin et les stratégies TEP guidées pourraient permettre de limiter le nombre de cycles de BACOP escaladés pour les patients répondeurs précoces. Et l'introduction de l'immunothérapie en première ligne a amélioré l'efficacité et minisé les effets secondaires. Et je vous remercie pour votre écoute.
Thank you, Professor. Now moving on to our second speaker, response assessment in pediatric Hodgkin lymphoma, DS, or metabolic tumor volume, a question explored by Professor Egesta Lopchi.
Bismillahirrahmanirrahim. As-salatu salam ala Rasulullah. Assalamu alaikum wa ala ibadillahi salihin. Thank you very much. Et merci beaucoup pour l'excellente introduction to l'argument. Your talk was really excellent. And it's my pleasure to talk about the response assessment. You had an introduction, but when you want to assess something, it's always better to know what we're talking about. And one of the peculiarities of Hodgkin lymphoma is that the cancer cell is just a niche. It's actually surrounded by immune infiltrate. So when we look at Hodgkin lymphoma lesions, we're not looking at the cancer cells, but we're looking at the microenvironment. And therefore, this is essential to understand its uptake with FDG, which we know that it's related from the Warburg effect, not just to the highly proliferative, which is tumor, but also the immune infiltrate active. And what is the advantage of Hodgkin lymphoma with this regards compared to other lymphoma type, for instance, diffuse large B-cell, which also show a high uptake, is that the amount of cancer cell is completely different. And therefore, when we want to assess response, we have this amazing information thanks to the switch off of the metabolism, because after just 2 cycles, we have a prediction of what is going on at the end of the treatment. And as brilliantly said before, we can already after 2 cycles see whether the patient will respond or not. And this has been described in historical studies, which is the advantage over morphological imaging. We might have partial response on CT, but we have that switch off of the metabolism, which predicts the outcome. And this is even this is also an historical graph, but gives you the idea that not only compared to morphological imaging, but also to the predictors and the scores for the prediction of the outcome, FDG PET is superior in setting the line whether the patient will do good or not. And this has drawn the paradigm of response to Hodgkin lymphoma. This is a setup. We are all aware of the fact that for Hodgkin lymphoma, whether in adults but also in pediatric population, you have to do the first 2 cycles, you set a response, and this is what we give for granted. And this is thanks also to the enormous collaboration, international collaboration, and is the perfect example how things reach success. You find a simple score and you validate it not just among the nuclear medicine discipline, but with your peers, clinicians. And I would like to remember Professor Maignan, who we missed some years ago, may he rest in peace, because he gave an amazing example to the community how things should be done, because he put together the Deauville group, the first workshop, and after that the Deauville score became sort of the standard for the response assessment. Well, very simple indication. You looked at the background. This is something we do when we analyze PET immediately, naturally. We look at it and look whether there is a hotspot compared to the background, and you have these 3 references. And afterwards, the validation and the Lugano classification, which I still consider the best way to interpret PET-CT in lymphoma. There are other publications coming on, taking into account also the CT response, but this is, to my opinion, the most broadly accepted indication for response assessment. Very simple, you have an uptake below or similar to the liver, and that is a response to the treatment. But if we give this for granted, we must be aware of the fact that our eye is tricked by the background. We see here 2 different shades, but if we remove the background, we see that it's the same line, but depending on the background, we can either interpret it as positive or not positive. So therefore, in the pediatric population, there have been some struggle and some attempt to quantify the actual visualization that we have with our eyes into something more reproducible and not operator dependent. And this is because, as I said, the background influences. And if we look at the different cases and we give it to experts in the field to interpret, some can give 1, some can give 2, some can give 3. This is not a big deal if we're still below Deauville score 3, because anyhow the patient won't have any change into the interpretation and into the management. But when it comes to cases like this one, and you look what the 5 experts have written about the interpretation, you have 2 saying it's a response and 3 saying it's not a response. So if we want to switch the treatment, escalate or de-escalate, what is the perfect indication in this case? Or even in this other example, which for me is definitely a residual tumor, but someone gave it as 3. 3 out of 5 interpreted as a response. So therefore, the Aeronet C1, which was a huge, it was started in Germany, but it's a huge attempt to use and to validate the use of PET-CT and the stratification of the treatment according to the early response assessment. From the first IHP criteria used in the protocol came out with a precise quantification, the QPET. The QPET actually uses the uptake in the residuum and relates it to the liver. And therefore, you have some numbers which can be reproduced in any machinery you do it. You don't really need to have the specific image reader from Hermes. You can also do it in your own softwares where you analyze the PET data. And actually, by using this continuous value, because it's not discrete as the Deauville score, you can actually say that 0.95 is negative, and 1.3 can be considered positive, which is slightly above the uptake of the liver, which is exactly what we want to, as a quantification, to say that there is no response. And actually, they could also give the indication also for Deauville 5, which some groups say it's twice the uptake of the liver, some say it's 3 times the uptake of the liver. So this way, they give the precise indication of the uptake. But this is not all that we can offer with PET. So we have the advantages, we can quantify it with a QPET, but we don't look, I mean, the disease is not just 1 spot or 2 spots. Sometimes, especially when you have advanced stages, as seen here in Algeria, you need to give a sort of burden of the disease. And there have been a lot of studies, especially in the adult population, using metabolic tumor volume as a predictor of the response, and also to stratify the patient. But when you look at the data on Hodgkin lymphoma, they're a little bit limited. This is also because, as I said, there's a huge difference between how Hodgkin lymphoma behaves to treatment and how non-Hodgkin lymphoma behave to treatment. There's a sense in using SUV variation, using metabolic tumor volume in non-Hodgkin lymphoma, because there the amount of cancer cells is widely huge, and then even small variations can be a predictor of response. But with Hodgkin lymphoma, you either have on or off. This is very straightforward. But still we can have an advantage. Therefore, I've seen the literature in pediatric Hodgkin lymphoma, and there have been some studies, really interesting studies like this one already 7 years ago, where by computing the metabolic tumor volume and the total lesion glycolysis at baseline, so as an add-on to the stage, as an add-on to the predictive scores, you could say what was going on afterwards with the patient. Other groups more recently in the C1 study made the same analysis. They are both retrospective analysis, though this is the cohort is small, and this is the pitfall, major pitfall, because that retrospective analysis just proved that with specific way of computing metabolic tumor volume and total lesion glycolysis, you can predict the outcome. Moreover, they could say that at interim evaluation, so not just at baseline, but after the 2 cycles, the amount of tumor that you have there and the volume left is a predictor. Now, just note that we have 2 independent predictors, which is interim with the metabolic tumor volume with a threshold of 2.5, whereas TLG is with a threshold of 41%. So kind of schizophrenic. So either use one method to compute the volume or the other. So that's probably because it's a retrospective analysis. Also, the children oncology group made similar evaluation in their trials. So they made assessment on different threshold methods for the computation of the volume. Well, they came out with the 2 of a background as a reference, and also together with bulky and the response. These were 3 also rational factors that predicted the outcome of the patient. Moreover, they could also say that whether the patient was a rapid responder, the information given by the volume was an add-on. So it could also differentiate the outcome in those patients being rapidly responding. But still, this is a retrospective analysis. So here comes to the data that we have in our new trial, the C2 trial, which will be in few months published, the final results. Out of this trial, which you can see from the scheme, is designed to tailor the treatment based both interim but also late response assessment, and the patients are divided into 3 treatment levels. Of course, the first one is having the most light treatment. And as an Italian group for pediatric oncohematology, we designed a parallel prospective study specifically evaluating the add-on of the metabolic volume and semi-quantitative analysis together with radiomics and with the partial response, but this is not the aim of my talk here. And what we first did is, when you compute the volume, you first have to say which is the best method, because as I mentioned in the paper before, they either use the fixed cutoff for the SUV max and also the 41%. So you can choose either or, you cannot choose both of them and say they are independent predictors, because it's kind of no sense. And actually, the method that you use makes a huge impact on the volume. Of course, any of them is predictive, even if you use 41% and you underestimate the effective amount, because it's proportionate to the tumor, but it's not the more precise one to do. So therefore, the first thing that we did in our pediatric cohorts, a very specific prospective analysis, we analyzed the 4 more widely used methods to see which one is the best to use for this pediatric population. And we noticed that with exclusion of the 41%, which once again you can see the excluded one on the your left side is really underestimating the volume. The other 3 methods were overall similar. But what was the add-on is that with the fixed cutoff of 2.5, you had a better computation even for small volumes at early response assessment. So therefore, it was probably the most reliable and the more easily reproducible cutoff. So therefore, we analyzed our cohort. We use all the different parameters that I said, not just the volume, but also semi-quantitative parameters. And we also introduced the Dmax. What is the Dmax? It's the maximal distance between the 2 most hottest lesions on FDG. And this was demonstrated in non-Hodgkin lymphoma to be a sort of kind of independent predictor. It's very simple. And since we have to go for simple things, because simple things then get into practice, very cumbersome, complicated, they don't. So we introduced also this one in our analysis. We analyzed the first 300 patients, and you see the timing of the protocol at PET0, ERA-PET, and late response assessment. And we kind of proved was already supposed to happen, meaning that baseline evaluation could predict the early response of the patient. You can see here the semi-quantitative parameters, Dmax, and also the volumetric analysis predicting the response. And of these, we could identify those that were sort of independent predictors, but this is not what we're really aiming to. We wanted to see which of these parameters at baseline or that early response could predict the outcome, in this case, the event-free survival. And we noticed, interestingly, that at baseline, it was the volume which was predictive, not the uptake, because the uptake is pretty high, even if you have one single lesion. So that was not that robust in predicting, but the amount of volume was predictive, and we could set some cutoffs which could clearly differentiate the event-free survival. On the other hand, when we look at the early response assessment, it was no more the volume, because the treatment works pretty well. So the volumes, the residual volumes are really small. And so it's not the volume anymore which makes the difference, but it's the uptake of the residual tumor, which is quite rational. I mean, it gets straightforward as to the logic. And here again, we could predict. But one of the add-ons of the analysis is that the Dmax, both at baseline, so the distance between the two most hottest lesions, was predicted of the outcome both at baseline and early response assessment, which was something new, meaning that, of course, Deauville works very nice. I mean, we all did with Deauville. For the protocol, the QPAT helped us to make a very robust, reproducible evaluation of the response based, of course, on the sort of Deauville. It's a variation, a quantification of the Deauville. And we could add on also the volumetric and the Dmax as add-on for the analysis. And you can nicely see here that what makes the difference. You might have a smaller Dmax, I mean, a smaller distance, and in both cases you have some residue, but the patient on your left side is cured, the other one has relapsed, because both at baseline and early response you have this scattered, I mean, the residual disease is distant from the other. And this was proven also in multivariate analysis. So therefore, we merged together these parameters, clinical, because we had also the stage and the bulk volume as predictor. And we could see that by merging together, we gave a sort of risk stratification of the patient. At baseline with the clinical data and the metabolic data, and an early response assessment as well, you can nicely see how they predict different event-free survivals. So bringing us to the conclusion that there is room for adding the volume, for adding Dmax, and this is the first analysis in pediatric population that Dmax proves to be valid. And if you want to have an insight into what we have actually done, you have the publication, if you want to read it, which came out earlier this year. Therefore, when we want to build future trials, we must think of also introducing these parameters to stratify the patient, because it was done for Deauville score, which is the standard for interpretation. It doesn't mean that you go out of here and you neglect Deauville score. It works. You can also use QPAT to quantify if you're not certain whether there's a response or not on those gray shades of responses, but there is room for implementation of the treatment. And for this, I would like to thank all the international collaboration, especially the Italian group of oncohematology who helped build up this trial and bring the results together. And I would like to thank you for the kind attention.
Thank you, Professor. And now we will move on to the segment dedicated to the economic aspect of theranostics. We will begin with the lecture entitled New Perspective of Theranostics in Oncology, especially in middle-income countries, presented by Professor Giamaril, who will be on video conference.
Yes, thank you very much. I would like just to say a few words in French before starting. Je tiens à remercier chaleureusement les organisateurs pour cette invitation qui m'honore. Je regrette sincèrement ne pas être avec vous, surtout Alger, qui est une ville que j'adore, mais ce sera pour une prochaine fois. Donc, je vais chercher I will try to show my screen. One moment. The screen. One. And then this. Okay. I hope you see my screen correctly. After a short introduction, I will speak about the present and the future of theranostic, and essentially will have some word on the situation in low and middle income countries, and then some conclusions. I have no conflict of interest in this setting. So just a few words to remember that theranostic means the use of the same radiopharmaceutical but a different radionuclide for diagnosis and therapeutic targeting. And that the nice aphorism, we see what we treat and we treat what we see. For the diagnostic aspect, we have the chance of visualize and characterize and measure biological process like the previous very nice talk from Egesta showed, at molecular and cellular levels in human and other living systems. So for treatment, we use either alpha emitter with non-reparable double strand and DNA breaks, so very effective but also toxic, or beta emitter with longer range and single strand DNA breaks. What is important, I think, that we have to consider, especially in low and middle income country, is the requirement for theranostic clinical application. First of all, the nuclear medicine physician role. I think he should be expert in oncology. He should have interdisciplinary cooperation and in particular participate in tumor board. And he should be able to follow up the patient, not only for easy pathology like, for instance, thyroid cancer, but also for more difficult aspects like in neuroendocrine tumors. The second aspect is internal dosimetry. What means dosimetry? Means to calculate the activity to be administered in order to achieve the desired effective dose. So it's the key of course, personalized treatment and of course also of the modern nuclear medicine. However, if we look at external beam radiotherapy, the absorber dose to target can be precisely calculated. However, in contrary, for radiopharmaceutical therapy, the situation is much more complicated. And also, according to recent communication from physics, the tumor absorber dose cannot be really be calculated for many reasons. This is not the topic, but I think that if we want to start to do theranostic, we have to consider if to do or not to do dosimetry. The advantage of doing dosimetry is, of course, is the base of personalized medicine. There are also some legal requirements, especially in Europe, and I think that we need absolutely randomized trials. Why not to do? Because it's too cumbersome and not, for the moment, fully clinical validated, I would say. It is not indicated in the product characteristic, although there are legal requirements, and mainly big pharma is not interested. So this is a decision that every scientific society should take before considering this aspect. Let's look at the present. I would like just to mention here some key theranostic treatments that are now standard in high-income settings, but could be next frontier for implementation in low and middle-income countries. The first is the bone pain palliation with radium-223. The idea is to palliate patients with painful metastasis. And radium-223 is a calcium analog, so its uptake is essentially newly formed bone, and the alpha particle are able to irradiate adjacent tumor cell. The second is the neuroendocrine tumors. The target is somatostatin receptor, and for diagnosis we use gallium or copper, for treatment lutetium or yttrium. The technique is well known as peptide receptor radionuclide therapy, and it was the first theranostic implication that emerged about 10 years ago, more than 10 years ago. For prostate cancer, that is a little bit more recent, we target the transmembrane protein with a pharmaceutical that is PSMA that can be labeled with gallium in diagnosis and lutetium in treatment. This is really effective, and we can treat and see and treat, as this nice picture shows. Now we move in advanced theranostic. In nuclear medicine, we have the big advantage of have a combination of radiopharmaceutical that can be infinite. We can target practically all the aspects of the physio and pathologic field. You can use new radionuclides beside the classical lutetium or yttrium, like bismuth, lead, thorium, terbium, that there are many more. I like particularly terbium that is called the Swiss knife, not only because it was produced in Switzerland, but also because you can have in the same element, of course, with different isotopes, the possibility of doing alpha, beta, auger, SPECT, and PET. New treatment modalities, for instance, association of non-radionuclide treatment, like, for instance, external beam treatment, but also immunotherapy or chemotherapy, standard chemotherapy, or using our method, our radiopharmaceutical treatment at early stage. And this is really very important because, as it was shown before, the first treatment is the most important, not only for lymphoma. And then we have new diagnostic modalities like whole body PET-CT or PET-MR. I would also cite the artificial intelligence that could help us a lot, especially, I think, in the dosimetric cumbersome calculation. So the first idea of this new therapeutic modality came from prostate cancer. Normally, we treat the patient in metastatic stage, but the idea is to advance and also either treat the prostatectomy with lutetium, that is called lutectomy. This is a trial that is ongoing with good results for the moment. Another very important and impactful new modality is the target alpha therapy. Here again, I show you prostate cancer, but it's not only related to prostate cancer. With tandem therapy, actinium-lutetium, this could enhance the treatment efficacy while not affecting too much the toxicity, because pure alpha therapy in prostate cancer has shown to be very toxic for the patient. We have a new radiopharmaceutical that is the FAPI. In this case, we label the fibroblast activation protein inhibitor, and this can be labeled in diagnosis with gallium or FDG. And this product is called the new FDG. It's the new FDG because we can have images of good quality, also in cancer that were not suitable for FDG. So the cancer can be, for instance, the breast of the stomach, but it seems that at least early stages show that the therapy evaluation is better rather than with FDG. And mainly, we could have possible theranostic approach, because of course with FDG you can only have the diagnostic aspect, and the therapy you will do with the standard chemotherapy, like it was shown for lymphoma. You cannot label FDG with a therapeutic radionuclide. While with FAPI, we could replace gallium, for instance, with lutetium. So this is something that is interesting. And in 2021, I could read this article where Novartis, that is a big pharma, is very involved in theranostic nuclear medicine. has both a license, and the idea is to have therapy with lutetium and also bismuth. And now we move to the core of that is also the end of my talk. The core of my talk is the theranostic in low and middle income countries. And then we will see together what are the strengths, the weakness, the opportunities, and the threat. First of all, the key challenges for theranostic implementation in those countries are, first of all, the clinical and technical barriers. We know that we are limited access to dosimetry expertise, to equipment, that hindering the treatment personalization. We have also regulatory gaps and restriction on handling, storage, and disposal of radioactive waste. But I think the biggest technical barrier is represented to the high cost of radiopharmaceutical, especially those kind of radiopharmaceutical that are involved in the theranostic aspect. We move to structural and economical constraints. We have insufficient infrastructure for production and quality control, high development and licensing costs, slowing local innovation, again, and limited awareness and integration of theranostic with the broader medical community. So there is also a defect of communication. So what are the way forward? I think there are some strategic priorities. First of all, to develop regional networks for radiopharmaceutical production, dosimetry, and training to enhance self-sufficiency. And I think that Africa is a very good example of that, with some leading country. Algeria is one of them, South Africa also. So for both French or English-speaking countries, these are leading networks that can enhance the activity of the whole continent. The second is the harmonize and simplify the regulatory framework governing the radiopharmaceutical, radiation safety, and waste management. This is very important locally. Sometimes the regulatory frameworks are too cumbersome or too expensive to apply. We have also to encourage local manufacturing and technology transfer to reduce costs and improve access. This is also very important. This happened, for instance, in South Africa, and I think that Algeria has the capacity of doing this too. To integrate multidisciplinary collaboration among nuclear medicine, oncology, and medical physics professionals. This Congress is an example of that, and I think we should increase this kind of interdisciplinary collaboration and communication. We should embed theranostic within national cancer control strategies and public health policies, not to be something that comes from outside. It should be in your national cancer control strategy. Ensure reliable supply chains for therapeutic and diagnostic isotopes. This is fundamental, of course. Expand education and continuous professional development for physicians, physicists, and radiopharmacists, of course, and technologists. Establish sustainable financing and reimbursement models. This also is important in low and middle and essentially low-income countries where the patient financing is poor, and we have to find some fund to provide treatment for those patients. Reinforce infrastructure for dosimetry, quality assurance, and radioprotection that are always to be taken into account. And promote global and regional research partnership, ensuring strong participation for low and middle income countries. This is also another key aspect in order to move. And the example of the two presentations before, we have to participate in research. So in conclusion, theranostic is a paradigm shift for individualized, high effective cancer treatment. The implementation in low and middle income countries is not simple, although there is a rise in cancer burden, but limited access. So we have, it's a very important problem, strategic problem that should be addressed. We have strategic framework that matters. Beyond technology alone, we have to be inclusive, sustainable, and systemic. And the key enablers for success in low and middle income countries are the regulatory reform, clear, harmonized, approved, and safety pathway, reliable radiopharmaceutical production and supply chains, workforce education and continuous training, and sustainable financing and reimbursement models. Then, systemic priorities, strength infrastructure for dosimetry, quality control, and waste management, foster global and regional research collaboration with active low and middle income countries involvement, embed theranostic into national control plans and health financing policy. The role of international organizations such as IEA, WHO, is advocacy and awareness, technical assistance and capacity building, and research support. Theranostic should be treated as a global public good with coordinated, equity-focused effort. It can become a cornerstone of modern cancer care. Thank you very much for your attention.
Invitation to come to Algeria, but this has been one of the countries that I want to visit sometime during my lifetime. And
I will take this.
And it's been a pleasure to meet so many colleagues and see that PET is alive and is really going to make a major impact in healthcare. As the previous speakers have emphasized the importance of PET in general, but theranostics in particular. So this is just what I'm going to discuss during my presentation. Of course, my talk is going to be complementary to, especially the last speaker who talked about really and just getting all the aspects of PET available to training people, getting the government, insurance companies to become aware of the importance of PET. Having been involved in daily PET as long as anyone, I have gone through all these phases in my own institution and in my own country in the United States. So this is a very tough area for us to deal with. Everybody likes CT, MRI because it looked very familiar. They had learned in the medical school how to body looks and under the anatomy table. But for us to show these fuzzy images with PET and convince our colleagues that this is really a true representation of what's going on in the body was a tough journey. And I'm going to share that with you. And of course, I'm going to emphasize also education. This is a very important part that really I would like to just help them in any way I can to get going in Algeria. So, as I said, it's just been a tough challenge for all of us who have been pioneers in this area and try to establish PET as an acceptable and effective modality in day-to-day practice of medicine. We introduce, of course, FDG, as I will discuss during my second talk. In 1976, I gave the first FDG to human being, but insurance companies and in the government agencies, they just refused to pay for it, while CT was paid for in my own institution because also first CT in the world come to Penn.
Presentation.
Is what that?
Yes. So, can someone help us here?
So, just going to continue until we fix this visual part of my presentation. Yeah, we introduced FTG in 76. I did the first human study in 76, and our insurance companies did not pay for it until 2000. So it took 24 years after we gave the first dose while they were paying for CT within 3 months, MRI within 6 months. So it has been a tough journey for even those of us who have been pioneers in this field to be able to convince the community that this is a viable option, and it's just going to, is it working now?
Excuse me for disturbing you, sir. Just, yeah.
Well, hopefully, but so it's something that, of course, I'm going to not too much talk about economy, but also I'm going to discuss the importance of training people for the future. You know, if you want to build any program, you invest in people, not buildings, not machines. This is really what, if you get the right people to do the right job, everything is going to happen. So one of the things that I'd like to see happen in Algeria is establishing training programs that are going to really make new generation of physicians and scientists. Not only physicians, but also scientists. We got to get a lot of physicists, chemists, pharmacists to get involved in order to have a successful PET program in any country, and definitely developing countries need it as much and more than developed countries. So that's really going to be, very essential, and I'm going to emphasize that, having, just contact with medical students, residents in specialties like radiology who are dealing with imaging. So we got to just get these people involved. I don't know what we're going to do with the slides. Hopefully it will have the slides in front of my eyes here, but I cannot see it on the screen. So I don't know if that, I don't know, I didn't do anything wrong. I mean, I just, well, so maybe just, I'll just talk about, without you seeing my slides, but therefore it's essential to educate medical providers around the world about the impact of PET-based diagnosis and intervention in reducing healthcare costs in many disciplines. This is really what we have shown, that this is what we call in America cost-effective. So you don't add another cost to medicine. When you have a patient who has got a nodule in the lung and you do a FTG scan, which in America costs about $1,000. This may be high for Algerians, but in America, $1,000 is not a big deal. So you stop doing surgery on a patient that's got lung nodule because CT scan cannot tell the difference between what is cancer and what is not. So by doing a PET scan, we have been able to have a negative PET scan and tell the patient, go and celebrate that you don't have cancer. And also in my institution, if we had to do surgery and a patient has got lung nodule and you take him to the operating room, the cost of operation is going to be about $150,000. So these patients not only, of course, cause less cost to the healthcare system, but also enjoy their life. When you have surgery for lung nodule, it takes you 6 months to recover from it. So in America, anybody that's got a lung nodule gets a PET scan. If it is negative, we tell them go and celebrate. If of course cancer, you definitely take the surgery and do what you do. So we have made an enormous impact on healthcare, but patient care, as well as cost to the society. So what if still?
So you try to fix that.
Okay, looks like a system pays up as we have done with PET. For the past 50 years, actually, we are celebrating the 5 decades of impact of PET on healthcare. This is it. In 2016, I edited this PET Clinics, which is a major review journal. So next, the 4 issues of my PET Clinics going to be on FDG because of its impact on healthcare system. So we just, this is exactly what I'm doing, just talking to the people around the world to show the impact of PET in diagnosis and intervention. Okay, because of its complexity, introducing theranostic to developing countries is going to be even tougher. I just talked about FDG, which was only diagnostic test. But when you're talking about theranostics, you're talking about much more complex entity, as you have heard, of course, by previous speakers. So this is even face much more tougher battle in a country like Algeria or other developing countries. And that's really why we have to do our best as international community, those of us who have had more experience, to help you to really get this started in a country like Algeria. International, currently IAEA suggests some helpful strategies that's in their website, and I'll just show you to establish, of course, function in PET. First, you have to start PET centers. And I'm actually shocked. A country of your size, 45 million people, has only 2 PET centers. In the Philadelphia area, we have about 20 PET machines. Just a city that's no more than 1.5 million people. And even that's not enough. We used to do only 1 or 2 PET studies in the 70s. Now we are doing 80 PET scans every day. So this is just part of practice of medicine, and we just have to do our best to establish, first of all, PET centers. That's going to lead to theranostics. And this is this is what International Energy Commission says: secure funding through government agencies, non-government organizations, or private investors. In many countries, I've talked to ministries of health to just tell them that this is a must, is not going to be additional cost to the society. It's going to save costs. So that's very important part. Collaborate with local healthcare providers and institutions for support. It's just, you have to constantly sell your great modality that you have to your colleagues, to the administrators in your institution. Of course, medical personnel has to be paid. You invest in people. If you want to build up a program, first you invest in people, not in buildings, not in machines. So this is going to be your big task in building the future for applications of PET in your country. Of course, we have to just, was again referred to by previous speakers, we have to be abiding. Unfortunately, the activity makes people nervous, and we have to just make sure that everybody understands that we are very careful about safety of these procedures. But definitely when it comes to theranostics, is much, much more serious to know about safety issues and make sure that machines are functioning well, and so that you're doing a decent job of using these technologies. So you have to have an operational system that is functional, and for the centers that are establishing this technology. You have to just assess the local healthcare system needs and demands for PET imaging service. And in order to establish a functioning PET center and definitely theranostics in the developing country, every effort has to be made that that tested and proven successful in the advanced countries. So even, for us in the United States and definitely at a major institution like University of Pennsylvania, we just had struggled during the past 50 years. Even today, we are not looked at the same way they look at CT and MRI. So we just have to do our best, never give up, never give in. This is really the advice that I talk to my students, and this is a very important part of just making sure that something that you believe in, you can convert to. If there was a good religion, PET is the best religion to convert the medicine to apply. Because education of medical students is very important. I've given a lot of talks to our medical students, and we do that every year. And especially in the third or fourth year, we have 4 years of education in the United States. And when they get into the clinical applications of medicine, after they've had basic scientists, they invite us. So that's very much like the radiologists. We give talks to our medical students. So you build up some base from the School of Medicine to make sure that these colleagues are realizing that PET is not going away. And in fact, in my view, PET is the most powerful modality in medicine. And as we have learned over the years, not only as clinical tool, but a better understanding on basic physiology, basic molecular aspects of the disease. All the drug companies in the world now are using PET to develop new drugs. In my neighborhood, the SmithKline has a basis around Philadelphia. They've got 10 PET machines. So all the drugs are developed by PET, not by just chemicals given to animals and then trying to where they are going by taking a piece of liver or lung and finding out where the drug is. So they just label the drug and see the dynamics of the drugs in the PET machine over 2-3 hours. And that has led to developing drugs much faster than any other technique. Now, also, we have to make sure that we educate our trainees. They've been the diagnostic radiologists are the people that clinicians trust, and therefore we have to train a lot of radiologists. We just don't have the resources to have our own independence to deal with the clinicians. So everybody deals through the department of radiology. So it's essential for us to educate our radiology residents and even other radiation oncologists are using this technique. We have actually 2 PET machines in our radiation oncology service. They won't treat anybody without having a PET scan to know exactly where the tumor is, other than just any opacity on the CT scan is radiated that may not be cancer. So it's very important that we train radiation oncologists. Of course, medical oncologists, even, of course, cardiologists are very, very important because this is a very rapidly evolving application in cardiology and, of course, orthopedics, neurology, and rheumatology. Just make every effort to attend specialty conferences. These are definitely oncology, but even other specialties that they meet and just describe the importance of PET in their practice. We have to attract the talented students, have potential to really master this complex specialty, definitely in physics, chemistry, mathematics, and modern biological disciplines that are applicable to practice of medicine. Your technical staff has to be educated, especially when you're talking about theranostics. This is going to be a very essential part that your technicians know what to do, because any contamination, as was pointed out, regulatory issues in every country is just paying a lot of attention to safety of what we do in both diagnostic, but particularly theranostics. If we contaminate a building, you have to stop, just completely evacuate the building. So you got to educate your technologists to make sure that they know the rules and follow them. And of course, both instrumentation and software is very essential that are taught to technical staff. You have to have very frequent meetings with your technical staff to make sure that they really understand. You have to update it every few years, you have to update your procedure manual, and this is going to be essential for just both safety as well as generating images that are of high quality. The requirements of Human Research Committee, of course, we have it probably more stricter human, we call it institutional review board, of course, radiation safety, than probably most countries in the world. But even in developing countries, they have, of course, rules about, especially doing research, that you have to deal with these research committees and just make sure that they are aware of safety of what we're doing. And that's going to be very important for you to also to follow. Regulations that deal with radiation safety, as I said, is a very, very important part of both diagnostic and theranostic applications for both research and clinical applications. And these are going to be even much more complicated for theranostic applications. Try to convince, of course, private and government insurance companies. Of course, in America, private insurance is the largest insurance. And then we don't get paid for government until you retire at the age of 65. So in America, we deal with private insurance companies and convince them to pay for these studies. But in countries like Algeria, where healthcare is primarily given by the government, it's very essential that you, again, meet with them and try to tell them that this is a must. This is going to cut costs for healthcare rather than added costs. So it's very essential that you deal with the Ministry of Health, you deal with other agencies that are in the same category and convince them that this is really essential for modern practice of medicine. So my conclusions are very clear. Developing countries has to take advantage of the experience that we in America, Europeans, have gained over the years about establishing functioning centers in the developing countries. These challenges are more relevant to implementing theranostic facilities, more so than diagnostic applications of PET. So never give up, never give in when you know that you're on the right track and will win in the long run. I mean, this is really advice that I will give to colleagues in Algeria and other colleagues who are attending this meeting from other countries, that this has been an incredibly challenging path for me, but I'm happy to see today that now we're going up like this. And I think this is the fastest growing area in medicine, and the potential is enormous. Of course, this SNMI has also some guidelines that they can just easily access through the internet, and that would be another source of information that you need to really just look at. And I want to thank you again for inviting me.
Thank you so much, Professor. And now we will welcome our next speaker, Professor Shi, to present his presentation. How can theranostics become more effective?
So thank you for introduction. It's a great honor to be here to share our experience from China. Yeah, although China is far away from here, probably that's more than 10,000 kilometers. But I think everyone just thinking about and what we are doing about the nuclear medicine almost the same. So I would like to introduce something. I would like to share our opinions about the theranostics. So firstly, I would like to introduce our hospital briefly. Our hospital is one of the biggest hospital of Fudan University, was founded in 1937, and it is the first large hospital established and run by Chinese people. And right now, it's the one of the first national medical center in China. So how about our department? Our department is one of the biggest department of nuclear medicine in China. Our department covered more than 5,800 meters squares. And we have 4 centers. One is the PET molecular imaging center. We have 4 PET CT scanner and 1 PET MRI. Every day, we have more than 120 patients for PET examinations. And we also have the single photon functional imaging center. We have 3 SPECT CT, 1 SPECT, and 2 dedicated gamma camera. And every day, we have more than 70 patients for the examinations. And also, we have 9 therapy beds. We call it radionuclide therapy centers. Every year, we treated more than 500 patients with differentiated thyroid carcinoma patient using the radioiodine. And we also have the molecular probe research centers. We have 20 MeV cyclotron, and we also have the 10 hot cells. So we can produce some of the new tracers by ourselves, and we can use it on site. So that's the advantages of Chinese policies. So we can do a lot of clinical research works. So talking about the theranostics, all the nuclear medicines is proud of that. So everyone wanted to do it better and wanted to let the patient get more benefit from this therapy method. But firstly, we should know how about our capabilities, what we can do it right now. So we all know that just after the VISION clinical trial, the FDA approved that the lutetium plasma used in clinical works. So we just analyzed those data in detail. We found that if we just, according to that the criteria, we just let the patient evaluate the patient if that the lesion uptake plasma is higher than the liver, that patient should be enrolled. So for this kind of the study, we can find that in this group of the patient that the plasma response that more than 50 declined, that's only 50%. But for any plasma declines, that's the 71%. So if another group of patients is that they really not enrolled, is not qualified enrolled for this study, but this patient really accept the lutetium therapy. In this group, there are more than 20% have the good response. That means that more than 50% plasma declined, and almost 41% got the any plasma declines. That means that if the patient accept that the plasma therapy, about 30% could not get the benefit. So if the patient really use it, if it's not qualified for that, but about 20% can get a good response. That means that some of the patients lost the opportunity to accept this kind of the therapy, but some of the patients really not get the benefit. Anyway, if they cannot get the benefit, they have to suffer from the side effect. So that means that they pay a lot of the money, get so many side effects. How can we do it better? So that the therapy that the clinical trial gave us the answer. So they changed that the criteria, that the enrolled criteria. So they just at the beginning in the VISION clinical trial, they just let the patient that the lesions that uptake that the radiotracers and more than the liver. But here they asked that the plasma that the lesion plasma accumulated that the SUV max should be more than 20, and all of those lesions that should be more than 10. At the same time, all the patients accepted that FDG PET scan and evaluated the patient with that the plasma PET and the FDG PET together. They just exclude some of the lesions have the FDG positive, but the plasma negative. So according to these criteria, some of the patients will exclude, could not accept this kind of the therapy. But anyway, that the result is so exciting. So when we use that the therapy clinical trial, in this therapy clinical trial, so there are more than that's the 66% patient got the plasma 50% response, compared with that the that the vision clinical trial, that's only 46%. But also at the same time, we can find that for the vision clinical trial, that the side effect, that's the 52.7%. But in the therapy clinical trial, that's only 33%. So more patients get the benefit, and also at the same time, the side effect decrease a lot of. So that means that if we use that the multi-tracer evaluate, we can let more patients get a benefit from it. So we always talking about that theranostics see what we treat and treat what we see. But firstly, we should think, yes, we can see. Then we should ask ourselves, we really see all of the things in it? That's a very important thing. So at here, that's just the baseline. And the first therapy, we got this imaging. And the third cycle got this imaging. It seems that most of the lesions became small and some of them disappeared. It's true? Most of the people will give the answer, probably. Why that's the probably? We can see it. This imaging that our team works. So because of that, we have the total body PET. So we do a lot of the dual tracer imagings. We inject the patient with half dose or that's the 1/3 dose or 1/10 dose. So we just to evaluate how about the different radio tracers distributed in the tumor and in the human body. So we want to get more information about the tumor bioactivities. So this patient, we can see that the tumors have the FDG uptake, no FDG uptake here. But some of the tumors have the FDG, have the PSMA uptake, and also FDG uptake. Some of them, that's not PSMA uptake, but higher FDG uptake. But some of the lesions, no PSMA uptake, and no FDG uptake. So just thinking about this imaging, and then we review that this imaging. So probably, the answer probably, I think that's scientific. So if we just want to say that the patient really got the benefit, probably that the PSA decreased is another, that's the data. But at the same time, multi-tracer, that should be more helpful. So not only that for that the PSMA, but for other kinds of the therapy methods, almost the same. For example, this is the patient suffered from that's the lung adenocarcinomas and the gastric adenocarcinomas. So we have found that so many lesions. Firstly, FDG show that so many lesions have high uptake radio tracers here. But then we performed that the FAPI, and we can find that very limited lesions have that the FAPI uptake here. If we have no that the FDG imaging, we just according to this, probably we got the different answers. So how can we do it? How can we select it? So we should thinking more and do more as we can do. So the first answer is that in order to get the good therapy response, dual or multi-tracer PET imaging evaluation before that the therapy would be effective. Probably everyone will think that if we do multi-radio tracer PET, it will let the patient pay more. Yes, that pay more, you can get more. Otherwise, you have the risk get nothing except for the side effect. So sometimes, for some case, have some that the different the therapy response. So this is the patient suffered from the prostate cancer, just enrolled for that clinical trial in our department. So that's the PSMA PET imaging. We can find that so many metastatic lesions in the bone. So and then this patient enrolled the clinical trial. And this patient finished that 4th cycle, that the lutetium PSMA therapy. And this is the imaging that the lutetium distribution in the human body. We can find that almost all those lesions have accumulated that the lutetium here. But just during this time, we can find that we really finish a series of the bone scan. So this is the baseline, but with the time, so many new metastatic lesions appeared at here and at here. So with time, there are so many. That means that for this patient, probably that the lutetium is effective, but it's not so strong. So many new metastatic lesions appears. That means that for this kind of the therapy, we just using it, this one, or we combined with other method. So MDT, that's very important. So in our center, except for that the clinical trial, we will combine with another kind of the therapy method, probably with that the chemotherapy or target therapy or that's the immunotherapy, just according to that the PSMA PET imaging and FDG imaging. And then we discussing with the different that the urologist and oncologist. So after we use that the lutetium therapy, so with the time, there are more and more that the solid data demonstrate that the side effect, especially that for that the kidney function. So that means that we always use that 20 millicurie for one patient. Is good enough? Is overused or is not good enough? So we have no answer. So calculated dosimetry is really good, but it really has so many challenges. Another thing is that the side effect is that on the salivary gland functions. So we really did some experience. We just let the patient oral vitamin C, and during that the gallium labeled PSMA PET acquisition. So with time, it's really accumulated less compared with that without interference. So sometimes we can do it, but if the patient really accepts that the lutetium therapy is really effective, we really don't know, because that we just do it during that the PET imaging acquisitions. So we should think more about the side effect, not only pay special attention for the benefit for the patient. So the second thing is that the theranostic radiopharmaceuticals should be more specific, and the personalized dose and the normal organs or tissues protection should be emphasized. So for the PET-CT and that the radiopharmaceutical for that the theranostic, all is expensive. Can we find some that the low price method to evaluate? We have a clinical trial. I would like to show you a case. So this is a patient suffered from that the poorly differentiated adenocarcinoma of the gastric, and also have the peritoneal metastasis. So this is the FDG PET imaging, and this is the FAPI PET imaging. We can see that the lesions here, and this is the metastatic lesions of the FAPI PET imaging. And here we can compare with that the FDG and the FAPI. We can find all those lesions have slightly that the radiotracers uptake. Anyway, using that the FDG or FAPI, we could find it. So that's really expensive. So and the PET scanners is not available at everywhere. So how about the technetium labeled FAPI? This is the one of the clinical trial we are ongoing right now. So we can see that the small metastatic lesions, and it's really have that the accumulator of the radiotracers here. And this is another, that's the metastatic lesions. And also, this is that the gastric wall lesions, original lesions, and also have the metastasis, have that the radiotracer uptake. And this is the small metastatic lesions. Just compared with that the PET imaging, we can get almost the same result. So If we can do it in the clinical in the future, I think more of the patient who could use this kind of the method to evaluate. But how about the therapy? This is another IIT study in China. We can find that this is the FAPI, that's the gallium labeled FAPI, and this is the technetium labeled. This really have the difference. And then the patient accept that the lutetium FAPI, that D7 and D. And we also can find that the radio tracers accumulate in it. So that means that in the future, if we can evaluate using that the technetium, it is easy to available, and probably most of the nuclear medicine service center could get it. So the other answer is that the lower cost of the radiopharmaceutical, that like more patients get benefit from theranostics. So finally, I would say thank you all of you, and especially I would say that I would appreciate all you support during my visa application. It's really so complicated for me and, during my visiting here. And I always think that one world, one nuclear medicine. We work together, we will let the nuclear medicine become better and better. So thank you for your attention, and welcome to Shanghai. Thank you.
بسم الله الرحمن الرحيم، والصلاة والسلام على رسول الله. السيد الأمين العام لوزارة الصحة، السيد رئيس الديوان لوزارة الصحة، السيدة المديرة العامة ممثلة وزير الطاقة والطاقات المتجددة، السيد ممثل وزير العمل والتشغيل والضمان الاجتماعي، السيد رئيس الوكالة الوطنية للأمن الصحي، السيد رئيس السلطة الوطنية للأمن والأمان النوويين، السيد محافظ الطاقة الذرية، السيدات والسادة رؤساء الجمعيات العلمية، السيدات والسادة أسرة المنظومة الصحية والأسرة الإعلامية، السيدات والسادة الحضور كل باسمه ومقامه، السلام عليكم ورحمة الله تعالى وبركاته. بفخر عارم وشيء من الارتياح تشرف الجمعية الجزائرية للطب النووي في تنظيم الطبعة الثانية للمؤتمر الدولي للطب النووي للجزائر بالشراكة مع محافظة الطاقة الذرية والوكالة الدولية للطاقة الذرية ودعم مركز البحث النووي الجزائر. إن الطب النووي تخصص عريق في الجزائر وليس مستحدثا عن الإطلاق، وتاريخه يضرب بجذوره في فترة مبكرة جدا بعد الاستقلال بفضل جهود رواد أمثال الأستاذ مولاي بالميلود رحمه الله. كان له الفضل في إرساء أولى تطبيقات استخدام الأشعة النووية في المجال الطبي على غرار اليود المشع 131 راديو أيودين ثيرابي بالجزائر عام 1966، أي 4 سنوات فقط بعد الاستقلال. هذه الريادة تثبت أن الجزائر كانت سباقة في تبني التكنولوجيا المتقدمة لعلاج مواطنيها، وأن الاستراتيجية المنتهجة من طرف السلطات العليا للبلاد وعلى رأسها السيد رئيس الجمهورية عبد المجيد تبون لبناء وتطوير هذا الاختصاص هي استمرار لهذا الإرث العظيم. سيتم تخصيص هذين اليومين لتقديم ورشات عمل تطبيقية وعملية في مجال التكوين المتواصل حول أمراض القلب والأوعية في الطب النووي، وقد خصصت دورة تدريبية متخصصة في قراءة وتفسير تشخيصات البيت سيتي. هذا استثمار مباشر في رفع كفاءات أطبائنا. وأيضا محاضرات علمية من طرف محاضرين دوليين ومحليين لإبراز مكانة والدور المتطور للعلاج التشخيصي النووي ثيرانوستيك، خاصة في أمراض السرطان وتأثيره على اقتصاديات الرعاية الصحية، حيث يجسد العلاج التشخيصي النووي ثيرانوستيك جوهر الطب الدقيق من خلال الجمع بين التشخيص والعلاج في آن واحد، ويفتح آفاقا جديدة في التكفل بمرضى السرطان. سيكون هذا المؤتمر لاستكشاف أحدث تطورات، سواء كانت نظائر جديدة أو تقنيات توصيل مستهدفة أو استراتيجيات لجعل هذه العلاجات متاحة على نطاق واسع. إن الطبعة الأولى للمؤتمر الدولي للطب النووي آيكون 24 كانت نجاحا مدويا، وذلك بفضل التزام الجميع، شركائنا المؤسساتيين، زملائنا من محافظة الطاقة الذرية والوكالة الدولية للطاقة الذرية، وقبل كل شيء أنتم أيها المشاركون الأعزاء. إن كانت الطبعة الأولى هي الوعد، فإن الطبعة الثانية هي تأكيد طموحنا. في هذه السنة لن نكتفي بتكرار هذا النجاح، نحن نحاول الابتكار ونوسع آفاقنا ونقدم ركائز أساسية توجه أعمالنا إن شاء الله. يشرفني أيضا أن أعلمكم بحضور أبرز القامات العلمية والعالمية في الطب النووي في هذا المؤتمر. هذا الحضور يعكس مدى اهتمام الأسرة العلمية بهذا التخصص في بلدنا، لكونه يمتلك جميع الإمكانيات المادية والبشرية والتقنية لتكون الجزائر رائدة على المستوى الإقليمي والعالمي. إن رعاية هذه التظاهرة العلمية من طرف وزير الصحة ووزير الطاقة والطاقات المتجددة من شأنها إرساء الطابع المؤسساتي وترسيخ الدبلوماسية الصحية، والتي تعد من أهم أهداف مؤتمرنا. أود أن أعرب عن جزيل الشكر للسيد وزير الصحة ووزير الطاقة والطاقات المتجددة لرعايتهما هذا المؤتمر، دون أن أنسى جميع المنظمين من الجمعية الجزائرية للطب النووي، محافظة الطاقة الذرية، ومركز البحث النووي الجزائر، وأصدقاؤنا الخبراء الذين جعلوا هذا الحدث ممكن. أشكر كل واحد منكم القادم من بعيد أو من قريب في التزامكم بتطوير اختصاصنا. وشكرا، المجد والخلود لشهدائنا الأبرار. أتيح الكلمة إلى السيدة رئيسة المؤتمر أستاذة عميمور آسيا فتتشرف.
بسم الله الرحمن الرحيم. سيد الأمين العام لوزارة الصحة، سيد رئيس الديوان لوزارة الصحة، السيدة المديرة ممثلة وزير الطاقة والطاقات الطاقات المتجددة، سيد ممثل وزير العمل والتشغيل والضمان الاجتماعي، سيد رئيس اللجنة الوطنية للأمن الصحي، سيد رئيس السلطة الوطنية للأمن والأمان النووي، سيد محافظ الطاقة الذرية، سيدة والسيد ممثلة الوكالة الدولية للطاقة النووية، الأساتذة الأفاضل، كل باسمه ومقامه، ضيوفنا الأعزاء، السلام عليكم ورحمة الله تعالى وبركاته. يشرفني ويسعدني بصفتي رئيسة المؤتمر الدولي الثاني للطب النووي أن أرحب بكم جميعا في هذا الحدث العلمي المميز الذي تنظمه الجمعية الجزائرية للطب النووي تحت الرعاية السامية لكل من معالي وزير الصحة ومعالي وزير الطاقة والطاقات المتجددة، وبدعم من الوكالة الدولية للطاقة الذرية وبالتعاون مع محافظة الطاقة الذرية. يتميز هذا المؤتمر ببرنامج علمي متنوع وثري يبدأ في يومه الأول بورشات تطبيقية في طب القلب وتحليل وتفسير صور التصوير المقطعي بالإصدار البوسيتروني لوبيت سيتي الذي يعد من أحدث محاور الطب النووي في التشخيص والعلاج في آن واحد. أما اليوم التالي فسيخصص لموضوع التيرانوستيك مع التطرق إلى أبعاده الاقتصادية وتطبيقاته السريرية الحديثة. كما سنتناول الجلسات اللاحقة قضايا الحماية من الإشعاع، وفي الأخير الابتكارات التقنية في ميدان الطب النووي. ومن الجوانب التي نعتز بها هذا العام أن أغلب المداخلات ستكون باللغة الإنجليزية، بما في ذلك العروض المقدمة من طرف الأطباء المقيمين الجزائريين الشباب، وذلك تماشيا مع التوجه الاستراتيجي الجديد الذي أطلقه فخامة رئيس الجمهورية من خلال وزارة التعليم العالي والبحث العلمي لجعل اللغة الإنجليزية لغة البحث والعلم في الجزائر. ويشرفنا أيضا أن نحضن هذا المؤتمر بتكريم روح المرحومة السيدة بنكي دادغا، الإطارة السابقة بوزارة الصحة التي قدمت الكثير لتطوير مجال الأدوية الإشعاعية في الجزائر. كما يسعدنا أن نواصل هذا العام التقليد الذي أرسي في الطبقة السابقة، وذلك من خلال تقديم جائزة دكتور سيباي تمنح لأفضل مداخلة يقدمها الأطباء المقيمون في الطب النووي، تشجيعا لهم على التمييز العلمي ومواصلة مسيرة الإبداع والعطاء في هذا التخصص النبيل. وفي الختام أتوجه بجزيل الشكر إلى جميع من ساهم في إنجاح هذا الحدث من منظمين ومحاضرين وشركاء وطنيون ودوليين وممثلي مؤسساتنا الوطنية، وعلى رأسها وزارة الصحة ووزارة الطاقة والطاقات المتجددة ومحافظة الطاقة الذرية والوكالة الدولية للطاقة الذرية. كما أتقدم بخالص عبارات التقدير إلى ضيوفنا الكرام الذين شرفونا بحضورهم من الأردن والعراق وإيران والصين وفرنسا وبلجيكا والولايات المتحدة الأمريكية وإيطاليا وسويسرا وألمانيا وجنوب إفريقيا، وإلى ممثلي الوكالة الدولية للطاقة الذرية على دعمهم وتعاونهم المستمر. كما لا يفوتني أن أخص بالشكر الرعاة والداعمين الذين ساهموا في تنظيم هذا المؤتمر، وبدون دعمهم الكريم لما تحقق هذا المستوى المتميز من النجاح. وأتمنى أن تكون هذه الأعمال مثمرة وأن تفتح آفاقا جديدة لتطوير هذا التخصص خدمة للمرضى وتعزيزا للبحث العلمي ورفعة لوطننا العزيز. والسلام عليكم ورحمة الله تعالى وبركاته.
سوف يقدم نائب المدير العام للوكالة الدولية للطاقة الذرية كلمته.
Honorable Minister, Excellencies, distinguished delegates, ladies and gentlemen, I'm honored to address you today at the opening of Algiers International Conference on Nuclear Medicine 2025. I'd like to convey the deep appreciation of the International Atomic Energy Agency to the government of Algeria, Algerian Atomic Energy Commission, and the Algerian Association of Nuclear Medicine for organizing this important event. We meet today united for the shared conviction that the peaceful application of nuclear science and technology can serve humanity by improving health and saving life. Ladies and gentlemen, since it was established in 1957, IAEA has been the global platform cooperating
الوزير الدكتور عجال مراد، والذي تعذر عليه الحضور لارتباطات مهنية مسبقة، يشرفني أن ألقي على مسامعكم الكلمة الافتتاحية للسيد وزير الطاقة والطاقات المجددة بمناسبة افتتاح المؤتمر الدولي الثاني للطب النووي بالجزائر لسنة 2025. السيد الأمين العام لوزارة الصحة، السيد رئيس الوكالة الوطنية للأمن الصحي، السيد رئيس اللجنة الوطنية لوقاية ومكافحة السرطان، السيد رئيس السلطة الوطنية للأمان والأمن النوويين، السيد محافظ الطاقة الذرية، السيد رئيس الجمعية الجزائرية للطب النووي، السيدة ممثلة الوكالة الدولية للطاقة الذرية السيدة سلافة كرار، مسؤولة إدارة برامج التعاون التقني للوكالة مع الجزائر، السيد ممثل وزارة العمل، السيدات والسادة الأساتذة والخبراء وممثلو الهيئات الوطنية والدولية المختلفة المشاركة في هذا المؤتمر، أسرة الصحافة، السيدات والسادة الحضور. يسعدني أن أكون بينكم للإشراف على الافتتاح الرسمي للمؤتمر الدولي الثاني للطب النووي بالجزائر 2025، المنظم بالشراكة بين محافظة الطاقة الذرية والجمعية الجزائرية للطب النووي. وأود أولا وقبل كل شيء أن أرحب بكم وبكل ضيوفنا الحاضرين هنا، وأغتنم هذه الفرصة لأوجه جزيل الشكر إلى المنظمين الذين عملوا على التحضير لهذا المؤتمر، الذي يؤكد مرة أخرى على حيوية مجتمعنا العلمي ورغبة بلدنا في وضع التكنولوجيا والعلوم في صميم التقدم الطبي، حيث أود بهذه المناسبة أن أحيي هذه المبادرة وأشارككم رؤيتنا الاستراتيجية الداعمة للتنمية المستدامة للطب النووي في الجزائر. السيدات والسادة الحضور، ينعقد هذا المؤتمر في فترة تولي فيها الحكومة الجزائرية اهتماما كبيرا لمكافحة السرطان واستخدام الطب النووي في هذا المجال، وذلك تطبيقا لتعليمات رئيس الجمهورية السيد عبد المجيد تبون لتوجيه الاستثمارات في مجال الطاقة النووية نحو الاستخدام الطبي، لا سيما العلاج الإشعاعي للمرضى الذين يعانون من السرطان أو أمراض أخرى تتطلب استخدام هذه التكنولوجيا. وفي ضوء التطورات العلمية والتكنولوجية في هذا المجال، يعمل قطاع الطاقة من خلال محافظة الطاقة الذرية على تعزيز الكفاءات البشرية والتقنية من خلال تكوين متخصصين في التصوير الجزيئي والصيدلة الإشعاعية، وكذلك إنشاء بنية تحتية وطنية حديثة وآمنة لإنتاج ومراقبة المستحضرات الصيدلانية الإشعاعية، وتشجيع البحث في التخصصات التي تربط بين المخابر والمصالح السريرية، وضمان الأمان والجودة والتعقب على مدار السلسلة النووية الطبية. وفي هذا الصدد تجدر الإشارة إلى الخبرة التي اكتسبتها بلادنا من خلال أنشطة مراكز البحث النووي لمحافظة الطاقة الذرية في مجال إنتاج ومراقبة الجودة وتوزيع المستحضرات الصيدلانية الإشعاعية المستخدمة في الطب النووي، حيث أن طموحنا لا يقتصر على ذلك، بل نحن بصدد العمل على إنشاء هياكل وطنية لإنتاج نظائر مشعة موثوقة وقابلة للتعقب. السيدات والسادة الحضور، تولي بلادنا أهمية قصوى لتنمية الموارد البشرية من خلال تأهيل وتكوين مختلف الفئات المهنية عن طريق التكوين العملي في المخابر والمنشآت الوطنية والجامعات والمستشفيات لتوجيه أعمال البحث التطبيقي، وكذلك التعاون الوثيق مع الوكالة الدولية للطاقة الذرية الذي يتيح لخبرائنا الحصول على تكوين عالي المستوى ونقل خبراتهم إلى بلدان أخرى. فعلى الصعيد المحلي تم إنشاء تعاون بين مختلف القطاعات، وعلى رأسها وزارة الصحة ووزارة التعليم العالي والبحث العلمي والعديد من المؤسسات الاستشفائية لضمان تناسق الأنشطة على الصعيد الوطني. أما على الصعيد الدولي يتواصل تعاوننا مع الوكالة الدولية للطاقة الذرية من خلال مشاريع إقليمية تهدف إلى تعزيز قدراتنا التقنية ووضع الجزائر في موقع مركز إقليمي متميز في مجال الطب النووي من خلال مبادرة أشعة الأمل من أجل تحقيق الهدف الثالث من أهداف التنمية المستدامة للأمم المتحدة والمتمثل في تمكين الجميع من العيش بصحة جيدة وتعزيز رفاهيتهم في مختلف الأعمار. السيدات والسادة الحضور، تعمل الجزائر على استخدام الطاقة النووية لغرض تطوير إنتاج المستحضرات الصيدلانية المشعة على المستوى المحلي لتلبية الاحتياجات الوطنية المتزايدة لهذه المواد وتأمين سلسلة التوريد وضمان التوفير المستمر لهذه المواد الحيوية للطب، مما يساهم في تقليل واردات المستحضرات الصيدلانية المشعة وتحسين رعاية المرضى وتقليص فترات الانتظار للعلاج. إن طموحنا واضح، هو ضمان السيادة الوطنية في إنتاج النظائر المشعة وتعزيز البحث والابتكار في مجال العلاج التشخيصي وترسيم قياس الجرعات المشخصة وجعل الجزائر فاعلا رئيسيا للتعاون العلمي بين بلدان الجنوب. ويعتبر هذا المؤتمر فرصة لتبادل الخبرات في مجال الطب النووي الذي يعرف تحولا سريعا وتطورا كبيرا بفضل التصوير الجزيئي المتقدم والتشخيص العلاجي وقياس الجرعات المخصصة. ومواكبة لهذا التحول ستسعى بلادنا لتكون شريكا استراتيجيا من خلال توحيد الجهود والاستفادة من التجربة الكبيرة والمهمة لمختلف الباحثين والمهندسين والأطباء والمؤسسات الشريكة. في الختام، أعلن رسميا عن افتتاح أشغال هذا المؤتمر حول الطب النووي، وأتمنى لأشغاله التوفيق والنجاح والخروج بتوصيات تساهم في دعم التنمية المستدامة لهذا المجال. وشكرا على حسن الإصغاء.
شكرا سيدة الممثلة وزير الطاقة والطاقات المتجددة. أدعو البروفيسور كمال صنهاجي رئيس الوكالة الوطنية للأمن الصحي ومستشار السيد رئيس الجمهورية، فليتفضل مشكور أستاذ.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين. On a bien vu cette palette linguistique en passant de l'arabe, l'anglais, ce sera aussi le français, pour dire que notre pays est ouvert aux langues, à toutes les langues, le plus possible de langues. Donc, Monsieur le secrétaire général du ministère de la Santé, le chef de cabinet donc, du même ministère, Madame la représentante du ministre de l'Énergie et des énergies renouvelables, représentant du ministre du Travail, Monsieur le commissaire à l'énergie atomique et Monsieur le président de l'autorité de l'énergie nucléaire. Donc, Mesdames et Messieurs les représentants des instituts nationaux et internationaux, honorables invités, chers confrères, chers collègues, Mesdames et Messieurs, que c'est avec une immense joie et une grande fierté que je me tiens devant vous aujourd'hui pour prendre part à la conférence internationale d'Alger sur la médecine nucléaire. AICONM, enfin, je sais pas, c'est un peu difficile à AICONM, ok, AICONM, 2025. Donc, au nom de l'Agence nationale de sécurité sanitaire, que je préside, et au mon nom personnel, aussi représentant et conseiller scientifique de Monsieur le Président de la République, je souhaite la plus chaleureuse bienvenue à tous les participants qui viennent d'Algérie ou de l'étranger. Aussi, je tiens tout particulièrement à remercier le comité d'organisation, donc en particulier donc l'association nationale algérienne de médecine nucléaire. Je vous en remercie vivement, ainsi que le commissariat de l'énergie atomique, donc avec lequel nous sommes habitués partenaires à travailler, parce que le docteur Mellah tient beaucoup à cet aspect donc de rationalité et d'anticipation en termes d'événements sanitaires, donc d'avoir donc organisé cette manifestation scientifique qui va traiter un volet important au service du patient à une période bien cruciale où des bouleversements impactent la santé des citoyens. Ces bouleversements sont prégnants, sont saillants, ils sont là, ils sont immédiats, vous les connaissez tous, ce sont les pandémies. Nous en avons bien reçu une bonne gifle du Covid, hein, à retenir la mauvaise alimentation, les changements climatiques. Ça, ce sont les premières urgences, il y en a d'autres. La tenue de cet événement majeur à Alger, au centre de recherche nucléaire d'Alger, le CRNA, est un signal fort de l'engagement de notre pays à promouvoir et à développer l'utilisation pacifique de l'énergie nucléaire dans le secteur vital, celui de la santé. L'Algérie, sous l'impulsion de M. le Président de la République, se positionne comme un leader régional dans ce domaine, avec pour objectif stratégique l'amélioration de la prise en charge des maladies graves et la modernisation de notre système de santé publique, mais il y a c'est toute la santé. Hein. Le thème de votre conférence, donc centré sur les avancées du diagnostic à la thérapie. Donc, vous l'avez bien signalé, Madame le professeur, reflète parfaitement la dynamique actuelle de la médecine nucléaire. Nous assistons en effet à une révolution où l'imagerie moléculaire et les thérapies par radionucléides transforment radicalement notre approche des pathologies, notamment en oncologie, cardiologie et neurologie. Ces technologies de pointe nous permettent non seulement de diagnostiquer avec précision inégalée, mais aussi de proposer des traitements ciblés, personnalisés et également moins invasifs. C'est important. Durant ces 2 jours, le programme scientifique riche et dense couvrira un large éventail de sujets allant des fondamentaux de la dosimétrie, par exemple, aux dernières innovations technologiques, en passant par les applications cliniques avancées. Nous avons l'honneur d'accueillir plusieurs conférenciers invités de renom, experts algériens et internationaux, dont la présence atteste de l'importance et de la qualité de cette rencontre. Vous en êtes vivement remerciés. Cette conférence se veut un carrefour d'échanges, de partage, de connaissances et d'expériences. C'est l'occasion unique pour les médecins, physiciens médicaux, pharmaciens, technologues et chercheurs de se rencontrer, de nouer des collaborations, de discuter des défis et des opportunités qu'ils façonnent à l'avenir de cette discipline. Mesdames et messieurs, le développement de la médecine nucléaire ne repose pas uniquement sur la technologie. Il nécessite un engagement fort en matière de formation des ressources humaines, de recherche scientifique et de développement technologique. L'Algérie a compris cet enjeu. Comme En témoignent les efforts du commissariat à l'énergie atomique et des institutions universitaires pour former des experts de haute qualité dans ces domaines pointus tels que la physique médicale et la radiopharmacie. La collaboration internationale est également essentielle. Je salue le partenariat fructueux avec l'Agence internationale à l'énergie atomique, l'AIEA, et d'autres partenaires internationaux qui nous permet de bénéficier des meilleures pratiques et des dernières avancées mondiales. L'exemple des solutions innovantes dans le domaine des produits radiopharmaceutiques, comme celles présentées lors des récents séminaires, démontre le potentiel de ces coopérations. Je tiens à exprimer ma profonde gratitude à tous les membres du comité scientifique et d'organisation pour leur travail acharné, leur dévouement qui ont rendu cet événement possible. Mes remerciements vont également à tous les partenaires pour leur soutien indéfectible. À tous les participants, nous vous encourageons à tirer le meilleur parti de ces 2 journées en assistant aux conférences, en participant aux débats, en visitant les expositions et surtout en échangeant avec vos pairs. J'espère sincèrement que cette conférence sera une source d'inspiration et d'enrichissement pour chacun d'entre nous. Je vous souhaite d'excellents travaux et un agréable séjour dans la ville accueillante d'Alger. Merci à tous.
Merci, professeur Sanhaji. أدعو الأمين العام لوزارة الصحة لإلقاء الكلمة. تفضل مشكور.
Donc c'est un signe que je suis âgé et vieux, la raison pour laquelle il m'a invité à faire cette intervention à partir de ce micro.
Encore jeune.
Bien. Donc Bismillah ar-Rahman ar-Rahim, والصلاة والسلام على أشرف المرسلين. سيد مستشار رئيس الجمهورية، السيد رئيس الوكالة الوطنية للأمن الصحي، سيد رئيس مدير الديوان لوزارة الصحة، سيد المديرة العامة، سيد المدير، سيد محافظ ومفوض المفوضية للطاقة الذرية، ضيوفنا الكرام، السيدات والسادة الخبراء، الأسرة الإعلامية الكريمة، الحضور الكريم، كل باسمه وبصفته ومقامه، السلام عليكم ورحمة الله وبركاته. إنه لمن دواعي سروري واعتزازي أن أكون بينكم اليوم في هذا الحدث العلمي البارز، نيابة عن سيد وزير الصحة الذي كلفني أن أمثله، والمتمثل في فعاليات المؤتمر الدولي الثاني للطب النووي لسنة 2025 الذي تنظمه الجمعية الجزائرية للطب النووي بالتعاون مع المفوضية للطاقة الذرية كومينا، وذلك بمساندة الوكالة الدولية للطاقة الذرية. أود بداية أن أرحب بضيوف الجزائر الأكارم من خبراء وباحثين وأطباء وفيزيائيين قدموا من مختلف الدول الصديقة والشقيقة، فأهلا بكم في بلدكم الثاني الجزائر، متمنيا لكم إقامة طيبة ومفيدة وعملا علميا مثمرا في كنف هذا التجمع الدولي المتميز. أيها الحضور الكريم، لقد أولت بلادنا بقيادة رئيس الجمهورية السيد عبد المجيد تبون أهمية قصوى لتطوير المنظومة الصحية وتعزيز التغطية الصحية الشاملة، وذلك من خلال تحسين التكوين وترقية الوقاية ومواجهة الأمراض المتنقلة والغير متنقلة على حد سواء. وفي هذا الإطار حظي الطب النووي بمكانة محورية ضمن خطط إصلاح القطاع الصحي لما يقدمه من قيمة مضافة في التشخيص والعلاج، خاصة لفائدة مرضى السرطان والأمراض المزمنة والمعقدة. وقد وجه السيد رئيس الجمهورية تعليمات واضحة تتعلق بتشجيع الاستثمار في مجال الطاقة الكهرونووية لأغراض طبية، وترقية استخدام التقنيات الحديثة للعلاج الإشعاعي بما يضمن للمريض الجزائري تكفلا علاجيا مطابقا للمعايير الدولية في جميع ولايات الوطن. كما أولت الجزائر كذلك اهتماما خاصا لتعزيز شراكتها مع الوكالة الدولية للطاقة الذرية، إدراكا منها للدور الحيوي الذي تلعبه المنظمة في مراقبة الدول وتطوير استعمالات الطاقة النووية السلمية. ونحن على استعداد كامل لتقاسم التجارب والخبرات، خصوصا في الدول الإفريقية الشقيقة في إطار رؤية تضامنية واستراتيجية مشتركة. أيها الحضور الكريم، لقد أصبح الطب النووي اليوم أحد أكثر التخصصات تقدما وتطورا في المجال الطبي، بفضل الاعتماد المتزايد على التصوير والتشخيص الوظيفي المتقدم، إلى جانب التوسع السريع في مجال التيرانوستيك الذي يجمع بين التشخيص والعلاج في مقاربة واحدة، تحدث ثورة حقيقية في التكفل بالسرطان. ويتميز هذا المؤتمر في طبعته الثانية بثرائه العلمي وتنوع محاوره التي تعكس أحدث التطورات في هذا التخصص الحيوي. وعلى مدار يومين كاملين ستشهد ورشات تكوينية تطبيقية في طب القلب النووي وقراءات الفحوصات في هذا المجال، بالإضافة إلى جلسات علمية متخصصة تتناول سرطانات الغدة الدرقية والبروستات ومواضيع حديثة في التكنولوجيا النووية الطبية، إلى جانب الجوانب الاقتصادية والتنظيمية ذات الصلة. ولا يفوتني هنا أن أؤكد بأن تنظيم مثل هذه الملتقيات يترجم إرادة الجزائر في الاندماج الفعلي في الديناميكية العلمية العالمية، وتعزيز دور البحث العلمي والابتكار، ودعم نقل التكنولوجيا المتقدمة نحو مؤسساتنا الصحية والجامعية. كما أود أن أثمن عاليا بخبرائنا الذين يجسدون بجهودهم وطموحهم وبدورهم في تطوير الممارسات الطبية في هذا التخصص في بلادنا. أيها الحضور الكريم، أتمنى لهذا المؤتمر كل النجاح والتوفيق، وأن تتوج أعماله بتوصيات عملية ورؤى مبتكرة تسهم في تحسين التكفل بالمرضى وتفتح آفاق أرحب للتعاون العلمي والشراكات الدولية خدمة للتقدم الطبي ولصحة المواطن. شكرا لكم على حسن الإصغاء، والسلام عليكم ورحمة الله وبركاته.
أشكركم السيد الأمين العام لوزارة الصحة على الكلمة، وأعلن رسميا افتتاح أعمال الطبعة الثانية للمؤتمر الدولي للطب النووي، وشكرا.
Good morning, esteemed guests, ladies and gentlemen. It's our honor to welcome you to this important event. Now, we now extend our gratitude for the opening ceremony. We will now proceed with our program with Professor Esterada Lobato, who will present the role of the IAEI in the capacity building and sustainable development of nuclear medicine in Algeria and the African region.
Thank you very much. Well, first of all, it's really a great honor to deliver a lecture in front of such an important people. And I want to apologize for my voice because in the last year I have had several surgeries in the vocal cords because I used to sing. I cannot sing anymore, but I developed nodules, the famous nodules for singers. Now I struggle to speak sometimes, but I hope it's going to be, we can do it without any problem. This is the outline of the presentation. We're going to speak a bit about the background of nuclear medicine in not only in Algeria, but also in the continent. The IAEA mandate and core activities, capacity building tools and programs. We're going to refer a little bit about what the IAEA has done in Algeria. And we're going to talk about sustainability strategies, partnerships and resource mobilization, challenges and recommendations. And we're going to do a roadmap on the expected impact of our activities. In fact, this is a very important topic when we are discussing the current IAEA activities because we do many things. We do a lot of projects, both nationals, regionals, but when we try to measure the real impact that we are having in the community, it's really difficult. I mean, we can do it, but not in a short term, especially when we are talking about health. We need several years to really see the impact of what we are doing. In nuclear medicine in Africa, we have several problems here because we are talking about heterogeneity in the practice of nuclear medicine. And in fact, we are talking about many countries in Africa without a single nuclear medicine department. That's why in many places, we need to work from scratch. And establishing a new facility in nuclear medicine is not only procuring the equipment. That's the easy part. We have to prepare not only the scientific team, the physicians, technologists, radiochemists, radiopharmacists, not only that team. We also need to prepare the framework, the legal framework for that. The country needs to have a legal framework for nuclear applications, and we can support also in that. So they are able to provide the licenses to operate the nuclear medicine facility. So it's really a lot of work. And we need to consider also providing the radiopharmaceuticals that are essential for the practice of nuclear medicine. And for that, we need to establish supply chains that are reliable and can allow the continuous work of the nuclear medicine department. This is just a snapshot of the nuclear medicine in the country. We have discussed this extensively in the last 2 days. In fact, the information that I had before coming to the meeting was really outdated. I had 15 functional nuclear medicine centers, and yesterday I found out that there are 57 with 5 cyclotrons in the country, which is really a big development in the last few years. We need now to update our databases because we have the really outdated information. All this supported by the Ministry of Health, the Ministry also of Energy and Renewable Energies, and not only the national authorities. In order to promote and improve the practice of nuclear medicine, we also need regional agreements. And for this, we have the regular national projects focusing on the needs of the country, but also there are common needs in the countries in the region that are covered by regional efforts like the AFRA agreement. The IEA mandate, our DDG from the Technical Cooperation Department already mentioned a bit, but we are here to promote the peaceful uses of nuclear technology, especially in health, to support the member states through the Technical Cooperation Program, and also the developing and delivering the standards in the practice of nuclear applications, strengthen safety, of course, quality assurance and regulatory oversight, enable sustainable, locally owned nuclear medicine and radiology service. And there are several core programs for nuclear medicine and diagnostic imaging. Of course, we are focusing on capacity building and resource development. And this is done not only through technical cooperation, but also with the regular budget of the nuclear medicine and diagnostic imaging section. We train people, we send fellows from one country to the most advanced countries. We organize workshops and e-learning activities. We have quality management programs, Quantum for nuclear medicine and Quadrille for radiology. We provide guidance in radiopharmacy or cyclotron use and theranostics. By the way, Professor Alavi, we have also another technical document on how to establish a theranostics facility. This is very new. I'm going to send it to you to your email. And we also work with regulatory and safety infrastructure strengthening. When we talk about the regular budget activities, and I want to emphasize this because it is different from the technical cooperation program. We have some activities developed through the section of nuclear medicine, and we have our human health campus that is an open source free website in which we have a lot of training materials, a lot of technical documents, guidelines, and all the standards provided by the IAEA in the practice of nuclear medicine and radiology. We have the databases like NUNDA for nuclear medicine and Imagine for all the rest of diagnostic imaging modalities, the programs for quality that I already mentioned, and also some initiatives launched by our Director General, like Zodiac for zoonotic diseases, Rays of Hope focusing on cancer, and the St. Jude's initiatives that are meant to help member states to improve pediatric oncology. Of course, we have the IAEA publication. We have many, and all of them are free. You can download the publications in PDF form and have it in your tablet and your computer to consult whenever you want. And talking about the capacity building tools and mechanisms, I already mentioned the fellowships, and Algeria has provided a lot of support in that regard. We have trained physicians from several African countries. They come here and they are trained in the whole specialty thanks to the colleagues from different hospitals. And now we signed also an agreement to have something called Anchor Center, not only for nuclear medicine and radiology, but also for radiotherapy, medical physics, and we include also a bit of radiopharmacy. We provide equipment, we procure equipment for countries, and we do remote mentoring, telemedicine, and we have many e-learning platforms. And of course, we provide assistance for national policies, staffing models, and clinical protocols. In radiopharmacy, this is a core need in many countries, in all the countries, in fact, because without that, we cannot work in nuclear medicine. We provide technical support for establishing radiopharmacies at different levels, for basic nuclear medicine, for advanced nuclear medicine, for theranostics. We assist with GMP practices in developing cold kits and sterile productions and quality control. And we also try to establish, to help member states with the supply chain for radiopharmaceuticals. And of course, training in quality, control and quality assurance and regulatory compliance, which is essential for nuclear medicine. We support the national regulatory authorities with licensing, with inspections. We train the authorities because when we are establishing a nuclear medicine from scratch, then we need to train also the regulatory authorities. Also training on the transport and waste management and radiation protection, implementation of international standards, and of course, we do a feasibility study to see if establishing a nuclear medicine department in a country could be beneficial or not, if it's unsustainable the long term. Education and workforce is one of our core activities at the IAEA. We develop curricula for all the professionals involved in the specialty, support residency programs, continuous professional development, certification, train the trainer approach. This is also something in which we give a lot of importance. Train the trainer, so afterwards that person can train the local staff. And of course, retention strategies. When we train people, we don't want that people to go to another country. They have to stay in the country where they belong. And well, this is the continuation of the case study for Algeria. We, in order to develop a project, and it's not only working for Algeria, for any country or any type of project, we need to define the objective. We need to have different components, like what are we going to do? Are we going to train people? Are we going to procure equipment? Are we going to organize national workshops? What are we going to do with that project? And of course, the outputs of the project. This is the product that we are going to have at the end, at the very end. And all our projects need to see to be sustainable, especially at the long term. And I mentioned before that we have not only national projects, but also regional approaches. And for that, we have AFRA, which is an agreement for most of the African countries. It's the African Regional Cooperative Agreement, and it provides a collaborative platform across Africa for nuclear medicine, for radiotherapy, for all the radiation medicine specialties. We have currently successful regional projects in which we provide a lot of training to many countries. And we share, of course, the expertise from more developed countries with the countries that are not lucky enough to have that type of development. And we promote harmonization of regulatory and technical standards across our member states. I mentioned before that sustainability was something really important for the long-term success of our projects. We need to analyze the cost recovery models, both with public insurance, government subsidies, and public-private partnerships. This is PPP, public-private partnerships, in which we don't fight with the possibility of having private industry involved in our projects when we are talking about the benefit of a country or a region. We also need to check on the predictive maintenance and local biomedical engineering to be able to provide the services for the equipment that we procure. To do an inventory and procurement planning to prevent stock outs. And also we try to increase or develop the local facilities for manufacturing, especially small equipment or disposable equipment. We also need to take care of the environment. So environmental sustainability and waste management is something also really important related to radiation protection, the safe handling and disposal of this short and long-lived radioactive waste, the adoption of waste minimization and segregation practices, training for safe transport and storage of the radioactive materials, and alignment with national waste policies and regional solutions. And talking about that, the transportation regulations are going to change. They are going to be a bit tougher, more difficult to comply, but it's going to be for the sake of the people involved in transporting radioactive materials and radioactive waste. Also, we try to increase the key partners. In the UN family, we work a lot with WHO, with the African Union, regional health bodies, donors, industry. We leverage multilateral funds, grants, and public-private partnerships, engaging with manufacturers for training, maintenance, and local stock, and promote South-South cooperation and institutional twinning. And of course, as my colleague mentioned before, we have a lot of challenges like sustained funding and budgetary constraints, the workforce shortages and retention difficulties. The supply chain fragility, we saw that during COVID. I mean, worldwide, we had problems to supply the radioactive materials. The practice of nuclear medicine went down 60% during that time, and was mostly because of the chain constraints. The regulatory gaps and variable safety culture, and also the maintenance support for all the equipment that we procure. Of course, well, I already mentioned this. And the recommendations and practical steps, first of all, is develop or improve the national roadmaps aligned with the IAEA assistance plans, implement phase capacity building, meaning training, equipment, quality assurance, sustainability, establish regional isotope supply hubs and maintenance networks, invest in local training of trainers and biomedical engineering, strengthen regulatory frameworks, and integrate all this into the national policies. This is just an example of the roadmap of a project. Could be national, could be regional. Normally, we do the needs assessment, the policy alignment, and then we start the trainings to have, let's say, quick wins, rapid trainings. That will be the first year. In the second year, we focus on procurement of equipment and long-term fellowships, and of course, improve radiopharmacy, either building one from scratch or improve the existing facilities. In the third year, we try to scale services to do quality accreditation and regional collaboration. And we need to monitor our projects, because the impact of what we are doing is very important. It's not only providing something. It's like when I procure an equipment, when I train people, is really having an impact, or everything is the same? Are the patients improving? Are they living longer? Or what are we doing? We need to really keep an eye on that. And of course, the expected impact and the metrics that we use are really important. For now, we have short-term metrics for our projects, but we are working on developing tools for the long-term impact to see if we are really making an impact in the community. And as a conclusion, I can tell you that the IAEA plays a really important role in enabling safe, effective, and sustainable nuclear medicine and diagnostic imaging across the world. Integrated approach by procuring equipment, training people, improving regulation and financing. Algeria has a lot of potential to be a regional leader through the Race of Hope Anchor Center initiative that we already signed the agreement. We have been collaborating for many years. Now we need to strengthen that collaboration. We already made it more formal, and we are going to be increasing that. And of course, having strategic partners, connecting people to be able to get funds, collaboration, and establishing other initiatives. Thank you very much for your attention.
Thank you, Professor Estrada, for your presentation. Comme ça, je vous libère. Ouais. Bon, on essaie juste une photo de groupe avec votre assistance. Donc, je vous permets de sortir les premiers. On va prendre une photo de groupe et la pause café, break coffee, 15 minutes, et on reprend nos travaux scientifiques. Merci.
Welcome back. I hope you all enjoyed your coffee break. And now we will proceed with our next speaker, Dr. Khallaf, presenting how to implement the Theranostics Iraq experience. Just a second, there's a little problem.
Excusez-moi, est-ce que vous pouvez tous prendre place afin que on commence, s'il vous plaît?
Welcome back. I hope everyone enjoyed their coffee break. And now we will proceed with our next speaker, Dr. Khalaf, presenting how to implement theranostics Iraq experience.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Firstly, I would like to thank Dr. Imad and the Algerian Association of Nuclear Medicine to invite me to be here in this remarkable event with this remarkable group of nuclear medicine scientists. First of all, I am Dr. Aysar Naji Khalaf, head of the Nuclear Medicine Department in Warith International Cancer Institute in Iraq, Karbala. First of all, this institute is a semi-charity institute, and all children below 15 and below are taking all services as a cancer patient free of charge. Now, always we say without strong roots, there is no expansion and no progression. In nuclear medicine history in Iraq, it's maybe in the early 60s began. This is Professor Dr. Ali Al-Hindawi, the first nuclear medicine physician in Iraq, and the crew of nuclear medicine department, and also the building of the first Iraqi nuclear medicine and radiation therapy center in Baghdad. It's big open its doors for the patient in 1962, and these are some of the first pioneers procedure have been done in this institute. In the early 60s and late 60s, the Sentinel view, the whole body counter, the neck and thigh counter for the uptake, and also the man in this demonstration is the first physicist or nuclear medicine physicist in Iraq, Mr. Salim Al-Mahdi. And on the left, there is the first gamma in the Iraq, Anchor Gamma. This is established in 1968, exactly. Due to some political situation, Iraq regressed somehow in nuclear medicine, and after 2017, the progression began. The journey in our center, Warith International Cancer Institute in the Nuclear Medicine Department, began in October 2021. We established the Nuclear Medicine Center or department. The facilities we had 6 isolated rooms for radioactive iodine and theranostics, isolated and standardized according to the international standardization. Also, these are the example of the isolation rooms or isolation wards. These are the equipments that's established in the nuclear medicine department, PET-CT and SPECT, as well as InSight cyclotron. In the beginning, we started the journey in nuclear medicine theranostic maybe in January 2023, and I left all that. The theranostic is a platform combine 2 important words, the diagnostic and therapeutic in one platform, which means that treat what you see and see what you treat. We followed the instructions on the guidelines of Joint European Association of Nuclear Medicine and Society of Nuclear Medicine and Molecular Imaging and procedures or NCPGs in our center. All these informations, I think it's discussed with the previous colleagues and the previous presenter. Mainly, we concentrate in something important, the use of FDG to make the standardization is high regarding the selection of patients that treated with lutetium therapy. So most of patients in our center had imaged by FDG PET-CT in parallel with the PSMA or gallium DOTA PET-CT. Our procedure or our guidelines regarding the patients that receive theranostic, specifically the lutetium PSMA and lutetium DOTA, we put a protocol of 4 doses to 6 doses. The interval between each is 6 to 8 weeks, and we follow up the patient regularly after 1 month after each, and did PSMA PET-CT or gallium DOTA PET-CT after the second dose to illustrate if the response is good or not. And the regulations, we stuck to the regulations of National Nuclear Radiological, Chemical and Biological Regulatory Committee, the Iraqi one, which is stick to the safety standards of the International Atomic Energy Agency. We started the program in the diagnostic part. Specifically in April 2022, we started and began to image the patient with PSMA and DOTA, gallium DOTA also, and the journey of the theranostic, the therapeutic part of the theranostic began in the 3rd or 4th of January 2023. Also, this slide demonstrates the first case that treated in our center. Exactly, he took the therapy on 4th of January 2023. Those are some PET-CT MIP for our patients that treated in our center, with range variety of distant metastases in bone, soft tissue, lymph nodes, and others. Actually, the most promising in our center, we received patients from all over the Iraqi governorates, from the north to the south of Iraq. Exactly about more than 104 patients distributed in most of the governorates in Iraq, mostly from Baghdad, the capital, and the rest from other governorates. In this slide, we had the first patient, it's an 88 years old male from Baghdad. Exactly, he diagnosed with metastatic prostate cancer since 2019, and after receiving multiple treatment lines from chemotherapy, hormonal, and palliative radiotherapy, he came to our center and received 4 doses of lutetium PSMA therapy. The figures illustrate that the patient had completely responded to the treatment, and the biochemically the PSA level regressed from more than 3,000 to reach 0.4 at the after the treatment. And this is the same patients, and we show in this slide how is the disease is disseminated. And after 2 doses, the PET-CT showed a regression about more than 80% of the disease lesions. Also, we have another patient had completely response from the lutetium PSMA therapy. It's a 77 years old male, suffered from metastatic prostate cancer to the pelvic lymph nodes. And after 4 doses of the lutetium PSMA therapy, the patient completely responded and showed complete disappearance of the lesion within the pelvic area, and also the PSA level regressed to reach the normal value. Also, we had the other one, patients, 72 years old, male, also had a disease, metastatic prostatic cancer to the thoracic and abdominal pelvic lymph node, and after therapy with lutetium, the patient had complete response, biochemically and by imaging. Also, after collection of data regarding the PSMA lutetium therapy in our patient in Warith Cancer Institute, we found that till September 2025, we managed about 89 patients with metastatic prostate cancer. About 73 of them had a decline after the first dose in the PSA level, and about more than 55% of those patients had a decline more than 50% in the PSA level after the first dose of the lutetium, which is promising in our country due to the short journey of the theranostic or such type of theranostic, I mean the lutetium, PSMA, and DOTA in our country. Regarding the lutetium DOTA therapy, we had about more than 14 cases till now from the beginning of the journey. This is an example of a female, 36 years old, treated as an ovarian cancer at first, and after traveling to other centers outside Iraq, she diagnosed, with the well-differentiated neuroendocrine. The primary was in the ovary, and then Ki-67 was between 5 and 10 for this patient, and received therapy, which is the lutetium DOTA therapy, and after 2 doses, the patient showed good or excellent partial response and decline of the chromatogranin A from more than 400 to reach 51. Another example, she is a female, 19 years old. This is a specific and special story. Why? Because this female now joined us in the department as an employee. So the patient came to Dr. Farah and then received therapy, lutetium DOTA therapy, and after that the patient had a good response, and the last follow-up is completely responded to the therapy. Also, regarding other types of theranostic, or the old one, the radioactive iodine therapy, we have many cases to manage. For example, this patient, 35 years old male patient, he had follicular thyroid cancer with multiple sites of bone metastases, and after doing surgery and radioactive iodine therapy, in the follow-up we found that the thyroglobulin level declined from more 500 to reach 72 after the first dose of the radioactive iodine, which was 200 millicurie. Another case with the solitary bone metastasis approved by other imaging and biopsy received 1 dose of radioactive iodine, accomplished excellent response after the therapy with radioactive iodine. Also, recently, before 3 months ago, we started a program to use the MIBG therapy in our department, and this is the first time in Iraq to use the radioactive iodine MIBG therapy for patients with neuroblastoma and other diseases. And what have been done in this 4 years of the journey is in the nuclear medicine department in Warith Cancer Institute are illustrated in this slide. More than 12,000 PET CT done for our patient. Also more than 2,000 patients received radioactive iodine therapy, and more than 100 patients receive lutetium therapy, mainly PSMA, and some cases received DOTA lutetium therapy. And also, only 3 cases received MIBG therapy, because this is the first time in Iraq to do that. After that, I should mention this, because our institute purchased the first mobile PET-CT in the region. This device just arrived before 2 weeks, and now in the preparation, the device in the preparation stage to be activated. These are some example of the procedure that we use to reduce the radiation radiation effect from the lutetium, to reduce the salivary gland uptake. Also, we're using the amino acid infusion to the patients that received lutetium DOTA therapy to protect the renal system. Also, we use the Logos solution that protect the thyroid from the MIBG therapy and to reduce the uptake. This is important for us because this is a message from the Iraqi Atomic Energy Agency, specifically the National Liaison Officer, to consider Warith as a national and regional training center under umbrella of International Atomic Energy Agency. One of the most important achievements throughout this short period or short journey is the accreditation that given by the Arab Board of Health Specializations for the Department of Nuclear Medicine in our center, Warith International Cancer Institute, to be a training center on only the first training private center in the nuclear medicine for board students in Iraq. Also, through these years, we have more than 20 publications we participate in. Most of them are in collaboration with King Hussein Cancer Center and specifically Dr. Akram. And also, now I am ambassador of this Oncidium Foundation, which is one of the foundations that deal with patients and give a coverage for doses of patients, for doses of lutetium to patients all over the world. And through this slide, I illustrate how the progress occur in our department. Firstly, October 2021, we are only 5 to 6%, and now after this progression, we have this staff in our department. I would like to thank him to stand behind the project and push the project forward. And also, lastly, I would like to thank my backbone and my wife and my deputy, Dr. Farah Mohammed, in standing with me to get such this progress in our country regarding the theranostic and the nuclear medicine. And lastly, I would like to thank Dr. Akram because he always is standing with us and supporting us to achieve such this achievements in our country. And I would like to say something important. In 2017, we had in Iraq only 1 PET machine with 4 gamma camera. Just now, we had more than 29 PET machine with more than 30 machine of gamma camera and SPECT CT all over the Iraq. And this is a huge number, and short time progress make some challenges, especially regarding the human resources. And lastly, I would like to thank you for your attention, and I hope I illustrate something important outside in Iraq.
Thank you so much. We may now proceed with our next speaker, Professor Flayman, who will be presenting how to increase cost efficacy of RLT predictive biomarkers.
Thank you very much for this introduction. I have to shift the slides.
I close this. Vlammen. I hope it's a good one. So, thank you. First of all, thank you for inviting me. It's an enormous pleasure to be here. I was here last year, but only one night, and now I plan to stay 1 week to get better know this nice country, because why I do have a link with Algeria. My career, in fact, by accident, started with at Institut Bordet. Here you see the hospital with Algerian nuclear medicine physician, which was Tarek Belloussi, with whom I worked during 5, 6, 7 years, and I succeeded with him in doing the first publications, etc. I speak with 20, maybe 30 years ago, but now. My link with Algeria is intensified since 2, 3, 4 years, because we have an education, a training program for Algerian nuclear medicine physicians and radiopharmacists that come via funding of the IAEA to our hospital there. For 3 months, sometimes 6 months, and that is really very nice. They get, because they stay so long, they get really accepted, and they work together with our team and with the physicists, the pharmacists, and they get a full training program, and they are completely happy with that when they go back home. So this is a nice hospital, and it is constructed only 3 years ago, and that means that I was very lucky, because since 5 years ago we know that radioligand therapy is increasing, and so we had the advantage of already including much more space for nuclear medicine in that hospital. That is one of the issues that existing hospitals have, because the volume you need to perform all these tasks, therapeutic tasks, and also increasing PET activities, the problem is that you don't have the volume, you have to construct other buildings, etc. So I will speak about cost effectivity. The cost of RLT is high. We should not be naive on that. It's not only the drug, which costs about, in our hands, between 15 and 20,000 euros per cycle. Most patients have 4 cycles, means 80,000 euros. Sometimes you go to 6. That means 100,000 euros per year. That is comparable to immunodrugs. We should not be too scaring about that, because the other drugs in oncology, which are also considered as breakthroughs, have the same price. But the cost is not only the drug, the cost is also a lot of work that comes in with the starting this therapeutic application. We need to see the patient. We do a lot of PET CTs. I will discuss that we need more than one PET CT. Somebody explained already that. We need dual PET CT that we have to hospitalize the patient in dedicated rooms. We have to administer the product, and we do post-therapy SPECT CT imaging. All that comes with an increased cost. The cost which is somebody has to pay for it. It's the society that has to pay, insurance company, and sometimes the patient has to pay, but in our country, patient cannot pay, so that means that it's most often the department that pays and performs this treatment in a deficitary, in a loss financial situation. So how will we increase the cost effectivity? And I will mainly focus, because I only have 20 minutes, on the things in red. We can increase efficacy of the drugs, and then on the other hand, we can reduce the cost. The efficacy, it has already been explained. We have these tools of theranostics, so we have diagnostic imaging that predicts the efficacy or the target expression that we want to use for our therapy. So pre-therapeutic PET CT. Also post-therapy imaging plays a role. I will explain all that. The cost will be reduced by reducing the number of cycles. We have, and I will show you the survival curves, we have, don't forget, 30 to 50% of patients that are not responding, which is similar in chemotherapy and similar in immunotherapy. We always have half of the patients that are not responding to these expensive drugs. So we can identify them and reduce the number of futile RLT cycles by performing PET-CT, SPECT-CT, post-therapeutic SPECT-CT imaging. So here you see the survival curves of the two latest breakthroughs in oncology. At the left you have the ICI, so the immunotherapy. On the right you have radioligand therapy in prostate cancer. The ICIs are the results of a meta-analysis in lung cancer. Second line metastatic lung cancer, and the radioligand therapy is third line metastatic prostate cancer. You see that the efficacy expressed by the gap between the two curves in it randomized is similar. It is similar, and the final result is not so spectacular. We have a median overall survival increase of 4 or 5 months. This is, as has already been explained this morning, for the VISION trial, this was an unselected patient after 2 lines of chemotherapy. So what you see if you look at this survival curve is this is the problem. We have about 30% of the patients that have rapid progression during therapy. You have the same, you have it even more pronounced with immunotherapy. So we need, this indicate that we are treating patients that are rapidly progressive, that shows no response at all to our therapy. We should identify them. Immunotherapy has enormous problems in identifying non-responding because they don't have good biomarkers. They measure the PD-L1 expression, but it's a very weak predictive biomarker. We, on the other hand, we have very strong biomarkers which are in our hands. And this is that toolkit that we have. It should be more used, I think. The industry is not taking that into account. And we should, as academics, we should stress that we have a very strong predictive toolkit in our hands. On the left hand, you have the molecular imaging that you perform before selecting the patient to be treated. We know that your treatment is efficient when there is an intense expression of your target. It is logic. So we have a whole body multimetastatic assessment of target expression. Immunotherapy is dreaming about that. They cannot do anything. If they have a biopsy, it's only for one lesion, and which takes not into account the heterogeneous expression among metastases in one patient. And then on your right hand, you have this post-therapeutic imaging, which is underused. And that will be the major message, my message today. We see what we treat. Nobody can do that. Chemo, immuno, target drugs, radiotherapy, you don't see. We are the only one that can see after therapy what we are treating. So, what are the tools that we can use to better select patients up front? So before deciding, before ordering the dose, the expensive dose. If you see here, these are the 2 big trials, randomized trials. You know all that VISION trial. It is PSMA compared to standard of care, and the therapy trial is PSMA compared to chemotherapy in the second line, so after first line chemotherapy. If you see the VISION trial, if you do the retroactive analysis, which has been published last year, and you assess the survival of these patients based upon the mean SUV, not the max SUV as has been used in the, somebody explained that, as has been used at entry at the eligibility criteria. It was based upon the max SUV, which should be higher than the liver in the VISION trial. If you look at the mean SUV, that means that mean of all lesions, that you're taking into account all the non-expressing lesions also. So if you have a mean SUV of higher than, in that case, it's 10, which we see about half of the patients, then you look at these survival curves. This is extremely, extremely powerful. If you select patients with an SUV lower than 10, or 8, whatever, that's not so important, then you see that these survival curves are going down, and that the difference of the survival of this patient with the control arm is not so significant anymore, not any more significant. The significance of survival comes from those patients in the vision trial that had a very high expression of PSMA. On the other hand, therapy trial, the ITT trial in terms of survival was negative, but if you split these patients of the therapy trial in patients having a SUF mean lower than 10 versus a SUF mean higher than 10, you see the survival curves, they go out. You have an impact, you are better than second-line chemotherapy, PSMA is better. That can be used at your tumor board because these patients are presented at the tumor board with resistance after first-line chemotherapy. Then the nuclear medicine physician has to say, stop, no second-line chemotherapy, but this is detrimental. The second-line chemotherapy is a catastrophe. Jawali just told me also a patient here treated after second-line chemotherapy, it went not very well. We should avoid the second-line therapy. How can you convince them? That is by after first-line chemotherapy, performing a PSMA PET scan, showing them the hot spots everywhere, saying this patient will respond, and you will be successful. So another thing to use, which is not used everywhere because patients, the doctors and the payment structures do not like that because it's expensive. The dual PET scan, is that expensive? A PET scan costs €1,000 in Europe, a bit more in the United States maybe. It's not expensive compared to the drug that you will use a drug of €20,000. So I can do an assessment in a small Excel file that when I do dual PET scan, I can exclude 15% of the patients. That's 1 on 10 or 1.5 on 10. Because we know this is from neuroendocrine tumors. If we have a heterogeneous a mismatching, let's say a mismatching between the dotatate PET-CT and the FDG PET-CT, having lesions that metabolically active, receptor negative, the outcome of these patients is bad for the moment. You need to add extra treatments, localized treatments focused on the mismatched lesion with external beam radiotherapy. It becomes very complicated. But these patients are not doing well. We published that together with Australia, a multi-global network that we had. And you see here in the survival curve, the upper curve is the patient that have all lesions dotatate positive and no lesions FDG positive. The downside, and in the middle you have here. You see my, oh no. In the middle, you have the patient where there is some lesions that are FDG positive and with some mismatch, but heterogeneous expression. And these are the patients which do not express the target. You should not treat them. That's sure. Everybody agrees on that because the survival is even worse than the control arm in the randomized trials. What is the proof? So this, I think the image has already been shown here. You should in prostate cancer, we perform systematically PSMA FDG. I think there are not so many centers who are doing that. Australia is doing that. They publish data on that. We do that systematically, and it's not unusual. I think 50% of the patients that we see this, where FDG, where in the middle, the liver metastases are active, but they are not expressing your targeted drug, your PSMA. So you should not treat this patient. He will, the outcome of this patient is really, really bad. These are the data which enable us to take the decision not to treat. You see the median overall survival in patient with FDG positive and PSMA negative. With mismatching, the overall survival is really bad. We don't treat these patients. So invest in extra FDG in all patients that you treat with radioligand therapy. Another way of doing this, so once you inject it, because now we have discussed techniques that you can perform before ordering the dose, These are the best techniques. Then once you are on the run, you inject your first cycle, then you can do dosimetry. You can dosimetry different ways. It's a separate talk to discuss how to do dosimetry. You can simplify things. You can use AI in the near future. We see that patients that have a whole body dosimetry which is low, that they are doing worse. So it could be an argument, not the dominant argument for the moment, to adapt therapy in these patients by increasing dose, which is difficult, or by choosing another therapy like alpha therapy in the near future, because alpha could, even with a lower uptake, could deliver enough dose to be curable. The most important message for today is the use of SPECT-CT post-therapy SPECT-CT. We are doing systematically on day one, so the next morning we treat at noon, and then the next morning we are doing a whole body SPECT-CT after each cycle. These images are extremely important, and it's only very recent that we have the data. They have been presented at the AICONM, and before I came here, our publication is now accepted in the AICONM. You see the survival curves there. That indicate that if the SPECT-CT at cycle 2, so that means it's mid-treatment. So you treated 2 cycles. Based upon the SPECT-CT imaging, you can identify about 20 to 30% of the patients that are progressive on SPECT, no PET on SPECT, and you can stop early treatment. If you do it blindly, as is often done in some centers, because the companies, they like to sell you a package of 4 to 6 doses, and a lot of centers are injecting blindly 4 to 6 doses until the patient is really progressing. Then, of course, you have an extremely high cost. These are examples. We use the RECIPE criteria. You should look that up because I don't have time. But the RECIPE criteria is based on volume. It's not on SUV, it's a volume. So you have to assess whole body tumor volume before, during treatment, and the evolution of that volume gives you the signs of progression or not, together with the appearance of new lesions on the SPECT-CT. Here you see on the left a partial responder. On the right you see clearly a progressive disease after 2 cycles. You should stop at 2 cycles, and we proved that, and that is now in press at the European Journal. In a multivariable analysis, we see that for PFS and for OS, this is a very strong. The presence of progression is a really strong negative predictor. That means that you can stop your therapy based upon that criteria that you apply after 2 cycles. Here you see the survival curves. It's very clear. The difference between progression and non-progression is very clear. You should stop because, as you see, an overall survival in the red curve is so bad, which is comparable of pure palliative care, no care at all in these patients. You only give extra toxicity to the patient. You damage the patient. Ethically non-acceptable. Then, should we do PET? This for the rich countries. We are doing PET at mid-therapy, also in prospective trials. I do know you do that also. Mid-term PSMA PET after 2 cycles? No, you don't do that? No, okay. You do that. Should we still do that? Our conclusion of this, but this is unpublished data, is not, you don't need it anymore if you do a careful whole body SPECT-CT, good quality. You don't need a PET-CT. This is the final slide where it's a bit complicated, but at the left is the SPECT result. And this is before, after 2 cycles. So based upon the SPECT, you have progressive disease, stable disease, partial response. If you do PET in the same patient, you see that PET detects more progression. So PET is better in early detection of progression compared to SPECT. If you combine what we are all doing in clinic, you combine SPECT images with the PSA assessment, circulating PSA, then you come to a very good accurate identification of progressive disease. Adding PET here will help identifying a minority of patients, but this is probably, in terms of cost effectivity, it's not useful, but a PSMA PET is really rather expensive. So my final conclusion, because I see that you are a bit impatient. But it's too late. I have to, final, so increase the drug efficacy. The major increase of drug efficacy will come in the future with the new drugs. You all know that there are hundreds of radioligand drugs are now under development. Probably our efficacy will become much better, but don't be naive. That will come also with an increase of price. They have this logic where they adapt the price is in connection to, related to the survival benefit. A decreased cost, we can do that tomorrow. Oh, we are doing it yesterday. So patient performance is also very important. I didn't discuss this. That's important for us. Why? Because I think the nuclear medicine physician has to see the patient. And he has to assess the global performance of the patient. This is really helpful. And then assess the PET scan. I explained that target expression, perform dual PET imaging. By performing all that, you will see that you will exclude about 1/3 of the candidate patients, which is important. You will have better results with the other 2/3. Rapid exclusion of non-responding, that should be in the routine. I think the data are so strong. Look at your mid-treatment images. PET is not needed anymore, but look very well at SPECT-CT and perform dosimetry for more in a prospective research setting. Thank you very much.
Thank you, Professor. Moving on to the focus on theranostics, current trends, starting with Rhenium 188 in skin cancer therapy, presented by Professor Paolo Castellucci from Italy.
Thank
I would
you.
like to invite Mr. Castellucci, Professor.
Can you see my slide? Okay. So thank you again for the kind invitation. I'm so sorry I cannot be there with you, and I apologize for that, but the logistic was really difficult in this. So this is the summary of my talk. We will briefly talk about non-melanoma skin cancer in general, then how to select patients for radioligand, skin cancer therapy. We are so used to talk about radioligand therapy. This is not radioligand. Skin cancer therapy, and then how it's done, a few notes about the literature, and then something about our experience, 5-7 years experience almost, and we move forward to the conclusion. So there are many different types of skin cancers, and they are very frequent, especially in old patients above 80 years old. And the most common type of skin cancer is the basal cells and the squamous cell carcinoma. They are so-called non-melanoma skin cancers. These cancers are very frequent in photoexposed areas, like, for example, the so-called H area in the face. And the diagnosis is relatively simple, since it's clinical first, of course, followed by dermoscopy, and then finally by a biopsy, or one or multiple biopsy, to confirm the clinical suspect of non-melanoma skin cancers. There are many, many different therapeutic options to treat the basal cells or squamous cells carcinoma, but by far the surgery using a technique that is called Mohs surgery is the most used worldwide, followed by different kind of radiation therapies like external or, for example, brachytherapy. So first of all, we have to always remember that in the vast majority of non-melanoma skin cancer, surgery using most techniques is excellent and should always be considered the first option. However, in some cases, there are difficult to treat with surgery lesions. This is a definition by dermatologists. Which are these lesions? Lesions very large, or patient with multiple small lesions, for example, in the face, or lesion located in the face where we are afraid of poor cosmetic results in case of complications, or for example, lesions located in functional areas like lips, eye, ears, or genitals. We will see later some cases about this, and also patients with comorbidities. And so only in these selected cases, rhenium skin cancer therapy could be considered as an alternative treatment to surgery. So, which is the ideal lesion to treat with skin cancer therapy? As we said, where the location is difficult to treat with surgery, where the lesion is large or there are multiple lesions, in patient very old, and most of the time with comorbidities for the eye surgical risk, and finally, but most importantly, lesion with a thickness lower than 3 millimeters according to one or multiple biopsy. Why this cutoff was 3 millimeters? This is the delivery energy profile of rhenium in the normal skin. As you can clearly see, about 75% of the energy is delivered in the first millimeter, while only 95% of the energy is delivered in the first 3 millimeters. What does it mean? It means that after 3 millimeters, to deliver a significant dose, I would increase so much the dose in the surface that is not acceptable anymore. So lesions lower than 3 millimeters are treatable with this technique. Higher than 3 millimeters in thickness are not treatable, at least in a single application. Very few notes about how we do this. We clean the lesion, we delineate the lesion, we calculate the surface of the lesion. We apply, very importantly, we apply a very thin foil, plastic foil above the lesion to avoid a direct contact of the skin with the rhenium paste. And then we use a commercially available device that is mainly composed by a brush with a reservoir filled of 0.2 milliliters of rhenium resin, very, very highly concentrated, about 1 gigabecquerel. And using this brush, we can delineate the lesion and apply our rhenium paste above the margins of the lesion, even if they are not linear. So how we know how much activity we administer? That's relatively simple. We measure the brush before the administration, we proceed to the administration, and measure the brush after the administration. And just to make you know that with one carpool, with one brush, let's say, with 0.2 milliliters of resin, we cover about 25-30 square centimeters. So we are able to treat between 3-6 lesions in one session, more or less. So it's very easy calculation. So you treat maybe 3 lesions of 10 square centimeters or 6 lesions of 5, and so on and so forth. So going quickly to the results in the literature, I want to make you aware that this is absolutely not a new technique. The first data have been published in 2008, so more than 15 years ago, by a group of dermatologists and nuclear medicine physicians from the University of Rome. And they first used not only rhenium, but also, for example, holmium or yttrium, so beta emitters with a similar characteristic. And they firstly assessed a very, very good results, so clinical remission in 100% of the cases after 3 months of follow-up. But coming quickly to recent publications, this is the largest study published so far is a multi-center study involving Australia, South Africa, Austria, and Germany. They collected 182 patients, again, with lesions small in size, so lower than 8 square centimeters, and lower, of course, of 3 millimeters in depth. And you can see the result after 6 months of follow-up, 97% complete response. And this is an update of these findings of this trial. Few months ago, I've been published this paper with the update from the same study after 12 months, so after 1 year. And as you can see, the number of relapses patient increase, of course, and there is not a significant difference between basal cell and squamous cell carcinoma, and the response rate after 1 year is 94%. And these are the results of our experience in the last 7 years. We have treated about 180 patients. You can read the characteristic on the left. Most of them were newly diagnosed, but almost half of them were relapsed after other treatments like cryosurgery, surgery, or radiation therapy. This is important to underline. The treatment time, mean treatment time, was about 1.5 hours. So very, very quick. And these are the doses that we administer. I don't want to go through details, but just if you are interested, I just let you know that the dose to the wall volume was about 50 grays, and the dose to the target was about 25 grays. These are results after 3 years of follow-up, so much longer than the data we observed before. So we had 91% local control, and we observe also some differences, especially in terms of histology. There are some histological type of basal cell carcinoma, especially sclerodermiform, that have shown a response rate much lower than other type of basal cells like the nodular or squamous cell carcinoma. Another thing to take into account is the size of the lesion. Look, there is a 96% response rate in lesions smaller than 7 square centimeters versus 80% response rate after 3 years in lesions that are higher, larger than 7 square centimeters. And it's important to underline that 4 of these 10 lesions that relapses were in the margin. So we considered as relapsed, but were almost outside the field of irradiation of the treatment. So this what happened after the treatment. The first thing to underline is that the patient do not present never any pain. So no patient refer any pain during or after the treatment or during follow-up. These are the example of early toxicity using the scale of common terminology criteria for adverse event of G1, G2, or G3. I just want to let you know what we observe. This is a grade 1, this is a grade 2, again at grade 3, another grade 3. And the percent in our population are that almost 90% of the lesions present of the patient or the lesions presented the toxicity G1 or G2, while only 10% or 9% presented a grade 3 toxicity in the first, let's say, 3 to 6, 8 weeks. But we will see later what's happened to this case. And now some cases, just to let you know what we are dealing with. I first start with this that is like a joke or a trivial. This is a patient with a lesion and that was treated 6 months before. Try to guess where the lesion was. While you're thinking about it, I tell you that this patient was a patient 90 years old, female, HIV positive, so with a very high surgical risk. The lesion was relatively good, small, 6 square centimeters and 1.2 millimeters in depth. So now that you thought about it, the situation 6 months before. What is important to underline, the treatment in this case lasted only 1.5 hours. So this old lady arrived in the hospital, received the treatment. After 2 hours, she went away with no problem at all. But of course, there is a price to pay in early adverse event. This is the situation after 2 weeks, after 4 weeks, after 8 weeks, and after 6 months, the picture that I've shown you. Another case from our series, this is a relapse in a very old lady. You can see the scar from the previous surgery. This patient relapsed. This is a lesion that is very, very, very almost impossible to treat with the surgery, especially in an 86-year-old patient. This patient had basal cell carcinoma sclerodermiform. You can read on the right the characteristic, the dose we have delivered. The treatment time was 1 hour. This is after 3 weeks, 45 days, 90 days, and after 6 months. So just to let you know that the telangiectasia and depigmentation are very, very common, let's say, complication or adverse event in these cases, but also you can see clearly that in the margin of the GTV, there is a relapse that, however, was surgically excised very easily. So let's say that, and also the scar, if you see, is reduced in thickness. And let's say that in this case, rhenium skin cancer therapy used as a neoadjuvant treatment. So was not treatable before, now we make treatable with surgery. Another patient with very large lesions, another reason to enroll patients, again, a relapse after surgery. You can see the large scar, and after radiation therapy, external beam radiation therapy, the pigmentation. In this case, we treated 2 of the 3 lesions. The treatment time was 2 hours. Situation after 4 weeks, 8 weeks, 8 months, and 12 months, 6 months, and 8 months, where we performed the biopsy that resulted negative. Another one, almost impossible to treat with surgery. This was a patient that maybe could be addressed to radiation therapy, yes, but with only 2 hours of treatment, we achieved a very good result with very little or almost no significant toxicity. Another one, very, very common location, the wing of the nose, very common location for non-melanoma skin cancer, but difficult to treat with surgery. In this case, the treatment lasted only 23 millimeters because the invasion was 0.4 millimeters, so very superficial. So we were able to deliver high dose in very low time. Situation after 4 weeks, almost already invisible, but after 2 months, after 2 years, completely disappears, and very, very excellent cosmetic results also. Another one, in this case, treatment 1 hour and 20 minutes, just observe the depigmentation after 2 years. Of course, in this patient is not so relevant, but you imagine in a young lady, for example, is something that you should always take care and think about. Another one, large lesion in an old lady, 87 years old, treatment time 1 hour and 20 minutes, just to show you how we apply the foil. As you can see, very easy. Then after the 1 hour and 20 minutes, you just remove the foil, and together with the foil, also you remove the rhenium paste. After 4 weeks, after 2 years, very good cosmetic results. And finally, the lady I show you with the toxicity G3. This was almost 2 millimeters thickness, so relatively thick. Treatment time almost 2 hours. And that's the situation after 4 weeks. Already see this picture, but look, after 6 months, complete recovery, and it's visible also the tattoo of the lips is visible again. And after 2 years, a very good, or let's say excellent cosmetic result, but again, take into consideration that the depigmentation is always present. Finally, I swear that's the last one. Just this absolutely very good result. Again, 2 millimeters deep of this lesion, 1 hour treatment time, difficult to treat with surgery. After 2 years, almost impossible to see where the lesion was. Of course, this is not a young, good-looking lady, but okay, we know that sometimes the cosmetic result, especially in small lesions, could be really, really excellent. So in conclusion, in our experience, renal skin cancer therapy is an effective treatment that should be considered in all cases where surgery or other modalities are difficult to perform, like for the additional location, for the size of the shape of the lesion, et cetera, or patient with relevant comorbidities. Just remember that small lesions, let's say smaller than 7, 8, 10 square centimeter, has shown a much better results. And of course, let me underline that a strict selection is the key for good result, as we just heard from radioligand therapy. So we have to treat the few patients, but the patient that we have treated must be really well indicated. And I strongly recommend a strict collaboration with dermatology, of course. How to move forward? There are many open questions. For example, the same dose to all questions, or to all lesions, I'm sorry, or a personalized effective dose according to the size, age of the patient. That's what we do, for example. And then we have to understand again which are the main predictive factors for relapse or toxicity. And of course, we need a longer follow-up to assess the real efficacy of the method and the relapse rate after, let's say, 3 to 5 years. I know there are no question and answers, so if you have any question, just send me an email. And I hope that Google Translator was correct to say that thank you for your kind attention. Bye-bye.
Thank you, Professor. So, ladies and gentlemen, now we will move on to our lunch break. So we will continue after the lunch break at 2. Yeah, you will be back at 2. Yes.
For the lead, 1 or 2, while only 10% disease. How to move forward? There are just send send me an email. And I hope that Google Translator was correct to say that thank you for your kind attention. Bye-bye.
Thank you, Professor. So, ladies and gentlemen, now we will move on to our lunch break. So we will continue after the lunch break at 2. Yeah, you will be back at 2. Yes.
Hello? 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 Hello?
لا لا لا
لازم نغلقها باش
Is everyone here? Can we start? Est-ce qu'on peut commencer? Tout le monde est là? Welcome everyone again after this afternoon session. I hope everyone had a great lunch break. So, okay. So we'll start. We are going to carry on with the 177 LU 2022 AC DOTA RLT in advanced refractory monogamy. Okay, presented by Professor Majid Assadi from Iran. Thank you.
You see the slides here? Okay, waiting for the slide coming off. Okay. That's okay. Hello, everybody. I'm so happy to be here, and I'd like to thank organizing committee, especially Dr. Imad and Professor Akram for inviting me. Before I begin, I'd like to express my sincere respect to esteemed colleagues, mentors, and pioneers like Professor Abbas Alavi, who guiding us to be here and a lot of improvement in this field. What I'm going to cover today, I'd like to speak a bit about the molecular imaging on meningioma, then talk about radionuclide therapy, and also present our preliminary work on the combination of alpha and beta in this dilemma, and also touch such key aspect of this area, this field, such as neoisotope, bioconjugate, and dosimetry, and also the role of AI in this field. As we know, the meningioma is the most primary CNS tumor, accounting for about 37% of all primary CNS tumors. And the main management based on the surgery, then radiation treatment. And day by day, some predictive and prognostic biomarkers are such as genomics, proteomics, and a lot of omics under extensive investigation, and there is no longer solely based the old management, the pure based on the grading, grade 1, 2, or 3. Instead, the recent recognition of molecular features, there's some huge management, especially after the last revision on neuro-oncology field management in 2021, called CNS5, that huge breakthrough in the field of neuro-oncology has happened. For example, if we have a case with grade 1 meningioma with such mutation in the TERT, telomerase transcriptase, or CDK mutation, irrespective of histological morphology, categorized as grade 3 these days. this is why we should have the interdisciplinary molecular board in this emerging field. With this short overview, let's talk about the molecular imaging in this field. As we know, the current imaging field based on the CT and MR with different sequences with and without contrast. But there was many challenges in this regard, especially in the places of skull base, parasagittal, and also bone involvement, and also some post-operation changes. And we need some more improvement, molecular imaging, to come up with these challenges. And also we know about 60% of meningioma have somehow dural tail. That this is very important for treatment, for robust treatment, either surgery or radiation treatment, and to find the PTV, NTV, and GTV in this regard. Let's take a look at this image of our cases. For example, this small lesion, as illustrated here, we can easily find this in the PET MR or PET CT. This is so hard to find it on the pure MRI, even with contrast. The next important issue in the field of molecular imaging, we know there is no standard response criteria for meningioma yet. Why? Because this goes back to the nature of meningioma. We know that somehow there is pure calcified lesion, in radiology called burnout. How, if we have the expect to have the decreased size of this lesion on the MRI, on the structural imaging, beyond expectation of this calcified lesion. So even in the radiation treatment studies, somehow seen that about 20 up to 30% decrease in size of this lesion. So of course we need molecular imaging to help us and assess the before and after treatment, so to design the responsive or unresponsive cases. And till now, RANO work group, means radiation response assessment of neuro-oncology working group, proposed to use the growth rate of this tumor instead of decrease in size. I mean, the PFS at 6 months is a good endpoint for clinical trials. As illustrated in this case that treated our department with 5-cycle beta and alpha, this case with huge lesion in the right globe, proptosis, periorbital edema, and some pain after the treatment, some clinical benefit as well, and also decrease in SUV uptake, dropped to up to half, but we couldn't see any change in the size on MRI. So this issue highlights the role of molecular imaging in response assessment. The next important issue in this dilemma, in this challenging field, is the role of PET on follow-up imaging. As we know, the follow-up strategy based on the therapeutic response and tumor biology. And as our experience and some evidence in this field, we should postpone the post-treatment assessment using molecular imaging over than 2 months, not less than 2 months after the last treatment cycle. 3 or 4 months is okay. And of course, we need some prospective clinical trial in different times to find the best time assessment of the treatment in the line of precision medicine. Let's take a look 2 scenarios, our cases in department. For example, this case referred from the back time from my clinic to our department due to neuroendocrine tumor and received some cycle of PRRT, and she had a small meningioma in the liver vermis. After cycle,
After the 4th cycle, it decreased to 11 to 9. Recently came back after 6 years to department, and for recurrence of abdominal neuroendocrine lesion, and almost the lesion that already was in the previous vermis gone, and dropped to 1/4, to 2, this UV 2. So I like to highlight the valuable role of long-term follow-up using molecular imaging in the line of precision medicine. Contrast, unlike the previous case, this case was treated with 6 cycles of alpha and beta. This PET done only 1 month after the last cycle. Clearly seen that SUV increased 14 to 18, but without any treatment, after a few months later, again decreased to 12. So I want to highlight again on the role of molecular imaging even in the line of precision medicine, and continued our assessment either in clinically or imaging, even if the initial response appear weak. So hopefully ENM, joined with other societies, publish a practical guideline to some potential indication of gallium SSTRs for in terms of diagnosis, monitoring, and also recurrence. Let's move on to treatment. As we know, there is no standard management of progressive meningioma beyond the surgery or radiation treatment. And there are some trials in using the systemic treatment, I mean chemotherapy, immunotherapy, and compared to PRRT, hopefully the superiority for PRRT, as can see here, grade 1, the 6-month PFS 6 months for PRRT was about 94%, as compared to 29% for systemic treatment. Till now, based on the small case series, small retrospective studies, that totally is about 256 cases till now about this. The most of them show the stable disease. I mean, using a lot of radiotracer just emitting beta. And most of them show some stable disease. Like this case in our department with a young lady that is stable for over than 5 years with huge CP angle meningioma. Only got some PRRT lutetium dotatate. And also we are waiting for the large multi-center clinical trial. As we know, the major clinical trial, as we know, Lumen 1 and Momentum 1, 2 major clinical trials that working only on lutetium 177 dotatate. We are waiting for them. So this is why try to use the alpha in addition to beta to have and use both of them, keep advantages of both alpha and beta emitters, actinium-225 and lutetium 177. And data, there is no previous report in using the alpha in meningioma yet. But hopefully, due to the BNCT, we know the BNCT in the technology of boron neutron capture therapy, the alpha particle generated inside the body. We know that after the bombardment of boron 10 by neutron inside the body, the alpha particle generated. And there are some, till now, 66 cases of meningioma treated, show some even
complete response in this regard. So this is good news for using of alpha. And we designed a study, till now 7 cases included, and 5 of them had at least 2 lesions, most of them had multiple meningioma as a big dilemma. And till now, 17 cycle of lutetium and 13 cycle of actinium. And those sequences about 3.7 up to 7.4 gigabecquerel lutetium next to the 100 kilobecquerel per kg in interval 6 to 8 weeks they receive. 6 cases show somehow response. I mean in terms of clinical benefit and molecular imaging, or an MRI. And also just 1 case saw progression, and finally after 8 months after the first cycle, progress and die, unfortunately. And in this study as an endpoint, as already said, the 6-month PFS met the Rano criteria and was about 85.70%. And also our colleague tried to have quantify this assessment by different items using the gallium dotatate PET, somatostatin receptor expression, tumor volume, which is very good because all tumor check. In addition, total lesion somatostatin receptor. Both are significant in these cases. Let's take a look at the first case. For example, the case 51 years old man, grade 3, progressed even after radiation treatment and surgery, referred to our department. And this case show complete response in 1 word build up the case. And as clearly seen, decreased in SUV and also size, and also clinical benefit. The most important question in nuclear medicine field is this using of this drug, radiotracer, anything in oncology field, useful, and does it translate to clinical? This is the main question in oncology. In this case, yes. The answer is yes. And even after the few months after the maybe 7 months after the post treatment, even after that, in follow-up, maybe a few months later, without any treatment, you can see the continued treatment without any treatment more. So I like to highlight the role of continued assessment, long-term assessment with PET. Next, take a look at this case with multiple meningioma. I think at least 6 lesions. This is a big dilemma. The oncologist, radiotherapist, neurosurgeon don't know this symptom of this case with multiple meningioma. They don't know how to correlate the symptoms with the lesions, with the location, with the size. This is a big dilemma in multiple meningioma. So this is why nuclear medicine can act in these cases, multiple meningioma. For example, at the largest one, at first, the SUV 158. After the 4th cycle, dropped to half, 62.75. As already mentioned in my talk, that PET could be a predictive value biomarker too. As you can see, there is the significant difference between SUV of responsive as compared to only 1 unresponsive cases. This is 9 in unresponsive case, and the minimum one in the responsive case was about 2.5. the maximum 158. Okay, let's talk about some key aspect in emerging some progress in the field of meningioma parallel to neuroendocrine tumor too, I think. For example, there is some improvement and increased dose, tumoral absorbed dose in administration of intraarterial as compared to systemic. There is some conflicting result, even in neuroendocrine tumor. So there's some debate here. And also combination therapy, maybe in future, maybe we succeed in neuroendocrine tumor, comes to meningioma as well. And also use dosimetry that we perform dosimetry on department 2, I show on my next slide. And also neo-isotope for imaging and treatment, and use AI. For example, in dosimetry, the main lack of the many studies, based on the literature, the tumoral absorbed dose in meningioma totally less than neuroendocrine tumor, due to maybe fast washout in the meningioma as compared to neuroendocrine tumor. But we know that it's based on the pre-treatment SUV. For example, in this case, with multiple meningioma, with the largest lesion in this case, with SUV 158, we could have a good image even with alpha. This is why work and talk only this case. It's so hard to have a post-imaging with alpha, but we could have a good imaging even after the actinium administration, and also the tumoral absorbed dose was for with actinium dotatate was 3.36 gray per MBQ megabecquerel, while for beta was 2.37 gray per gigabecquerel. So in the same range of neuroendocrine tumor. This is why, because good uptake on SUV in pre-treatment study. The next important issue in our field, talking about the tandem combination like this every field, here meningioma. There are very few studies on the role of the microdistribution of each tracer when administered. For example, administered lutetium with actinium at the same time, tandem treatment. There is very few studies. The red one represents the ligand attached to the target only using beta, but the red one presents the actinium. Although we can see the huge, the good overlap between alpha and beta in even use same molecule, same target, but there is not fully identical while using the alpha and beta in the same target. Same to this issue, in line of this issue, our colleague performed this main important issue, and as can clearly seen, there is very good overlap between alpha and beta in this case too. Based on a lot of studies on neuroendocrine tumor, as we know, there is the huge inter-patient heterogeneity in the case of neuroendocrine tumor. Based on this study, up to 320 difference between the tumor absorbed dose across the lesions in the patients. In the line of this, we performed this issue in our case with 6 lesions, and we found that there is intra-patient, inter-lesion, intra-patient, up to 118 for beta emitters for lutetium and 33 for actinium between lesions. And so nuclear medicine can act as a lesion-based therapeutic concept. I mean, in nuclear medicine, we can act each lesion as a unique and individualized treatment. For example, in this case, with 6 lesions, we can easily perform each lesion for themselves, not totally like other fields. For example, we can different results for different lesions. And it may help us to candidate each lesion for each treatment, a specific treatment. I mean, lesion with lower SUV uptake on pre-treatment SUV dotatate, it could be useful for other kind of treatment, not for PRRT and somehow radionuclide therapy. Maybe good candidate for radiation treatment, immunotherapy, chemotherapy, other kind of treatment. So it's time to change to the work as a unique individual as in the line of precision medicine. The next important issue, we are searching and working department for different targets, like in addition to SSTR, in addition to somatostatin, working on FAPI, most exciting things in nuclear medicine these days, and also SSTR antagonists, we did LM3, although rising a star in this field, but still gallium dotatate king in this region. The next important issue, there is a good radioisotope Cu64 next to Cu67 as a good theranostic pair. As we know, this is Cu64, have a good half-life, about 12 hours. It would be a good option for radio-guided surgery, as clearly seen in this figure. Injected before treatment, you can see the small focus of remaining tissue after surgery. How possible to detect this small lesion with anatomical imaging, even with different sequences? Let's use the AI. Based on this issue, I talk here, as we know, different genomics, proteomics, a lot of data, which age, sex, a lot of data taken together. We ask our colleague, AI colleague in the department, to develop a platform to use this for us, to ask it to find the best treatment, best approach, best prognostic, predictive value in this platform to help us to answer the question for everybody. Although we are in the beginning of this phase, hopefully very soon try to will public it for using all over the world to use this platform in meningioma. Let's conclude my talk. As we know, there is very good results on using the SS-targeted theranostics in the field of meningioma. As I emphasized during my presentation on using of theranostic placenta instead of pure theranostic, and we need to get some more answer from the future perspective, the better combination treatment, optimal timing, sequencing, and like this. And I like to share that our group are invited from Nature Oncology to write a paper, and hopefully our paper will be published in a few months later. I share with you including all things, all parts of the meningioma, but the much more field of theranostic and field of nuclear medicine society. So I like to thank all of you by thanking committee, Algerian Nuclear Medicine Society, colleagues, and thank you for everything. I'm so happy to answer the question.
Thank you, Professor. Thank you. Now we'll be moving on to the next speaker with his presentation about the RLT 2025 AC 213 BI DOTA, the substance in glioblastoma, presented by Dr. Habibullah Dadgar. from Iran. So I understand that there is a lot of information on each presentation, and it's really, really meaningful and priceless, but we actually have to respect the timeline of the presentation so we could have more time for other speakers. Thank you all.
Yeah, thank you so much. Hi, everyone. Thank you so much for joining me today. My name is Haibal Dalga. I'm a nuclear medicine physicist with the closing clinical trials, especially with Professor Majid, is my mentor in Iran. And I'm so happy to be here to talk about the initial experience with the target alpha radionuclide therapy with actinium bismuth substance in patients with gliomas. I think it's a time for the brain imaging and brain treatments beyond the lutetium PSMA for prostate and 2 days circulating. Yes. So in recent years, there have been numerous studies investigating the treatment for target alpha treatment for various cancers, including the prostate cancer, glioblastoma, and also the leukemia. For example, the studies on actinium PSMA for prostate cancer shows that the promising results, as you showed previously. And the research on the PubMed and other scientific databases uses the term of the thought, yields hundreds of thousands of publications. And as you can see here, this is our recent publication, Theranostics, that focus on the physics, biology, and also the internal dosimetry for the lutetium and actinium in neuroendocrine tumors and prostate cancer, on the supervision of Professor Assadi and also the Habib Zaidi from Switzerland. And the next one is the current status of Theranostics on the supervision of Professor Akram. It's my pleasure to participate in this great investigation. Such for the basic principles for alpha radiation, I should tell you that it consists of the alpha particles, which are essentially helium nuclei, and low penetration power can be stopped by a sheet of paper of a few centimeters or air. And also the highly ionizing, meaning it can cause a significant damage to cells. For the beta radiation, composed of beta particles, which are high energy electrons or positrons, and the moderate penetration power can be stopped by a few millimeters of aluminum plastic. Moreover, they're less ionizing than the alpha radiation, but more penetrating. For the gamma radiation, which are the photons with a high energy and no mass or charge, and the high penetration power requires the dense materials like the lead of several centimeters of concrete to attenuate. So less ionizing, but highly penetration, making it dangerous for external exposure. And this is also the key differences between the three radiations, the penetrating power, the ionizing ability, and also the shielding requirements for them. Alpha-emitting radionuclides have a short range around less than 100 micrometer and a high LET around the 100 kiloelectron-volt per micrometer in human tissues. And TOT can deliver a highly toxic dose to the target cells while minimizing the damage to the surrounding tissue, healthy tissues. And cell death induced by the alpha radiation is predominantly due to the DNA double-strand breaks along the densely ionizing particle trajectory. So the biological effects of radiation is largely independent of cell cycle phase and cell oxygenation status. This gives the TOTs the potential to treat the tumors which have occurred, the resistance of for the other radiation treatment, including the hypoxic tumors. So the alpha radiation is able to overcome the resistance to chemotherapy drugs. So TOT might be used as a salvage therapy in patients with recurrent disease, might be included immediately after the diagnosis of recurrence, and might be used as an adjuvant therapy immediately after the end of the standard treatment, or maybe used as a no adjuvant treatment before the surgery. So alpha particle emitters, such as the actinium and also the bismuth-213, are conjugated to targeting agents, antibodies, peptides, and also the small molecules. And these agents bind specifically to receptors or antigen overexpressed on the cancer cells. And once binding has happened, the radionuclide decays, emitting the higher energy alpha particles around the 4 to 9 mega electron volts. And alpha particles also have a short range in tissue around the 50 to 100 micrometer, ensuring the localized damage to the cells. Alpha particles cause double-strand breaks in DNA due to their high LET, and this damage is difficult to repair, leading to cell death. So we have two effects of the thoughts for the cancer cells. The direct effects, I showed a brief talk to you. The alpha particles directly interact with DNA of cancer cells, and they cause the double-stranded breaks, which are highly lethal and difficult for cells to repair, and they lead to the cell death, apoptosis, and necrosis. And also, alpha particles deposit a large amount of energy through the short distance with high LT, and this results in dense ionizing along their path, causing the several localization of damage. As an indirect effect, the alpha particles ionize the water molecules in the cells, generating the reactive oxygen species such as the hydroxyl radicals, and always further damage the DNA, proteins, and cell membranes, amplifying the therapeutic effect. Nearby cells, it's very important, it's very great for me to research about the biology after the treatment, what happened for the DNA. This is very important. The nearby the cells, even those not directly hit by the alpha particles, are affected due to two things: the signaling molecules released by the dying cells, and always spreading to adjacent cells. This enhance the overall anti-cancer effect. That's meant and called the bystander effect. And the second one, the alpha radiation can trigger an immune response by releasing the tumor antigens from the dying cells. Very impressive. And this may help the immune system recognize and attack the remaining cancer cells. It's called the abscopal effect for a treatment. And this is the, as you can see here, this is the decay chain of actinium-225 with the half-life around 10 days. And after the emission for decay, it goes to the half-life with the bismuth-213 with the half-life of 46 minutes. And this is starting for the GBM treatment. GBM is the most common primary malignant brain tumor, which constitutes 12 to 50% of intracranial tumors. And GBM is primarily proliferative and invasive, display the high aberrant vascularization, and is resistant to traditional radio and chemotherapy regimes. So despite decades of research outcome for brain tumors, patients have only improved marginally. So better treatments for brain cancers are a pressing need. Among the scarce number of alpha emitters suitable for application in cancer treatment, the generation-derived nuclide pair alpha-225, actinium-225, and also the bismuth-213 has emerged as particularly promising. So the actinium is a pure alpha emitter with a half-life 10 days, and it's a relatively long half-life, and the multiple phase particles generated in the rapid decay chain render the actinium-225 as a particularly cytotoxic nuclide. And bismuth-213 is a mixed alpha and beta emitter with a half-life of 46 minutes, and it's mainly decay via the beta emission to the ultra short-lived. And the challenges in glioma treatment is intratumoral and tumor microenvironment heterogeneity, and also the blood-brain barrier and also the glioblastoma stem cells are barrier against the effective therapeutic strategies for glioblastoma multiforme. They also confirm the resistance to drugs and may obstruct proper drug delivery to the brain tumors. As a standard therapy, the first step is a surgical removal as much as of the tumor as possible without the damaging the critical brain tissues. And also, the aim is reduce the tumor burden and relieve the symptoms. And the second one, after the post-surgery, patients undergo the fractionation EBRT. And the goal is to target residual tumor cells and delay the recurrence. During the radiation, patients receive the temozolomide for enhancing the effectiveness of radiation. And after that, after completion of radiation, patients continue temozolomide maybe to 1 year for suppressing the tumor growth. And finally, for the suppurative care, included the corticosteroid, such as the dexamethasone to reduce the swelling for these patients, for improving the quality of life and also to manage symptoms. Classical radiotherapy and conformal radiotherapy is limited to maximum dose of around 60 gray applied in daily 2 gray fractionation for that as recommended by the RTOG. And the additional temozolomide radiotherapy led to a mean survival of around 15 months as compared to 12 months with radiotherapy alone. So, however, this more aggressive combination of therapy has some limitation, such as the severe fatigue and thromboembolic events. So, as you can see, this is a very nice picture for me because the longest delay in tumor growth was observed in the normal fractionation and also in the moderate fractionation compared to the high dose. The flash radiotherapy is one fractionation of the high dose more than the 10 grade to the tumor cells. And this one activates the CD8 plus T cells, regulated T cells, to overexpress, and also the leave of the TIGIT when expressed to the dose of the normal fractionation, while the dose of the normal fractionation result in decrease of the TIGIT. So it means that the radiotherapy was significantly more effective when administered at a dose of 3 multiplied the 8th grade compared to the older side. This is our investigation that's published recently in the Academic Radiology, and thank you so much from Professor Assadi and also Habib to participate in this amazing research for chemical receptors to find the margins from the tumors from the glioblastoma multiforme. And while the magnetic imaging MRI remains the gold standard for the GBM imaging, its ability to differentiate the tumor tissue and tumor-induced changes on the cellular level is insufficient. So we focus on the 29 patients for CXCR4 receptor, as the Professor Lopsi talked about the thyroid cancer treatment and also the imaging from the CXCR4 receptor yesterday. And we started the collaboration with the Medical University of Essen from Germany, and it's very interesting for us to collaborate with the Razavi Hospital and Busher Medical of Medical Science under supervision of Professor Assadi to focus on the voxel-wise dosimetry and also the radiomix analysis for finding the details from the brain tumors and finding the margins for starting the maybe the radiotherapy, radiotherapy, or theranostics. But for CXCR4 positive glioblastomas or metastases that are unresectable or refractory to standard therapies, the lutetium pentixate offer theranostic options paired with the gallium pentixate-4 for patient selection. Actually, we have 2 patients that passed away, unfortunately, after the 2 doses of lutetium pentixate because they was in the last stage of the disease, and it's not working for these patients. Regarding to the neurological side effects, why the injection, IV injection of lutetium pentixate, I will be show you how we can overcome to these opportunities. So the cerebral edema, and seizure, and cognitive or motor dysfunction was happening for these patients. The another thing is the hematological side effects. Maybe the more effective for the bone marrow suppression, anemia and thrombocytopenia, and also the leukopenia for these patients happened, and unfortunately they pass away. To overcome for these limitations for the IV injection to the patients and cytotoxic for this patient, the local regional treatment is recommended. Local regional injection of radiotracer in GBM is an imaging approach for diagnosis, targeted radiotherapy, and real-time tumor monitoring. These techniques deliver the radioactive agents directly into the tumor resection cavity, and also improving the precision while minimizing the systemic toxicity. So we have 2 choices: the intra-arterial delivery, the super selective radiotracer injected in tumor-feeding arteries, such as the yttrium-19 for the GBM. And also the intratumoral and intraactivity injection during the surgery, and also the connection enhanced delivery CED that I showed you what happened for these patients. The advantage over the system delivery is a higher tumor concentration, the lower systemic toxicity is very important, I think. And also the bypass the blood-brain barrier and real-time monitoring via the pattern SPECT imaging and potential synergy with the immunotherapy. And the challenges and limitations for this section is infiltrative tumor regions and also the radiation necrosis risk at the high doses and heterogeneous uptake due to the GBM's variable biology and regulatory hardness of novel radiotracers. As I told you before, this is CED is a technique designed to improve the distribution of therapeutic agents within the brain tumors with using the continuous lower pressure infusion to bypass the blood-brain barrier to overcome the diffusion limitations. So an increased intratumoral pressure may contract local drug distribution, and specific preparations have to done to control the pressure levels, such as the intravenous administration of an osmodiuretic drug and insertion of the more than one part on a CAS system. It means that the CAD is a promising but technically challenging approach for GBM, offering the better drug distribution than the passive injections. And as you know, there is many receptors that focus on the brain imaging, especially to GBM. There's a EGFR and also the integrins, alpha B beta 3, and PD-L1, somatostatin receptors, FAP, and also the VEGF. Sorry. How can I back? Okay. Meanwhile, the neurokinin type 1 receptors appear to be extensively expressed on the cell surface of gliomas. It's good news. The major physiological ligands for the NCAR1 is a tachykine neurotransmitter family member known as a substance P. When the ligand, such as a substance P, binds to the NCAR1, a change in the subunit of the receptor occurs with the start of the signaling cascade, such as the P13-AKT and other pathways, and these pathways also lead to activation of the gene transcription, coding for proliferation and survival and invasion of also effects. NCAR expression found in GBM cells, endothelial cells, and macrophages, and promote all the proliferation, survival, and migration, and enhances the angiogenesis and modulate the immune suppression. And native substance P, this target is metabolically unstable. So for exchange of the amino acids to increase its stability is very important to focus on the stressors as well. And autoradiography discloses a very high prevalence of increased expression of NCAR1 in GBM cells, regardless of the degree of malignancies. So as I told you before, for the local regional application of substance, we have two options. The intracavity injection, the target of this injection is administered into the surgical resection cavity after the tumor debulking, and purpose are to treat residual infiltrative tumor cells at the cavity margins and reduce the local radius by recurrence by delivering the radiation radiotracers to the tumor-brain interface. And also the advantage of this injection is the wider distribution along the resection walls and lower risk of the direct brain injury compared to the intratumoral injection in unresected tumors. And the challenges also exist about the heterogeneous drug penetration into the surrounding brain tissues, risk of the leakage into CSF. And I showed you what happened after the leakage of this to the CSF. And another type is the intratumoral injection is a different. The target is directly injection into the unresected tumor mass, and the purpose is to maximize the local radiation dose while sparing the healthy tissues, and potential for the CAD, as I told you before, to improve the distribution. And the advantage is the high local concentration within the tumor and bypass the blood-brain barrier. So the challenges exist in this type also. The limited diffusion in GBM's dense hypoxic microenvironment and risk of the backflow along the needle track and inhomogeneous distribution in infiltrative tumor regions. So this is the first investigation using the yttrium-19 for the first time in 2010 by the Courier et al. That used this tracer as well. As you can see here, the pointer is working. Yes. They use the dose distribution with the spexity here. You can see the peritherapeutic intratumoral train injection, and the B shows that the contrast enhancement post-operative CT scan, and also the C show the in-block removal of the GBM after the internal decompression. The 3 catheters, as you can see here, exist. The system have been left in the cyto as anatomical landmarks. So the resection of the tumors was remarkably facilitated after the microsurgical dissection. Figure C, you can see in this, and then the conventional glioma surgery. And intraoperative operative bleeding was also found to be markedly reduced, most probably resulting from the fact that the tumor cells attach and also they grow along the vascular structures, which are effectively irradiated by the so-called crossfire effect that you know about the beta particle emitting radionuclides. However, this tissue range of the yttrium-90 with the resulting crossfire effect potentially damage the adjacent the brain areas. So alternatively, the alpha particles emitting radionuclides may be powerful candidates for that, such as the bismuth-213, as an example, has the mean tissue range of only 81 micrometer with a high energy of 5.8 megaelectron volt, allowing a highly cytotoxic radiation dose to the delivered to the target cells, while sparing the adjacent brain tissues. So, from the, another study for these guys from the Cordier et al. Groups, catheters connected to the subcutaneous port prepared for the multiple punctures were implanted into the post-surgical cavity strategically or intratumorally, and 2 to 4 weeks before the treatment. And to confirm the proper catheter position and to exclude the connection with the vertical or system CSF system, to local test injection into the port system was performed using the gadolinium contrast enhancement MRI before the treatment. A critical point in the local administration is the control of the injection procedures to achieve the maximum intratumoral biodistribution, saturating in not only the nodal tumor components, but also those gliomas cells invading the adjacent normal brain tissues. And this is the great image that shows that putting the catheters inside the tumor, and this is a gallium PET-CT examination 30 minutes after the injection of bismuth dotted substance P. It's very impressive, I think, and the background of the whole of the body is 0, I think, because it's an intratumoral injection just on the tumor site. And whole body scan shows distribution 30 minutes after the injection of 10 megabecquerel only. It's very good news because the toxicity for the cancer cells is high and for the surrounding tissues is very low. And the signal detected in the body outside the brain is very faint and or negligible in liver, kidneys, spleen, and bone marrow. The bladder shows the big signal corresponding less than 5% to the injected activity. And this is a nice case, and I followed this group because they work very nice. An intratumorally injection for this group around the 50 millicurie of bismuth-213 substance V, as you can see here in the left image. It is the initial imaging before the cytotoxic biopsy and catheter placement. And the second one in the C and D, you can see the 2 weeks after the intratumoral bismuth injection. And the third one is the 6 weeks after the injection. Noted that the lesion appears more compact with the less edema. And also the next imaging is around after the resection of the tumor. And the next one is 6 months after the resection without the evidence of residual or recurrence. And after 1 year, you can see anything on the brain. It's a good news, I think, or the glioblastoma multiforme treatments. In Iran, unfortunately, physicians don't like to focus on brain. Just Professor Assadi, I remember in my mind, because in our hospital, the physicians, go ahead. No, it's the GBM. No, it's very hard for me to image, to treat. So go ahead and go to the Professor Assadi to decide for these cases. So whole of the case from Iran, I think, goes to the Professor Assadi in the south of Iran, and it's my pleasure to have the student for him. And the current status for these patients, 8 years after the initial diagnosis with no symptoms, no residual disease, and detectable, and also the no toxicity is a good news for the GBM treatment. And this is another case in 2018 that shows that the application of bismuth gallium together to inject to the patients in the same time by the butterfly catheter. And in this case, as you can see here in the left side, in 2040 is it started, and as a baseline, and after that, after the injection, the first injection, you can see the MRI image, and after the following, you can see anything on the brain. This was a good news also. So, the actinium or bismuth analogs for glioblastoma treatment. Short half-life of the bismuth 213 can limit the optimal distribution of the tracer in larger tumors. So a radioisotope with a larger long half-life might be preferred. The actinium-225 with a half-life of 10 days can improve the distribution radiopharmaceutical within the tumor. So it's a replace to the bismuth. So I will show again here. It's very slides. I like it because it shows that the adverse events of the bismuth versus the actinium substance P in these patients as well. For the bismuth dotatate substance P, the literature shows that the 4 of 20 patients in their study experienced in the slight facial flushing, a systemic side effect caused by the minor tracer absorption in the blood, and also in 2 patients a transient worsening of the paresis and also the aphasia for 5 days. And for the actinium sp, the additional hematological liver and kidney and toxicity was measured, and epileptic seizures were observed at 2 to 5 days in 4 patients, and also 6 patients revealed the worsening of hemiparesis or aphasia, and also in 2 patients 2 and 3 weeks after the treatment with the 30 megabacterial several prefocal brain edema was shown. So, for the survival parameters compared to tracers, the injected activity approximately for the bismuth dotatate substance P was the 1.85 gigabecquerel per cycle, but for the actinium dotatate in a dose escalation schemes, an activity of only 10 megabecquerel, followed by the 20 to 30 megabecquerel was approved. So it means that the radiotoxicity for the brain tumors is a local, very nice, but in the surrounding tissues is very low. So it's very nice for the treatment of the patients. So it was no statistically significant differences between the patients group treated with the bismuth DOTA substance P and that treated with the actinium substance P for both primary and secondary GBM, as you can see here in these tables. So the longer half-life of the actinium, 2 to 5, by the distribution of actinium to the tumor, and also the alpha decay instead of 1 decay for actinium 2 to 5 increased the deposit energy by the factor 4 for the improving the outcomes. So the partial dislocation of the daughter nuclei of decade of actinium 2 to 5 decreases the therapeutic efficacy. It is our case. Thank you so much from the Professor Majid to help us. It is a case from the center of the Professor Majid. That is a 65-year-old female with a history of surgery for low-grade gliomas referred for the peptide receptor radionuclide therapy, underwent the gallium dotatate. You can see here in A and B. And the pre-treatment gallium dotatate revealed 2 avid lesions in the left posterior ventricular blue row, and also the another side, so you can see here. And also the following treatment with the 5 cycle of lutetium dotatate, you can see in the C and D, and also the 2 cycles actinium in the E and F, you can see in the middle, I think, is actinium dotatate after the treatment. And it's the follow-up the gallium PET-CT in the G and H, you can see, and shows the mixed response. You can see that the one lesion exists right now, but another lesion is removed but it's an initial experience, thanks to Majid. And, we are starting right now to the alpha treatment with under supervision of Professor Majid. It's just the Boucher University of Medical Science to support the whole of the GBM treatment and thrombosis, and Majid is a pioneer of the thrombosis in Iran as well. So it's very important because I'm a medical physicist, I'm not a clinician, so sorry for my talk about the clinical cases, but here is my, a specialty for dosimetry of targeted electrotropy with actinium-225. And actual dosimetry for actinium remains a challenging due to the complex decay change emitting for alpha particles, a heterogeneous derived dispersion, and also need for the precise quantification of absorbed doses in the tumor versus the critical structures. And also we have the result studies in GBM has explored the actinium agents with the image-based dosimetry. It's very interesting for the SPECT and PET imaging and full Monte Carlo simulation. Yes, thank you so much from the Habib, from the AI, and also group from the Geneva University Hospital is my mentor again for the AI and other things. So because I know the time is limited for me, so I go ahead. Yeah. The first step in calculating the absorbed dose in TOTS is the quantitative imaging of the radiopharmaceutical distribution in the patient's body from the energy spectrum registered by the gamma camera. Two principal gamma emissions around the 218 kiloelectron volts and 440 kiloelectron volts exist along the British-Mistral X-ray from the PB209 and May scattering photons are observed. And this is the studies that focus and research on the energy windows for putting on and accepted in for the gamma cameras. But after doing that, the results is the final section is the 82 kiloelectron volts and also 260 and 444 is a 3 windows, scattering windows for imaging. I think it's better for the alpha diagnosis after the thronostics injection. And I short it because this is a phantom study for concentration before doing the dosimetry for these patients and putting the spexity acquisition and reconstruction because we have the Siemens healthcare system, the single wheel, and we focus on the spexity acquisition and we put the windows and primary and also the low scatter windows for these assessments. And this is the collimator that we used, and also the matrix, voxel size, and number of projections, and also the number of subsets, iterations, and goes on. And it's used just for our study as well. And before the injection to the patients, we use the image, the calibration factors for the actinium-225, and also we put the recovery coefficients for our system again. So thank you so much, but it is a good news for us. We publish right now the target alpha treatment, the terbium-161 FAP-2286 as the first investigation in this non-small cell lung cancer with the Professor Majid Asadi, and also the guys from the Indian Society of Nuclear Medicine. And fortunately, it's give the best prognostic award, and we do the dosimetry and also the whole of the, the assessment of the statistics analysis. We do it with the collaboration in other countries, and our mission is also come here, and thank you so much, Dr. Emad, and also the other investigations and the committee that invited us here as a first time in the beautiful country and beautiful, and also the kindness of the people. And the last things is using the terbium-16 FAP maybe in the soonest future for treatment glioblastoma multiforme under supervision of Majid in the soonest future. And thank you so much for your time. I'm so sorry because the lunch is so heavy and I'm so thank you so much. And I'm ready for any question. I am at your disposal. Thank you so much. My voice is so high. I think after the lunch, my voice is increased. Because I'm sleeping right now. Okay. Any question? I'm disposed. No? Okay.
actually going to leave the question afterwards.
Afterwards, okay, thank you.
Thank you so much. Move on to our next session, radiation protection in the era of theranostics. Starting off with Mr. Shinofi, who will be presenting theranostics ethical challenges and legal framework.
Mesdames, Messieurs, bonjour. Dans le cadre de cette présentation, radioprotection, on essaiera de changer complètement de cap. Nous ne sommes pas dans les chiffres et les cellules, les pénétrations des médicaments, mais c'est dans le cadre radioprotection et notre occasion de rappeler encore une fois l'innovation et les techniques innovantes en matière de médecine nucléaire. Ça nécessite l'utilisation des sources de rayonnement ionisant et de notre devoir de rappeler à chaque occasion qu'il y a un dispositif réglementaire qu'il faut respecter, qu'il faut appliquer, qu'il faut observer. Oui, pour les techniques, les nouvelles techniques, mais c'est-à-dire le souci de protection et le souci de radioprotection demeure majeur par rapport au développement de ces techniques. C'est pourquoi, dans le cadre de ce séminaire, et en premier lieu, je remercie l'Association de médecine nucléaire de faire appel à l'Autorité nationale de sûreté et sécurité nucléaire pour participer à cette importante rencontre dans le cadre de développement des techniques et d'utilisation des sources de rayonnement ionisant dans le cadre médical. Et c'est pourquoi, maintenant, en termes de theranostics, quel est le cadre réglementaire? Qu'est-ce qu'on doit essayer d'appliquer? Les dispositifs réglementaires, les règles de radioprotection, les règles de sûreté, l'utilisation, etc. Et qu'en est-il du développement de cette technique dans notre système juridique? C'est pourquoi je vais dire que tout simplement, brièvement, concernant le développement d'un cadre réglementaire de la theranostics repose principalement sur la réglementation des activités nucléaires, donc la médecine nucléaire, qui nécessite un régime réglementaire. Le régime réglementaire, auparavant, il est basé sur deux aspects en matière de médecine nucléaire. Il y avait des techniques en termes de diagnostic, qui soumet un régime d'autorisation, et par la suite, le développement vers les techniques thérapeutiques, qui nécessitent également un régime réglementaire, et maintenant l'association des deux techniques en une seule technique, qu'en est-il du cadre réglementaire? Et quel est le développement en matière de radioprotection, particulièrement concernant les conditions de production, les conditions d'utilisation, les conditions de préparation, les conditions qui nécessitent hospitalisation et quelles sont les règles de radioprotection qu'on aura toujours l'occasion de rappeler à chaque événement et à chaque occasion. Donc, le cadre réglementaire applicable, c'est quoi? La réglementation relative aux activités nucléaires, il y a lieu de rappeler à chaque occasion, car l'utilisation des substances radioactives, ça reste exceptionnel, c'est-à-dire s'il n'y a pas d'autres techniques, on fait appel à des sources de rayonnement ionisant. Si on fait appel à l'utilisation des sources de rayonnement ionisant, donc il y a une certaine règle qu'il faut observer, notamment en médecine nucléaire. Tout ce qui concerne les règles de radioprotection, protection du personnel et du public, conformité radiologique des installations, et un regard particulier sur les formations et les qualifications requises. Et bien sûr, on parle aussi de tout ce qui concerne la sécurité des patients et bien sûr, enfin, gestion des déchets. Donc, autorisation, c'est le régime d'autorisation. Donc, nous avons le diagnostic et nous avons le traitement. Et la question qui se pose maintenant en termes d'utilisation. Qu'en est-il pour avoir les autorisations nécessaires pour une telle technique? Une technique qui fait appel au diagnostic et en même temps au traitement. Et là, la question que se pose, quelles sont les normes qu'on devrait observer et appliquer? Ça commence par la préparation elle-même du radioisotope. Et juridiquement parlant, on parle de médicaments radiopharmaceutiques. Et il y a des conditions qu'il faut respecter, qu'il faut appliquer en matière de préparation. Et par la suite, on ne sont plus en termes de diagnostic classique, mais on va aller directement vers le traitement. Et si on va vers le traitement, là, on change de cadre juridique. Est-ce qu'il s'agit des installations qui sont autorisé pour le diagnostic et en même temps pour le traitement? Est-ce qu'il y a des conditions particulières uniquement pour les conditions uniquement de diagnostic? Et c'est pourquoi, aujourd'hui, on ne peut pas parler dans notre système juridique actuel, en attendant le renforcement des capacités en matière de cadre juridique et réglementaire. Aujourd'hui, on ne peut pas dire qu'il y a des dispositions réglementaires qui nécessitent, c'est-à-dire dédiées à cette technique en médecine nucléaire. Mais, en parallèle, il y a un cadre réglementaire auparavant qui est existant, donc si ça nécessite le développement et la mise à jour, et c'est pourquoi le développement des techniques fait appel aussi pour renforcement et pour les capacités du point de vue réglementaire, notamment en matière des normes, et c'est pourquoi il y a un régime qui concerne les autorisations en matière de diagnostic et les autorisations en matière de traitement. Et la question qui se pose maintenant, en termes de diagnostic, on fait appel au diagnostic, tout ce qui concerne, c'est-à-dire les normes de référence. Et puisqu'on parle maintenant, on bascule directement vers le traitement, là, ça nécessite un travail technicien, médecin et les radioprotections aussi pour la mise à niveau de les normes en matière de protection et particulièrement le rôle que joue le physicien dans le cadre de sa préparation et dans le cadre de traitement dédié, quand il s'agit de traitement ciblé. C'est pourquoi cette technique fait appel au renforcement des capacités en matière de radioprotection et en termes de référence. Le plus important, c'est en termes de référence qu'il faut prendre en considération. Maintenant, on fait appel à des radiopharmaceutiques. Donc, aujourd'hui aussi, dans notre système, on parle de la production. Bonne chose pour nous. Et on parle aussi de la préparation. Et qui est chargé de cette préparation? Quel est son rôle? Et par la suite aussi l'admission et les conditions d'hospitalisation. Dans d'autres systèmes juridiques, on parle aussi des systèmes d'autorisation en termes de quelle est la classification de l'unité c'est-à-dire de traitement. Et il s'agit d'une unité de traitement qui peut faire, c'est-à-dire l'ensemble des techniques. C'est là les capacités techniques, c'est là les conditions, notamment en matière de sécurité des patients, et notamment c'est-à-dire pour préparation en cas de rupture, en cas c'est-à-dire de continuité dans le traitement. C'est pourquoi les capacités qu'on devrait vérifier en amont, avant l'autorisation réglementaire, reposent sur des normes de sûreté et de radioprotection bien définies. Donc, le dispositif médical, outil d'imagerie ou de délivrance, conformité radiologique. Donc, ça nécessite aussi de vérification avant d'admission et avant traitement. Et c'est pourquoi c'est une autorisation qui devrait être basée sur des normes bien établies, bien définies, et là, dans le cas de la protection et la nécessité pour l'admission des patients. Alors, assurer que l'exposition des rayonnements ionisants liés au traitement et aux procédures médicales soit délivrée conformément aux normes de radioprotection et dans les conditions optimales. Et là, la question qui se pose, si on parle des conditions optimales, ceci nécessite le renforcement. Et ceci aussi, on devrait faire appel à l'ensemble des praticiens, des médecins, ceux qui sont chargés de la radioprotection, c'est pour améliorer les conditions en matière de protection. Et bien sûr, parce que le but recherché dans le développement des techniques, c'est-à-dire c'est d'arriver à des niveaux de traitement rapides et des traitements efficaces. Mais en parallèle, l'équation nécessite la mise en place de tout ce qui est dispositif de radioprotection. C'est pourquoi les niveaux de référence, à chaque fois je vous rappelle sur ça, et qui est très important au niveau national, qui est basé bien sûr sur les recommandations, ce qui est développé dans le cadre international. Mais au niveau national, on devrait avoir ce niveau de référence dans le cadre des diagnostics, notamment en médecine nucléaire, pour amélioration et l'efficacité du traitement proposé par ces unités. La responsabilité, parce qu'on parle de production, on parle de préparation, on parle de médicaments radiopharmaceutiques, on parle aussi des prescripteurs, on parle des médecins, etc. La réglementation aussi, l'un des objectifs, c'est-à-dire de déterminer et de donner exactement quel est le rôle de chacun, qu'est-ce qu'il doit faire et la limite de responsabilité de chaque intervenant dans le cadre du développement de ces techniques. C'est pourquoi aussi, diagnostic, traitement, unité de médecine nucléaire, les conditions, quel est le rôle de chacun, quel est le minimum requis pour avoir l'autorisation nécessaire pour exercer cette technique, ou bien, c'est-à-dire, c'est à la base de, c'est-à-dire, on ne peut pas dire qu'il y a une réglementation qui est spécifique uniquement pour le diagnostic, non. ça aussi rentre dans le cadre de médecine nucléaire, mais est-ce qu'aujourd'hui on parle de conditions de radioprotection particulières liées à chaque technique qui nécessite au-delà d'un cadre général? Non. La règle est toujours la même. Pourquoi? Parce que nous sommes en face de l'utilisation des radioisotopes. Et la règle est toujours la même. Sauf qu'il y a des conditions particulières en matière de renforcement des protections, que ce soit au niveau de la préparation, au niveau de l'injection et au niveau aussi même hospitalisation et après hospitalisation. C'est ça le plus important en matière de respecter les conditions liées à la radioprotection. C'est pourquoi aujourd'hui on parle de développement des techniques. C'est-à-dire autrefois c'était de la radio, on va dire l'imagerie moléculaire classique. Maintenant aujourd'hui on parle aussi, on arrive jusqu'au traitement. Autrefois c'est vrai qu'à lancement avec l'irathérapie, on était dans le traitement, etc., mais pas au stade diagnostic-traitement en même temps. C'est ça la différence qui nécessite un petit peu de renforcement en matière de radioprotection. Et c'est pourquoi le rôle de l'Autorité nationale de sûreté et sécurité nucléaire, c'est juste de profiter de cette occasion et la présence très importante aujourd'hui parmi les professionnels et le milieu médical de rappeler qu'il y a des dispositions de radioprotection qu'il faut observer et qu'il faut mettre en place. C'est pourquoi le cadre réglementaire pour la terranucléaire reste en cours de consolidation, c'est-à-dire qu'il faut renforcer, et ça c'est tout à fait normal, c'est le développement de la réglementation à partir du développement des techniques et l'utilisation innovante, et pour répondre aux exigences de la radioprotection afin d'assurer la sécurité des patients, l'application de la réglementation inexistante relative à la radiopharmaceutique aux dispositifs médicaux s'impose tout en accompagnant l'intégration de cette approche innovante dans les pratiques utilisant les sources de rayonnement ionisant. Et je vous remercie.
Thank you so much, sir. We will proceed with our next speaker, Mr. Khalasi, who will present the rise of theranostics in Algeria, the strategic contribution of COMENA.
Il est où? Messieurs, dames, bonjour. Je vais enchaîner par la présentation. C'est pratiquement un peu la suite de ce qu'a présenté mon collègue, Monsieur Chenoufi, mais là, je vais apporter un peu l'apport stratégique du COMENA dans l'ère du theranostic. Donc, comme vous le savez, le theranostic, c'est une combinaison entre le diagnostic et la thérapie. Pour répondre à cette exigence, donc, nous devons avoir une infrastructure adaptée, des compétences solides en radioprotection, compétences solides en physique médicale, production et contrôle de qualité des radiopharmaceutiques. Alors, le COMENA, de par ses missions, est chargé d'étudier et de proposer les éléments d'une stratégie nationale dans le domaine de l'énergie atomique, conformément aux orientations, priorités et décisions arrêtées par l'autorité tutelle. Le COMENA aussi est chargé d'étudier et de définir la stratégie de mise en œuvre, les modalités et les moyens nécessaires pour favoriser le développement des sciences et technologies nucléaires et de promouvoir l'utilisation de l'énergie atomique et des applications dans tous les secteurs, y compris celui de la santé. Il est aussi chargé de contribuer au développement des applications des techniques nucléaires au sein des entités relevant d'autres institutions et organismes nationaux. Assurer en liaison avec les secteurs concernés la formation, le recyclage et le perfectionnement des personnels nécessaires à la réalisation de ces missions, notamment au sein des structures qui lui sont rattachées. Il est aussi en charge de contribuer en liaison avec les instances concernées à l'élaboration des normes techniques de sécurité et de sûreté se rapportant à son domaine d'activité et des normes techniques générales de sûreté nucléaire, physique et radiologique concernant les installations nucléaires et radiologiques et les installations de gestion des déchets radioactifs. Donc, le rôle du COMENA en radioprotection, c'est l'alignement sur les standards internationaux AIEA, la CIPR, contribution à un cadre réglementaire national robuste, surveillance dosimétrique des travailleurs exposés et protocole de protection des patients, du personnel et du public. Concernant l'alignement réglementaire et normes internationales, le COMENA contribue à la conformité du cadre législatif national avec les standards internationaux en radioprotection définis par l'AIUA. Le COMENA aussi participe à la mise à jour des réglementations nationales et des procédures de contrôle liées à la production, à l'utilisation et au transport des rayonnements à usage médical pour un souci de traçabilité, transparence et sûreté. Concernant la surveillance et protection des travailleurs exposés, donc la mise en place des dispositifs de dosimétrie individuelle pour les professionnels impliqués dans la production, la manipulation et l'administration des radiopharmaceutiques, programme de formation et de sensibilisation en radioprotection organisé pour renforcer la culture de la sûreté dans les établissements hospitaliers et les centres de médecine nucléaire. Le suivi dosimétrique est intégré dans un système national de surveillance radiologique garantissant la prévention des surexpositions et la maîtrise des risques professionnels. Pour le patient, le personnel soignant et l'environnement, le COMENA élabore en collaboration avec les institutions sanitaires des protocoles de radioprotection clinique adaptés aux nouvelles pratiques théranostiques. Le COMENA aussi participe au développement de lignes directrices pour optimiser la sécurité lors des examens diagnostiques et des usages thérapeutiques. Il veille aussi au respect des conditions de manipulation, de stockage et d'élimination des sources radioactives et déchets contaminés afin de prévenir toute dispersion radioactive dans l'environnement. La chaîne dosimétrique est le processus qui permet de mesurer, calculer et contrôler la quantité du rayonnement reçu. Donc le COMENA y intervient à tous les niveaux, au niveau diagnostic, thérapeutique, calcul de dose. Oups, excusez-moi. Comment je peux revenir en arrière ? Je ne vois pas. Je reviens en arrière. Non. Pardon. Voilà. Donc, ceci nécessite, c'est pour assurer une efficacité thérapeutique optimisée, une dose maîtrisée et un maximum de dose à l'organe cible avec un minimum de toxicité. Le COMENA, à travers le Centre de recherche nucléaire d'Alger, soutient les pratiques de dosimétrie du patient avancé à partir d'imagerie quantitative. Il met en contribution son expertise à travers la recherche et la formation en physique médicale. Donc, le COMENA aussi organise et centralise le système national de dosimétrie. Il collecte les dosimètres, les fait analyser dans ses laboratoires agréés et archive les résultats pour chaque travailleur. Il vérifie le respect des limites réglementaires d'exposition. Il définit le seuil d'alarme des dosimètres opérationnels utilisés pour la surveillance, pour surveiller l'exposition pendant les préparations et l'administration des radiopharmaceutiques. Le COMENA aussi, à travers le CRNA, offre une demande de service de suivi dosimétrique individuel pour répondre à cette obligation, à l'obligation, la réglementation nationale. Il assure un suivi dosimétrique à un large nombre d'utilisateurs répartis à travers l'ensemble du territoire et met à disposition un système de dosimétrie dédié au contrôle radiologique du corps entier. Donc, concernant la dosimétrie interne, donc le COMENA est doté d'une installation d'anthropogammamétrie qui réalise des examens anthropogammamétriques à l'échelle nationale, témoignant de son rôle central dans ce domaine. En cas d'accident ou d'incident radiologique, des équipes spécialisées en mesurent sont en mesure de fournir des mesures rapides et fiables grâce à leurs équipements techniques de pointe. Le COMENA aussi est responsable de l'étalonnage des instruments de mesure de la radioactivité utilisés dans les différents hôpitaux. Il y a aussi une prise en charge, on peut aussi offrir une prise en charge de l'étalonnage et vérification périodique des activimètres afin de garantir que l'activité des radios pharmaceutiques thérapeutiques mesurées et injectées aux patients est exacte. Concernant la physique médicale et l'optimisation des traitements, donc soutien du COMENA à la dosimétrie personnalisée, promotion de l'imagerie quantitative et de la planification optimisée pour un objectif de maximiser l'efficacité thérapeutique et réduire la toxicité. Donc, il y a un accompagnement des structures de médecine nucléaire concernant le soutien à la physique médicale, donc accompagnement des structures de médecine nucléaire et de radiothérapie dans la mise en œuvre des bonnes pratiques de dosimétrie, contribution au développement de protocoles nationaux d'assurance qualité pour les équipements de diagnostic et de thérapie et contribution à la formation des physiciens médicaux selon les standards internationaux. Le soutien à la dosimétrie personnalisée à travers la recherche, donc appui à la recherche sur les modèles biocinétiques et la dosimétrie interne, utilisation des codes Monte-Carlo et modèles voxelisés pour la dosimétrie du patient. Aussi développement de l'imagerie quantitative pour estimer la distribution réelle des radiotraceurs, soutien à l'optimisation à l'utilisation de logiciels de planification dosimétrique optimisés intégrant la cinétique du patient. Concernant le programme de production et d'application des radioisotopes, donc nous disposons de 2 réacteurs de recherche, donc exploitation de nos réacteurs de recherche pour produire des radioisotopes, développement des unités de radiopharmacie et la promotion des applications thérapeutiques, radiothérapie métabolique. Donc l'objectif, c'est de garantir un approvisionnement national stable et sécurisé en radiopharmaceutique, réduire la dépendance des importations souvent coûteuses et soumises à des contraintes logistiques, développer des capacités locales de production et de distribution adaptées aux besoins cliniques, promouvoir l'innovation et la recherche translationnelle en radiopharmacie. Concernant le volet l'assurance qualité, donc le COMENA contribue à l'élaboration des protocoles nationaux de préparation, de contrôle de qualité et de distribution, développement d'un système de traçabilité des radiopharmaceutiques et contribue à la mise en place d'un réseau national de laboratoires de contrôle de qualité et en termes d'expertise et d'intercomparaison. Pour la production des radiopharmaceutiques innovantes, donc on soutient la recherche appliquée sur les nouveaux traceurs, développer des radiotraceurs ciblés en radiopharmacie et valoriser la production locale. Je passe maintenant au volet formation et compétences. Donc, le COMENA contribue dans la formation académique universitaire en partenariat avec les universités du master de physique médicale. La mise en place aussi en partenariat avec les universités d'un master en radiopharmacie. L'encadrement d'étudiants dans les différentes disciplines en radioprotection, physique, chimie, nucléaire, ainsi de suite, et la facilitation de l'obtention de stages de formation avec l'AIUA. La formation technique et professionnelle, donc nous assurons des formations de radioprotection et de sûreté nucléaire. Nous assurons des formations en instrumentation et maintenance des équipements nucléaires et des techniques de mesure et d'analyse nucléaire et d'autres aussi formations. Concernant la coopération, la formation en coopération internationale, donc nous organisons des ateliers et des cours régionaux et des séminaires aussi. AFRA, dans le cadre AFRA, AIUA, collaboration bilatérale, envoi d'experts et de stagiaires algériens dans différentes formations internationales. Et nous accueillons aussi des boursiers et des participants d'autres pays. Et je vois là, tout à fait en haut, beaucoup de stagiaires africains qui sont là. On vous souhaite la bienvenue en Algérie. Aussi, le renforcement de la coopération avec l'AUA, des projets bilatéraux, projets régionaux et des projets de recherche coordonnés, développer des programmes de jumelage avec des centres d'excellence régionaux et interrégionaux, participer à des réseaux scientifiques régionaux africains et promouvoir des partenariats dans le cadre bilatéral, Sud-Sud par exemple, ou autre. Donc en conclusion, le COMEN a contribué à structurer l'essor du theranostic en Algérie, dans la sécurité radiologique, l'optimisation clinique et la souveraineté radiopharmaceutique. Donc vers un pôle régional de référence en médecine nucléaire à travers la collaboration, à travers notre centre collaborateur avec l'AUA, qui voit un très grand dynamisme en termes de formation. Donc nous accueillons un très grand nombre de formations. Nous offrons notre expertise à différents pays africains avec l'aide de du professeur Amimour. Quand je la sollicite et elle répond favorablement, je suis très rassurée. Je vous remercie beaucoup pour votre assistance.
Merci beaucoup, madame. Thank you. Now moving on to our next topic. Our first presentation is titled Revolutionary Impact of PET, CT, MRI on Research and Medical Practices. Please welcome Professor Abbas Alvi.
Can I just go to my slides? Can I use this to? Yeah, I can do that. Okay.
Which one?
No, that's okay. And just you go ahead to my slide.
Which one is yours? Algeria, final, no.
Yeah, yes, Algeria, final. No, not that one. No, there's another one. You put it on. Can you just, that's all? Okay, that's it. Just go to the first slide. Again, thanks for inviting me to participate in this major educational activity. It's a true pleasure, and I met many colleagues and I've enjoyed my interactions with so many colleagues. So what really I'm going to tell you is the journey that we have taken at the University of Pennsylvania over the past 55 years when I entered the field of nuclear medicine, and what really has transpired through our efforts and efforts of many scientists, physicians, technicians around the world. We became, let me just see if we, just make sure that, let me just see, this, the previous, yeah. Okay, we at Penn were pioneers in developing tomography. I started my training in nuclear medicine in 1971 when this machine was being put together by my predecessor, who almost got a Nobel Prize along with Hansfield, to do tomography with single gamma emitters. So we, of course, doing single spectrum imaging as we call today, we used to call emission tomography. And I used to get like 10 patients a day from the United States, from Europe. They would come to Penn to get spectrum images as you see here. We have 4 sets of detectors on each side, and we were just getting, this moves. So we were getting really very good images. This is, of course, blood-brain barrier abnormality, which I was using technetium per decade. I don't know why this is moving. I'm not doing it. So Then CT, why is it, I cannot, this is just moving on its own. Can somebody help me with this? It's just.
You want to go back?
Well,
Yes.
I guess I will use this. I think that's fine. Now,
You
this is fine. I'm going to use it. I'm not going to use that. I think I'm just going to. Okay. Let me just. I'll just go here. Okay. So this is what we were getting, and then in 1973, when Hansfeld introduced CT scan, we were in the United States the first center to get the CT scan, and of course, we started comparing what CT can do versus what we can do, and it was very clear that CT was superior to what we were doing with technetium per decade at the time by showing that there's a lesion there's a relation around it. So neurosurgeons fell in love with this instrument. Within like 3 months, my 10 studies a day became 0. So we said, this is just amazing. We thought that we had the first tomography unit in the world, and I was doing 10 studies a day, and that became 0. Of course, we tried to do some fancy stuff, like here's a patient with head injury and has got bleeding in the head that they can see on CT scan. There's a contrast enhancement around it, which of course we can also show it on technetium per decade. And then we thought that maybe we could lose blood volume. This is the labeled blood cells that I've labeled with technetium to see really whether we can gain more from what we had at the time and still survive. And it was very clear that we had very limited possibilities. There was just very few traces that we can label technetium or iodine. And we said, how can we survive? Okay, let's survive by using this molecule, the oxyglucose, which was introduced by our colleagues at Penn in the neurology department, and they were labeling C14 to the oxyglucose, inject into animals, and then kill the animal in about an hour, and put the slice of the brain on a radiographic film, and develop what's called autoradiography. So we were just saying that this is really smiling at us. Now that we are losing everything to CT, let's look at the possibility of labeling the oxyglucose with something that we can image from the outside rather than making slice up the brain. Of course, we couldn't. And so this was a big stimulus, came very timely, and that led, of course, to do even more interesting stuff. Look, this is a rat whose whiskers, mustache, have been cut except for a single whisker, and we are brushing this single whisker while C14 deoxyglucose is circulating in the body. As a response to the stimulation, we have activated sensory cortex in the brain of this rat. This was just an amazing type of just data that we were generating. This actually paper that was published has been cited like 10,000 times. This is for the first time we've just shown regionally how brain is activated. You couldn't do this on histology. Just cells here won't look any different after activation than surrounding areas. So, in a cold day in Philadelphia in December 1973, 3 of us, myself, David Kuhl, who, as I said, introduced tomography for anyone else, of course, Martin Rivich, who was a neurologist working with us, decided to go to Brookhaven National Laboratory, which is in the middle of Long Island. And I was actually a junior staff and had a Volkswagen, so I put David and Marty in my car and drove all the way from Philadelphia to Long Island, about 4 hours of drive, and talked to colleagues at Brookhaven National Laboratory. They had sophisticated cyclotrons. They were just playing with different agents, and they had no use for it because nobody could image them from the outside. So they had everything that we needed, and also they had the capabilities that dealt with labeling compounds to biologically important tracers. And so we discussed it, and they say, as long as you're going to be working with us, we will be happy to work with you and make fluorine-18 deoxyglucose. So this was really a very, very important day in the history of our field. Without FDG, this meeting would not become a reality. FDG has made not only tracers survive, but also PET to survive. So we tested, of course, this fluorinating. It took them 3 years, from 73 to 76. So we were able to show that FDG, very similar to C14-deoxyglucose, gets phosphorylated through glucose transporter and becomes FDG6-phosphate. And then, in contrast to glucose that goes through these cycles, it will be just locked in there. This is really God's gift to us as imager in the field, that this just FDG6 stays there, and therefore we could just image for hours after the administration of FDG. So in August 1976, the first dose of FDG was sent from Long Island to Philadelphia. So that's by plane. So I sent a medical student who was working with me at the time to pick the FDG from the airport, which is about 10 kilometers from where we are. And of course, he was stopped. He was speeding in the highway, and the police said, "Why are you going the speed of 65 miles where the speed limit is only 55 miles?" He says, "Officer, we're going to do an important test today. This is like a bucket that has got water in it, and there's a hole. It's leaking constantly. If you stop me for an hour to give me a ticket, half of the isotope will be gone." So, okay, go. So he brings it to Penn, and of course I ejected another medical student, and I did SPECT image of the FDG, very similar to some of the presentations that we have done, the theranostics. So we were the first actually to use the only 511 kV fluorinating to do the images of the brain. Of course, this is nowhere close to what we can do today with just specialized PET instruments. But this was a great day. Honestly, when we even tried to quantify, these are milligrams per 100 gram per minute of metabolic rates. So we did the best we could with a SPECT machine that we had at the time. So while I had this poor medical student at my disposal, I said, "Do you mind if you lie down on this machine that we used to call a rectilinear scanners? We will build dot by dot. They will go all the way dot by dot, focus collimator." So it took me 2 hours to go from here to here, and this became the first total body FDG scan, as we could detect only one of the 511 kVs that was coming from the body. So we show it beautifully. There's a lot of uptake in the brain, some in the heart, and of course a fair amount goes to the bladder, which made us upset. Brain would accept deoxyglucose as being glucose analog, but the kidneys are smarter. They just let it go. They don't absorb it as they do with glucose. So honestly, in the past 5 decades, we have had enormous difficulties to convince that we do a better job than CT and MRI. Of course, our department, it was the first to get the first CT scan in the world and the first MRI scan in the world because of our really pioneering work that we were doing at the time at Penn. So they were easily just bought by the community. But during the past 50 years of life of FDG, we have shown that structural imaging is very insensitive. In fact, the sensitivity of PET versus MRI is 1,000 to 1. If you were to put fluorine-19 on deoxyglucose to do MRI image of fluorine-19, you will kill every patient. You're going to give 20 grams of fluorine-19 deoxyglucose. So this is really the lack of sensitivity and, of course, non-specificity of the contrast agents. There's only one iodinated contrast agent. There's only one MRI contrast at gadolinium. So toxicity, of course, of these agents. You cannot give gadolinium DTP or iodinated contrast to somebody that's got even mild renal failure. The spatial resolution of PET compared to SPECT, which of course, after our work in the brain, SPECT became available by using scintillation cameras, but evidently we have much better spatial resolution with PET than we have with conventional nuclear medicine and for sure even the radiologic techniques. And there's a great contrast. We just direct our tracer to what we want and therefore get a high contrast. And of course, we can do much faster images with PET than we can with conventional SPECT. Of course, accurate quantification, which is another major applications of PET that we can quantify in just decimal concentration of any tracer that we administer. Of course, the world is open to PET. We can use chlorine-11, fluorine-18, iodine, whatever else, to label it to various drugs as well as various metals. And this really opened up. Instead of just relying on technetium and maybe I-131, I-123, we had the world open up to us to make many, many compounds. Of course, another city, university in the state of Pennsylvania, where we are, Philadelphia, is Pittsburgh, introduced PET-CT in 2000. So that was about 25 years later. We have got PET-CT, and we said, this is great. Now we can convince radiologists, we can convince oncologists that what we see on PET has a corresponding structural abnormality on CT. So these instruments, as I said, this was actually published in Time magazine as the image of the year. So for the first time, our specialty is represented in the national magazine as being a major development in science. Of course, FDG has 8 applications, and we really have introduced most of these applications at Penn and, of course, other colleagues. Of course, started with the brain, then we realized that, of course, we knew this before, that cancer is glycolytic, uses a lot of glucose. And then when we started looking at cancer and then people had infection, inflammation, that became source of false positive results. Then I was really the first one. I said, let's just turn your enemy to make him your friend. Let's use FDG in a setting where we're looking for inflammation. Somebody that's got sarcoidosis, we can detect this. Somebody that's got osteomyelitis, we can detect it by the FDG. This actually, especially in the past 5-10 years, applications of FDG and infection inflammation, have become very apparent. And I really have all the 8 applications. We're the pioneer at Penn to really show it to the world. And that's really a very big area because infection and inflammation are the #1 diseases of mankind. Being able to see what antibiotics are working or not. Drug resistance to antibiotics is a big problem. And this is really going to be best assessed in the individualized basis by using FDG PET. Of course, we can look at myocardial viability for bypass surgery. I personally use this of atherosclerosis, which is related to inflammation because macrophages in the plaques pick up FDG so we can see it. Of course, we can look at various muscle problems, and we can even detect clots. Somebody has got pulmonary embolism, and now with total body PET, we will be able to see the clots. And like in patients with cancer, you have high incidence of high incidence of the clot formation. Therefore, we can see it. This is due to the activated cells in the clot that we can. So with one agent, you really have enormous possibilities. Like at Penn right now, we are doing 80 studies a day. When I started, we just rarely could get any patient referral for us to. So normal brain, of course, all the details, let's see what part of the brain is active, what's not. And so clearly, in a patient with Alzheimer's disease where we see significant reduction of FDG uptake in the temporal lobes and parietal lobes, and of course, when the patient has got more advanced disease, then there's a frontal lobe. This is the sensory cortex that is intact. These patients can walk, can feel the pain, but they don't remember what they did a minute ago. So this really just became a very important part of selling this technology to our neurologists who had fallen in love with MRI and CT scan. Because cancer diagnosis and the glycolysis of cancer was described 80 years ago, and it wasn't until FDG became available and we can definitely see a cancer This is the breast cancer that is so clearly seen. We can see lymph nodes involvement and metastasis to the rest of the body. And big problem with the CT scan was not being able to do correct staging of the disease. So this patient has got lung cancer with central necrosis, but in the middle of these densities on the CT scan, which we could not even retrospect find it, there's a lymph node involvement. So this is accurate staging. So this patient cannot be cured. Clearly, I mean, if you take out this lesion, the node here, especially if you had just used only CT scan, would have just spread to the rest of the body. So this stage in the patients with cancer has become a big application and the reason for survival of FDG PET as we have today. Of course, response to treatment has been very difficult with either CT or MRI. Here's a patient with lymphoma that is all over the place. These are the lesions in the axilla, in the mediastinum, the abdomen, and you treat the patient 2 cycles of treatments. We see everything gone except for 1 lesion in the left groin. That means that cancer is not a uniform, the same type of cell everywhere in the body. So this lesion is going to grow and spread to the rest of the body. So you can just predict who's going to have a bad prognosis, who's going to have a good prognosis. Of course, patient has got very significant involvement of the disease. So treatment response has become a major application, especially diseases like lymphomas that are very responsive to treatment. We can so readily see the efficacy of treatment. Infection inflammation, as I mentioned, has been a great interest of mine because of their significance. And especially as a drug resistance, like in many parts of the world, there is resistance to treatment of tuberculosis. This is going to be the best way to know what is best treatment for the patients with infection, but also inflammatory disease by itself is really a very important part. So this is a patient with diabetic foot that has got infection in the arch of the foot here, but there's also infection in the bone, osteomyelitis. You cannot cure this patient. This patient has to have amputation. And this patient had negative MRI and negative CT. Of course, I mentioned that we detect plaques in the artery. Number 1 killer of mankind is atherosclerosis, like cancer. So being able to see evidence for plaques that are inflamed so readily, this is the arch of the aorta, that usually has a lot of atherosclerotic plaques. And now, of course, with PET-CT, we can convince our colleagues, and they really have become very convinced that FDG shows the plaques. Unfortunately, FDG uptake in the heart makes it impossible for us to look at coronary arteries. But definitely, we can look at the aorta, we can look at carotid artery, we can look at the peripheral arteries. So there's life beyond FDG, which is really great. As a scientist, to me, this is a great reward that FDG has made it possible to have hundreds of compounds made all over the world. Of course, we can look at DNA synthesis, we can look at hypoxia, gene transfer, we can look at slow-growing tumors with amino acids. And of course, we have been sitting through this conference hearing a lot about PSMA. These wouldn't have happened if we didn't have FDG. FDG justifies to buy a PET machine. And if you are a major referral center, you can buy a cyclotron. Convince your administrators that paying, $200, $300 for FDG for a dose, other than making it on your own institution, is going to really save a lot of money for the institution. Because some of the statin receptors, we just heard a lot about it. I've become very interested in calcium metabolism, namely calcium metabolism, particularly as it relates to atherosclerosis. I'll show you a little bit of that. Of course, FAPI, we have heard a lot about it. So this is just an examples of what we have been able to do over the past 5 decades with the introduction of PET. But this is, of course, classification that you so clearly see. This is a patient, young subject, no classification. This is a 69-year-old and atherosclerosis. Of course, unfortunately, based on our data, and especially in countries that are really have bad diets like America, we are seeing atherosclerosis in people in their 20s. And that is not going to be possible to see on CT scan. You have to wait until you are in the 40s to be able to see calcification on the CT. And when you have got calcification on the CT, that is irreversible. You cannot get rid of the rocks that are sitting in your coronary arteries and your carotid arteries. But if you see molecular calcification with sodium fluoride, you can reverse it. You can stop it. You tell the patient, especially people who have got high risk for atherosclerosis. Because we have at our institution 2 PET-CT machines in radiation therapy department. They will not treat a patient without doing FDG scan or other agents, PSMA or other agents that are available for patients with cancer. So this is a patient. On CT scan, you see this huge lesion, but you can't tell whether you should radiate the whole thing or not. You look at the FDG scan, half of it is cancer, half of it is not. Radiation therapy-induced damage is very serious. 3% of the patients who get radiation therapy for lung cancer die from pneumonitis. And of course, the rest of the people get significant inflammation in the adjacent lungs. By doing PET scan, you're able to focus only in this area and minimize damage to the normal tissues. Theranostics, you have to learn a lot during this meeting, and that again is the result of having PET availability and having diagnosis made by PET, and then therapy based on the molecules that we use for diagnostic purpose. And just this is one of the greatest developments in therapy, and it just is moving very fast, and it's going to be applicable to many cancers. And the question is whether it's going to be in the hands of nuclear medicine people or radiation oncologists will lose a lot of business to us. And so we may have a battle to just deal with, but this is a true revolution in medicine. Of course, this is just an example of prostate cancer before and after treatment. It's just PSMA, ACE, yttrium, and you can see that, of course, you follow with the SPECT to see the course of the disease. So PET MRI, of course, has been available for the past 10, 15 years, but of course, you can have a combined unit. It has very limited applications, and very much like MRI has limited applications. So I'm not sure how far it's going to go. Definitely will be applicable to organs like the brain or some other areas where MRI has been successful, but it has not caught on as PET-CT has. But it's definitely there. Attenuation correction is a big problem with PET MRI, and also the time it takes to do the PET MRI. But it's a reality. It hasn't sold as many units as PET-CTs have. Of course, our group at Penn, as well as people at Davis in California, have become interested in total body PET. So this is a machine that, of course, United Imaging has a display exhibit here. Working with Davis colleagues, have built this 2-meter machine. So you go inside the machine, in 2 minutes, your whole body is being imaged. So you can just have children who you don't want to stay still, image with this total body PET-CT so readily. And of course, it costs $10 million to get this machine. Because all the major companies now, GE, Siemens, Philips, are developed, but they've gone to 1-meter machine. Honestly, cancer goes to where red marrow is, and that is confined to the axial skeleton, namely spine, pelvis, and upper part, but very proximal femur. So looking at all the way to your toes is not going to be as useful for cancer patients, which is a really dominant aspect of total PET-CT. So you can actually do so that not 1-meter machines are becoming very popular, and just they're going to take over this conventional PET machines, because it just, we want to do as many PET we can. You know, just with conventional 25-centimeter field of view, we are not going to do too many PET studies a day. It takes about an hour, but takes only 5 minutes to do total body images with these long field of view machines. So this is a patient with melanoma. All the lesions you see are lighting up. And again, in 2 minutes, this image was taken. And the repeat study after treatment, immunotherapy, shows disappearing of all these lesions, but lesions in the lower extremity. So if we did a total body PET, people would have ignored these because it would have stopped here and you say, you're cured. But this patient clearly is not cured. So this, of course, most cancers are not going to be like this. They just don't go, to the toes or fingers. So, but again, 1 meter machine is going to allow you to look up to here, and in 3 minutes, you have done the scan, and the patient just go home after that. So the conclusions are very, very clear. I mean, this is just amazing episode in medicine. During just 4 decades, FDG, of course, has had a major impact on day-to-day practice of medicine and introduction of new tracers. Right now, there are hundreds of publications in the literature about various tracers that have been used for various diseases. And this is it further enhances the critical role of this modality in day-to-day practice of medicine as well as research. SmithKline, which is a major drug company in the world, has 10 animal machines in their facility. So they're not testing drugs anymore by the old-fashioned ways, namely injecting the animal with the cold drug and then taking pieces of tissue in 10 minutes, 20 minutes, an hour to find out where they are, and not even get an accurate distribution. They're now using small animal machines, which is really a big market too. All the major research institutions have 1 or 2 small animal machines. So this is really revolutionizing drug development much more effectively than was possible previously. Of course, I have Röntgen's 5-scan with the X-ray, first X-ray, with the ring in his 5-scan, and I have my first FDG scan. And I just say in my description of these two, this was important, but this is more important. Introduction of FDG has led to so much, science, using truly sciences, physics, mathematics. My reason for going to Italy to the field was that I missed so much dealing with mathematics, quantification, tracers, chemistry, and just this PET has been the gift of God to me, and clearly structural imaging just has only still the same X-ray with other applications, CT scan, but nothing more. There's only one contrast agent, iodinated contrast. And the same, of course, applicable to MR, made an enormous impression on the community at large, and including in my own. We got the first MRI in the world to come to Penn, and everybody fell in love. How can you do anything better than MRI? Clearly, it was misconception. So really, and that's why Dalai Lama became interested in what we were doing. I'm describing to Dalai Lama is here. This is, visiting our department, and I'm showing how we can activate the brain. And of course, he became interested in using PET for meditation. So these are followers that lived in the Philadelphia area. So we started looking at meditation effect. So you can see that it is not only real science, something that is philosophical of great interest to humanity, how we can deal with emotions and activation of the brain. And that just has taken me from science to something that is even very interesting. So thank you for really inviting me, and this has been a great pleasure.
Thank you, Professor. Thank you. Our second speaker, Professor Zaidi Habib from Switzerland, presenting quantitative imaging, biomarks in the era of precision medicine.
Assalamu alaikum. Look into the faces, I can feel that many people are wondering if I'm going to give the talk in English or in French or in Arabic, right? You don't need the headsets, I'll make it in English, yeah, so. Thank you very much, actually, for the opportunity. And so you need to really to be trilingual to follow actually all the sessions, right? So you would like to get the joke, right? Start with a joke, yeah, just to relax. Yeah, you know, if you speak 3 languages, then you are trilingual. If you speak only 2, you're bilingual, right? But if you speak only 1, you are American. It doesn't apply to you at best because I know that you speak Persian and Turkish as well. Yeah, right. Thank you. So let's get started here. So these are my disclosures here. And yeah, let's get started with this nice picture that we have seen actually illustrated by Professor Arabi, the first FDG PET image which dates back to the 1976. And yeah, Abbas Arabi has been my mentor for a number of years, and he basically stimulated my interest in quantitative imaging. And the advantage again of PET, as he mentioned in his brilliant talk, is that you see the numbers on the left side, is that you can quantify something that you can remove during using anatomical imaging techniques. And I really actually encourage you actually to read this very nice biography written by our colleague Paul from Denmark. So Professor Alavi turned 80 in when? 2018. So this means that he's 87 years old. So in this particular country where people start thinking about retirement at the age of 50, I think it's really a nice example. So yeah, keep working till the last day of your life if you can afford. Right, so to talk about quantitative imaging, we start defining what we mean about quantitative imaging, and I think this is a very nice definition given by the Quantitative Imaging Biomarkers Alliance, which is a group actually created by the Radiological Society of North America in the US, and they say that quantitative medical imaging is defined as the extraction of quantifiable features. So we're talking basically about imagery-derived metrics that can be used actually for clinical diagnosis, monitoring, treatment response, radiation therapy treatments, planning, and a number of other applications. So this is the official definition. And this is slightly different from what Dr. Lopsi, so the star of this meeting, has shown in his presentation. What you see is basically two seamlessly different bars with different intensities on kind of shaded gray that you see here. And if I bring the 2 bars close to each other, you realize that they have exactly the same intensity. So this is one of the limitations of the human visual system, right? And most of the MDs actually, they prefer to interpret visually the images, but I think this is a nice example that the human visual system might trick you in some cases. So why do we need quantification? We have another quiz here from a nice illustration from our friend Professor Buller, or his mentor actually. So, but he's co-author of this publication. You know that when acquiring the data, we can acquire dynamic frames, and we can also sum up the events collected with a certain time period to get kind of static image, and this is what is used in the clinic nowadays. And if I show you this image here, so the same subject, it's a healthy subject which has been scanned twice, baseline, and then after the administration of aprepitant, which is kind of an antagonist which binds actually to the KP1, PK1 receptors. So if you look to the static image, actually baseline and after administration of the antagonist, and they ask you actually to basically give me what is your sense of the occupants in the AQ1 receptors in this 3 atom. Is it going to be less than 25%, 50, 75%? I think to the naked eye, the physicists are inclined to see less than 50%. And this slide has been shown actually during many conferences, and most of the audience, actually including experienced PET scientists, they usually say between 50 and 75. So if you use tracer kinetic modeling, and then build these parametric maps that you see here, and then we quantify actually the binding, non-displaceable binding potential, you see is that is in the range of 97%. So quality which is definitely much, much higher than what the human visual system is going to depict based on the static image. So how things happen in the clinic is that most of the facilities that I know, including ours, so we tend actually to interpret qualitatively the medical images, right? And the criteria actually for qualitative assessment of the medical exams is to have a good quality image. And most of the MDs actually are trained to differentiate between normal biodistribution that you have in the brain for FDG and the patterns, which is typical, actually, this is these hypoperfusions that you see, typical of the neurodegenerative disease, basically Alzheimer's, dementia of Alzheimer's type, right? And the same can be said also for whole body imaging. So this is the normal biodistribution that we have for FDG, right, with 6% given to the brain, 20% probably given to the bladder, and the rest is distributed somehow in different organs. And this is the typical pattern of lymphoma, right? And then the second step actually is to proceed also to what we call semi-quantitative analysis, and this is basically the standard adopted for multi-center clinical trials. Phase 2 trials actually conducted by the pharma industry, where they need to scan different patients in different locations and those different places. Usually they use different scanners, different brands, and different acquisition reconstruction protocols, and they need some form of harmonization actually to be able to harmonize the data collected on the different sites using different patients and different acquisition protocols. And this is one of the good reviews that we recommend on harmonization. This also applies actually to clinical sites where we've got one patient scanned on one PET scanner for the baseline, and then you decide to change the scanner to get another one with a higher performance, and you need to harmonize the data so that you can compare the baseline to the follow-up scan rate. And this type of techniques is used in the clinic, at least in our department. A number of such tools actually are commercially available. I'm not going to name the manufacturer of this tool, but basically the idea is that you get a PET scan of one patient, and then you have a normal database, what we call templates. So basically age and gender-dependent human subjects that undergo, normal subjects, of course, that undergo PET scans, and then you realign them, and then you constitute what we call a template or normal database, and then you can do the comparison between the patient's specific PET scan with respect to this template. This can be carried out on a voxel-wise basis to get the deficient area, which is different actually from the normal database. We can also define a number of regions, right, on the MRI, so that you can do the semi-quantitative analysis basically on region-by-region basis, actually for 63 regions. And the same type of techniques are also employed for myocardial perfusion imaging. In the context of clinical oncology, so we have seen many numbers in the previous presentations today, and the idea is basically to define region of interest on the malignant disease, and then you quantify what we call the standardized uptake value, which is given by the Seeley equation that you see here. It's basically the ratio of the activity concentration in the malignant disease divided by the activity injected to the patient, normalized actually by the weight of the patients. And because we've got a number of voxels within this region of interest, so we can do some simple statistics to get the average, to get the maximum, or even the peak standardized uptake value as recommended in the PERSIST criteria. Some people actually use also what we call the TLG, total lesion glycolysis, provided that you get the metabolic serum volume. You can multiply this by the SUV mean to get this TLG, and sometimes the weight is replaced by other factors such as the body surface area, lean body mass index, and so on. So the good thing is that 90% of the sites, according to a survey published in GNM a number of years ago, reports the standardized uptake value in the reports. And this is the case for our institution as well. And the SUV max is usually reported, and we have seen many of these numbers actually in the previous slides. And the bad thing, I think, in my opinion, this is the bottom line, is that this SUV max reflects only one voxel within the whole lesion actually that can be defined. And the bottom line again is that this SUV depends on many factors, some of them linked to the patient's physiology. We need to ask the patients to fast a number of hours. Not all of them respect this. Blood glucose levels as well. So some other factors linked to the instrumentation, actually the acquisition conditions. For instance, one factor which is often neglected is that in our institution we use automated dispensers, and the clock of the automated dispenser has to be synchronized with the clock of your PET scanners, because otherwise your bias actually is going to reflect this difference in the in the timing because the two clocks are not synchronized. And then you have a number of other factors that are summarized here, which can go up to 50, 70% in some of the cases, right? So the last tool that is often used in research applications, but not used in the clinic, is full kinetic modeling. And usually this is well known to compartment to tissue to compartment model for FDG. It's like fluid mechanics, right? So the one compartment reflecting actually the flow from the blood to the tissue, and so on. So we have the microparameters K1, K2, K3, and K4, and then you need to have the input fraction, which can be estimated in many different ways. You can get the blood samples, you can get image-derived input function, and this allows you actually to get the parametric maps that I showed you earlier, or again what you see here. Right, so in terms of image quality, actually, you know that PET-CT suffers from a number of physical degrading factors. This includes attenuation, Compton scattering, partial volume effects, which I'm going to talk about this later on. And then, so these are some of the different artifacts that we observe in the clinic. So these misalignments between the X-ray CT and the PETs, because of the differences in breathing patterns, you know that we can acquire an X-ray CT so for less than a few seconds, especially if using 128 detector rows, and then the PET is usually acquired between 2 and 3 minutes per bed position, so it reflects an average of large number of respiratory cycles, and then you might end up with this banana or cord artifact that you see here. People doing X-ray CT, the radiologists, they know that these metallic artifacts that we encounter very often, especially if you have dental implants, if you have large prostheses, you end up with these large artifacts that can get propagated actually to the corresponding PET image, because we use those CT images for attenuation correction of the corresponding PET images, and this might end up with this artifact that you see here. And then the same can be said for IV or all contrast media, if this is used for attenuation correction. Truncation artifacts, I think this is very common in the US because they usually scan high BMA patients. It's rarely the case in our facility because usually the patients have very low BMA in Europe. How to sort out all these problems? I think we have assisted really into a revolution in the medical imaging, like the tsunami in medical imaging, the use of AI for medical imaging, and some of these tools using AI can be used to sort out all the problems that I just mentioned. I'm going to show you a few examples. So we have an extensive discussion last year. So just to show you some examples, Isaac, one of the former PhD students in my lab, he developed this comprehensive framework which enables to get rid of the majority of artifacts that we encounter, including misregistration, metallic artifacts, the hollow artifacts, which we see very often in gallium-68 PSMA imaging. And let me just show you one example. This is one of the examples from our facility. You see the X-ray CT, which is mismatched with the attenuation corrected PET image that you see here at the level of the lungs of the diaphragm here. And this is an artificial intelligence-based attenuation correction technique that doesn't use the CT for this purpose. So it's kind of direct conversion between the incorrected and the corrected image. And you see that this PET image is nicely matched actually with the X-ray CT that you see here. Another example, this is the hollow artifacts. So which is kind of miscorrection for Compton scattering and an overestimation actually with the scatter component, where you see these huge artifacts in this region, low uptake in this area here. And what the MDs usually do is that they tend to re-scan the patient, repeat the exam, hoping that this artifact is going to disappear. And you see that the artifact is still here for the second acquisition. And the deep learning network is really doing a good job in this respect, in the sense that the artifact is not visible in both scans here. We also care very much about the radiation dose delivered to the patients, and this is another study actually by Yazdan, other PhD students in the lab. So this is the regular CT scan that we use in our facility for attenuation correction purposes, delivering almost 3.1 millisieverts actually to the patients. And we have a nice tool actually provided by Siemens, which adds kind of noise-dependent or scanner-dependent noise to the regular CT scan or the standard dose scan to get these low dose scans at different dose levels. And this is with the factor of 30 reduction, so only a couple of MAS for requiring the CT scan, because obviously we did not scan the patients twice because this is not ethical. And this is the one predicted by the deep learning network, so almost similar image quality is what you can see here. It's with a factor of 30 reduction in terms of radiation dose to the patients. You can see that even from this example, even the small structures here got preserved on this low-dose CT scan, so something which is extremely reassuring. And we look also to the impacts, because these CT scans are used for pattern attenuation correction, making sure that the bias is not significant in terms of standardized uptake value quantification. It gets really down from 80% when using the low-dose CT scans to up to less than 0.5% when using this developed technique. Partial volume is definitely an important physical degrading factors, and this is a comprehensive review published again with having Professor Alavi as one of the co-authors on this review, because he is one of the first physician scientists who got interested in this partial volume effect. So this is how we can explain it actually to non-physicists. If you just scan a number of spheres with the diameters going from 4 to kind of 16 millimeters and playing actually with the what we call the point spread function or the spatial resolution of the scanner, which ranges in this case between 4 and 10 millimeters. So this is a simulation-based study generating actually this simulated PET image, and you've got the impression actually that the contrast decreases actually for the smallest sphere, when in reality we have the same contrast in all the spheres. So with this we end up actually with this curve for what we call the recovery coefficient, which is defined by the activity concentration measured actually on the image by defining a region of interest on the sphere divided by what we injected really what we measured on the dose calibrator and injected in the sphere. So we got this shape actually of the recovery coefficients. And one of the well-known actually techniques to compensate for partial volume effects is to basically reverse the recovery coefficient to compensate for, provided the spheres actually have spherical shape, of course. And we have been using actually this MRI-based partial volume correction in our clinical collaboration with the neurologists since almost 15 years, and this it basically segments the MRI, so number of intermediate steps that I'm not going to discuss in this presentation, and then you correct this image that you see here. These are two patients, and this is dementia of Alzheimer's type, where we demonstrated that the hypometabolism here extended beyond the atrophy, and this is a frontotemporal dementia case where the hypometabolism basically coincided with the atrophy. So giving some important information actually to the physicians to decide about the cases using partial volume correction. In cases where MRI is not available to do this type of corrections, Amir and other PhD students in the lab developed this artificial intelligence-based technique, which consists obviously, as you might know, two steps, one for training, the second for application on unseen data sets. So we have a couple of cycle GANs. So this is one of the most popular neural network architectures that you use for medical image analysis. And we have two basic cycle GANs consisting of a generator and discriminator that does this job. And this is basically the outcome. You see the MRI for different tracers, FDG, tau, amyloids, and DOPA. You see the MRI, the PET image, which is not corrected for partial volume correction, the MR-based partial volume corrected image, and the one corrected with the artificial intelligence network. So I think we're really still within this in crisis in terms of PET quantification, because there is no consensus. We have seen different numbers, SUV mean, SUV max, TLG, whatever. So we'll be talking about radiomics and parametric imaging. And I think it's difficult for the young scientists, young physicians to really choose among all the metrics which are available, which one is going to be used. So we have different types of metrics. The first order metrics are quite simple, like the SUV max, the SUV peak. The second order metrics, the SUV mean, which is extensively sensitive actually to the partial volume effects, the MTV TLG. and another metric which has been pioneered by Professor Alabi called the global metabolic burden. We have the high order metrics, which is called radiomics of textual features. 5 minutes more is okay? All right. 5 minutes, all right, very good. And then we have parametric imaging, which is a specialist's best friend. I think the tumor heterogeneity has been reported in the major publications as being prognostic factor, and unfortunately for the community, actually focusing only one voxel, which is the SUV max, we're not taking into account this heterogeneity. And it has been also demonstrated in a number of papers that if you go from small, uniform actually uptake to a larger with lesions with heterogeneous uptake, the largest heterogeneous lesions are going to be more resilient to therapy. And then it's, I think, really unfortunate that we are only considering one voxel to characterize the disease. This includes also our institution. The MDs already reports only the standardized uptake value max, and this is what is used actually to decide if the patient is responding. This is basically the typical plot for patients responding to a therapy and another patient which is not responding to the therapy, and unfortunately this patient died after a few weeks. And so it's really unfortunate that we discard all this important information that can be used actually for prognosis or for outcome prediction. And this is actually what has been advocated by Robert Julius, who unfortunately passed away a couple of years ago, who has been the father of this concept called radiomics, because images are more than pictures, they are the data. And the idea of radiomics is that you basically segment the malignant disease to be able to extract what we call the gross tumor volume, and then we extract the number of features that could be either intensity-based, shape-based, or texture-based. And with the texture-based features, we can build what we call here the heat map, which is extremely difficult, I can understand, for MDs. And this is probably one of the reasons why radiomics has not been implemented or adopted in clinical settings. Just to show you some of these examples, for more morphological features, you can look actually basically the solidity, which is low in this case, a high for the green case, and this is the rectangularity, and this is the sphericity. We can get also the histogram, not really meaningful, because you can get different histograms reflecting the same biodistribution. And some of the advanced high-order metrics include what we call the gray level co-occurrence matrix, where we basically express how combinations of discretized gray levels of neighboring voxels are distributed along a certain distance. And with this, we can actually extract what we call the entropy, the energy, and large number of features that can be extracted from these features. If you look actually to the publications, this is a nice review paper, probably not up to date, but still I think the information that it carries is important in the sense that the largest number of articles published in radiomics, 77%, uses a small number of patients, less than 100 patients, and only 3 actually used more than 200 patients. So there is definitely a need actually to pull data from different studies, from different clinical sites, and the problem with radiomics is that they're very sensitive to the type of scanner, to the acquisition reconstruction protocol. So it's difficult because you get 2 different biodistributions. And a good technique that has been actually applied in the field is it's called COMBAT, which basically enables you to pull data coming from different sites, different scanners, using basically some techniques developed for the analysis of genomic data. And to standardize actually the way we extract radiomics, so the IPSI, the Image Biomarker Standardization Initiative has done a good job actually publishing a couple of papers in radiology a number of years ago. So this includes a pretty large number of academic institutions, over 25, who have actually basically standardized the reporting and interpretation of these radiomic features. And then for the students and also for the physician scientists interested to do radiomics, to use radiomics in their research studies, a number actually of open source software can be used for this purpose. The most popular one is probably the one coming from Harvard called Pure Radiomics. So if you look also to PubMed, I just did this this morning actually before coming to the conference. You have over 390, 3,900 publications using radiomics in the papers. And so if you look to the trend, so really the number of papers is exploding and following an exponential. Again, so just a couple of minutes. I would like to draw your attention to this study actually by Yazdan from my group. So what he did is basically to extend this concept of radiomics to intra or to peritumoral tissue, so by extending actually the GTV by 1, 2, 3 centimeters. And then he also segmented the healthy organs and included this in the analysis towards the concept of what he called organomics, which is basically organ-based radiomics. And then he used these nice data sets for small cell lung cancer. And then he combined different feature selection techniques with machine learning models, looking actually to the GTV on the CT, on the PET, and including also the healthy organs. And he ended up actually concluding that the largest C index or concordance index could be achieved actually by using this concept of organomics combining both PET and CT. And obviously this leads to better discrimination between low-risk and high-risk patients, as you can see from the Kaplan-Meier curves here. Let me just skip a couple of slides just for the sake of time to talk about this concept of parametric imaging. As has been alluded, so we're moving actually from short axial field of view PET scanners to large axial field of view PET scanners up to 2 meters long. And there are different ways actually of doing parametric imaging depending on the scanner which is available to you. If you have a short axial field of view PET scanner, this is a nice methodology. Basically scanning the patients for short acquisition time per bed position, putting the patients exactly in the same position as was done initially, and then you start the second scan. And with this you can scan the patients multiple times, ending up with a large number actually of dynamic scans that can be used actually as an input for a tracer kinetic model to derive the kinetic maps. So we can do this with a simple graphical analysis using the PATLAC analysis with or without the K-loss, which basically if you have a reversible or non-reversible tracer. And you can also do this already at the with the full kinetic model to extract all the microparameters. So this is basically the standardized uptake value image, which is acquired in the clinical setting. And these are the parametric PATLAC maps, so basically the influx rate and the distribution volume that can be acquired. And one of the scanner manufacturers is offering this as part of the software provided to the end users. We have demonstrated actually in clinical study that full parametric imaging might be useful in some cases. So this is a case with hepatocellular carcinoma, where you see that the SUV image is negative, and the K1 and K2 some show that these really positive cases. And by the way, just as a comment, so I think nuclear medicine is the only specialty I know where the physicians are very excited and they'll be happy when the scan is positive. Something which is astonishing, but I've been observing this since a number of years. So this is positive on the K1, K2, but negative on the SUV image. And obviously, if you have a total body PET scanner, you can actually get, immediately after you inject the patient, you can get the tracer uptake basically in the patient, different components of the uptake, and you can also derive the kinetic parameters, including the delivery rate, which you can show here, distribution volumes, and all what you are interested in. So let me just skip the summary, actually, just for the sake of time. Let me thank the funding bodies actually funding our research, my team actually that you see here. Special twink for those who graduated recently, getting their PhDs. And then, as I said in the beginning, so I think the Persians, after Professor Olabi, are still leading the field. So two of my former PhD students, Persians, so this is Isaac, who got the Bruce Hasegawa Award this year in Japan, and this is Abul Fazl, who graduated in 2015 and who got the Bruce Hasegawa Award in 2018 in Sydney. So the Persians are still leading the field, and delighted to have you here, Professor Olabi, and thank you very much for your attention.
Thank you, Professor. Thank you. Now we're getting back to the FAPI topic, again for the presentation of Professor Richard Piebam from Germany about the FAP-based radiotherapeutic, FRT, for the treatment of diverse adenocarcinoma and sarcoma. Please start.
Thank you very much for the introduction. I'm very happy that I be able today to join you. It was unfortunately yesterday not possible because I'm in Mendoza in Argentina and had to deliver a lecture at the same time. So the tumor microenvironment is mainly built by fibroblasts, is a selective marker of cancer-associated fibroblasts or CAFs, which are expressed in 90% of all malignant tumors. And CAFs are highly prevalent in the TME of many, if not all, malignancies, and at all malignant stages. So from a few cells, about 5 to 10 cells, till kilograms of tumor in very progressed cases. CAFs are expressed as a pan-tumor target and not expressed on normal fibroblast or in normal tissue. The concentration is very low. So everybody thinks that FAP or FAP is a new topic, but actually it is over 30 years old, and the target was first described by the group of Lloyd Old at Memorial Sloan Kettering in 1990. Now, FAP have a lot of pro-tumorigenic functions. As you can see, they promote angiogenesis and tumor growth, invasion and metastasis. They modulate the immune system and make it difficult for the immune system to attack a tumor, and that all together leads to therapy resistance. Now, the FAP structure was first published in 2014 by Peter van der Vegen's group from the University of Antwerp with this very important molecule UAMC1110, which is the basis of all FAP tracers, which are used mainly today for imaging. And as you can see, there is a wide range of tumors from sarcomas to renal cell cancer with quite different uptakes and expression of FAP. But the mean of 44 primary tumors was around 10 SUV max and metastases even lower, about 9 to 10 SUV max with the first compounds. So the uptake is relatively low, but the clearance is very fast. So you have a good tumor to non-tumor ratio very early, even 10 minutes after injection. But unfortunately, all the FAP agents, the small ligands, they fall off of the tumor very fast. As you can see, the biological half-life is between 1.6 and 2.8 hours. Now, our group was the first to use peptides for FAP targeting, or peptidomimetics to be correct. And there are different approaches which, due to limited of time, I cannot discuss in detail, like FAP dimers, heterodimers, and albumin binding FAP, but our group decided for a peptide named FAP2286, which was actually developed by 3B Pharma in Berlin. And we performed already in 2019 imaging and treatment with this FAP2286. And you can see here again, which are early images after 15 minutes, 3 hours, up to 10 days, that there is very good early uptake and longer residence time in the tumor than with the FAP compounds. And we can see also on the PET scan before and after treatment that there is an effect which was in this patient mainly pain reduction. Fortunately, our paper, which was published in the Journal of Nuclear Medicine, received the Editor's Award as the overall best clinical article published in 2022. We then changed to another peptide, which is very similar. Actually, there is only one amino acid difference to 2286, which is called 3BP3940, is also a cyclic peptide conjugated to DOTA. which can be labeled with different metallic radioisotopes, and it has a very high affinity, as you can see here. And since March 2021, we have performed 330 treatments in 125 patients with advanced malignancies, mostly adenocarcinoma. I will show you later a list. All patients had previously exhausted other therapies, so there was no other treatment availability given for these patients. And of course, after confirmation of significant tumor uptake using PET-CT and the same peptide, biodistribution was analyzed post-therapy with SPECT-CT, and clinical parameters and laboratory finding and tumor markers were also monitored. So we administered lutetium, yttrium, or actinium labeled compounds intravenously over 1 minute. So you do not need a half-hour infusion like it is prescribed for PSMA or for the Lutathera, which, by the way, is also not necessary to inject so slowly. And very important, no renal protection was performed because the kidney uptake is, as you will see, very low. The injected activity was chosen individually following a personalized medicine approach, and additional cycles were given if the patient condition allowed for further treatment, and response was determined using molecular imaging with PET-CT and SPECT-CT, and also morphologic imaging using contrast-enhanced CT scans, MRI, and by monitoring tumor-associated antigens. This is just one example of a very rare tumor, a metastatic clear cell sarcoma of the small bowel in a young patient. And you see the extremely good uptake and the very small lesions we can detect, for example, in the liver. In this case, there was a lesion so small that it could not be even seen on MRI, and which grow, unfortunately, despite treatment, to a larger lesion. And the history of the patient is mentioned on this slide. You see from left to right the development of the disease, so some response after treatment with yttrium-90 and actinium, and the combination of lutetium and actinium. But then, unfortunately, the patient progressed, and you see the necrotic metastasis in the liver, you see bone metastasis, and also very nicely lymph node metastasis in this patient. This demonstrates the quality of the SPECT-CT, and you can see even after 2 hours on the left upper row, we have a very nice uptake in a pancreatic adenocarcinoma and in liver metastases, which persists 48 hours after injection and even 6 days, 144 hours after injection. And you also see that the uptake in the kidney is extremely low, not higher than the liver, and also there is no uptake in normal bowel in this patient, and even smaller lymph node metastasis, in this case around 80 millimeter, could be detected by SPECT-CT. Surprisingly for me, there was also quite good image quality when using yttrium-90 for treatment, and you can see that the yttrium-90 SPECT-CT here is able to follow the patient and give some molecular information on the treatment response in these cases. We also performed dosimetry in some patients, so there were doses between 3 and 5 gray tumors given per cycle. This is a list of the patients we have treated, so 23 distinct malignancies, mostly pancreatic adenocarcinoma, PDAC, followed by lung, breast, rectum, prostate, also undifferentiated without PSMA uptake, appendix tumors, uveal melanoma. You see a lot of rare tumors you usually don't see in a nuclear medicine department. This is a pre-theranostic treatment landscape, and you see that all the patients were really heavily pre-treated with surgery, of course, hormonal therapy, chemotherapy, immunotherapy, and so on. And these are the isotopes we have used, either single or in tandem. Mostly we have used a combination of lutetium and actinium in around 50 patients, and then followed by lutetium alone and also triple. But that does not work even, of course, on one day, but in different administration cycles, yttrium-90 and yttrium together with actinium. For me, quite positive experience was that we have seen no clinical relevant adverse effects on bone marrow or renal function. On the right, you see the graph that there was even improvement of renal function in some patients, which might be due to what we call hepatorenal syndrome. So if you improve the liver function, the kidney function also improves. And this is remarkable because we have given up to 12 gigabecquerel of yttrium-90 without renal protection. In some of the patients, we have seen developing anemia, leukocytopenia, and thrombocytopenia, but not in a range which is clinically relevant. So the overall tumor response was around 66%, and the disease control rate about 80%. And this is a patient I would like to discuss a little bit more in detail. A poorly differentiated epithelioid pancreatic carcinoma, a rare form of pancreatic cancer. And the patient, of course, had first pancreatectomy with lymphadenectomy, followed by different chemotherapy cycles, and even a K-RACE vaccine was given. And she had an excellent response and was published by the Stanford group, by Bob Fisher, actually, in a journal as a patient with a complete response, but unfortunately later developed progression of the disease, and she received a EZH2 inhibitor and again chemotherapy, immunotherapy with pembrolizumab, even MRI-guided external beam radiation therapy of the primary tumor and the lymph node metastasis and transarterial chemoembolization. And despite all this, the patient progressed. And this just demonstrates how heavily pretreated our patients have been. And then we started treatment with 5 gigabecquerel of yttrium-90 in combination with actinium, followed by 2 cycles of yttrium-90. And you see that there was quite a nice response between October 21 and February 22. The liver gets smaller, the lesions get also smaller or disappear, and even the primary tumor, as you can see here, was quite nicely responding. These are post-therapeutic SPECT CTs, and even on MRI, if you are using RECIST criteria, we have seen 50% reduction in size of the tumor. This is another patient with ovarian cancer, and in ovarian cancer, there is sometimes expression of the FAP on the tumor cell and not only in the tumor microenvironment. And this patient also was heavily pretreated, and after 3 cycles using yttrium-90 and lutetium FAP 3940, we have seen a complete remission in this patient, and this was also published in Lancet Oncology in this very nice review article. We have seen also other patients with complete remission, so this was the exception to stress this here with, for example, metastatic colon adenocarcinoma and a lot of peritoneal metastases, so over 50 small lesions. And we continued the chemotherapy with Folfox and Folfiri, and in addition used 3 cycles of lutetium, stribipes 3914, and after that we have seen complete remission of the disease. This is the only patient having a de novo radioligand treatment with breast cancer, lymph node, and heavy bone metastasis, and suffering from terrible pain. So the patient needed actually 3 hourly opioid injections to control the pain, and 2 hours after the treatment, the pain was nearly completely gone. You see the extensive metastases in the bone here, and the post-therapy SPECT-CT and the improvement after our treatment. So overall survival for all patients from start of treatment was 7.5 months. And what is remarkable, I think, is that the overall survival for PDAC, for ductal pancreatic adenocarcinoma, was 7 months. You might know that the disease itself from early diagnosis has just the overall survival between 5 and 6 months. So an additional 7 months, I think, is a remarkable achievement. To summarize, specific uptake and good tumor retention was present on the post-therapeutic lutetium and yttrium SPECT-CT images. We have seen very low accumulation in normal organs, especially no significant renal retention. Only mild or no uptake was noted in benign conditions, and that did not cause any complications. We have seen no major side effects. Sometimes mild alopecia occurred because the gallia of the skull also contains fibroblasts, and some fatigue, of course, especially when we were using higher doses of yttrium-90, but no grade 3 hematological adverse effects occurred and no renal or hepatic side effects. So restaging by molecular imaging and tumor markers showed cytotoxic effects of our treatment, specifically when using tandem therapy, and alpha radiation with high LET might be needed to kill CAFs, which per se are relatively slowly growing cells, whereas strong beta emitters like yttrium-90 might be necessary to kill tumor cells by crossfire effects. And best treatment effects were observed in combination with other oncological therapies, especially monoclonal antibodies against VEGF receptor like bevacizumab, or immune checkpoint inhibitors like pembrolizumab, and radiosensitizing chemotherapy like doxorubicin, irinotecan, or taxanes. So this is something new, and a message for all interested in the therapy: you do not have to stop chemotherapy. You can continue chemotherapy and other oncological treatments during the treatment with the radioligand therapy. We have seen some complete remissions, as I mentioned, and the perspective is, of course, to use and find the best combination. But I think the most exciting development, and that is on the horizon, is what we call covalent targeted radioligands. And there was an article published in Nature which showed this concept with the covalent warhead, which not only shows higher uptake, as you can see on this animal study, as compared to the normal FAPI, but that, and this might be the most important slide of my presentation, it also increases dramatically the retention of the compound in the tumor. So the area under the curve in gray is what we are using today, and the red one might be what we are using in the future. And this is not only a graph, this has biological consequences. As you can see here, the cytotoxic effects in this xenotransplant was much better than with the other compounds without the suffix components. There are now also early trials at Peking University Cancer Hospital, which shows that even in patients, this is a sarcoma of the shoulder, there is very long retention time, up to 2 weeks after treatment. You can do scans here, and very early uptake. Those scans remind me a little bit of radioiodine therapy, where you only see the tumor and nothing else. And in animals, Actitera has developed a similar compound. There is not only very much higher uptake, but also much longer retention time. Again, area under the curve is dramatically improved, which allow to achieve tumor doses of up to 497 gray, which might be curative for some smaller tumors. So what is important in the future is, as mentioned today in many presentations, precise information on genetics and molecular pathology, combination of therapies, as I have shown, interdisciplinary collaboration, which is a must if you are treating patients with 20 or 25 different tumors, and then what I call theranostic, which was nicely presented in the last talk, and training, especially of our young staffs. And for that, we have developed the ICPO Academy for Theranostic, with its 4 pillars: medical physics, radiochemistry, RPO, and nursing and patient management, with over 50 hours of online content. So who is interested can become member of the ICPO or the whole center. The ICPO Theranostic Centers, which is now a worldwide network. We have just passed 50 centers worldwide and aim at 100 centers end of next year. So I have to thank a lot of people. Also Abbas Alawi, I think he is not on this slide, but for many stimulating discussions, but especially our radiochemist Lukas Greifenstein, who did all this radio labeling, and Freddy Giesel, who is a very good partner, especially for the imaging. And I would like to invite you all to the next Theranostic World Congress, which is taking place in South Africa from 29th of January to 1st of February coming year. Thank you very much for your attention.
Thank you, Professor Bum. We will now allocate the 5-minute oral communication with our first speaker, Dr. Mansouri Farouk, presenting on radio iodine therapy in the era of personalized thyroid cancer care.
Alors bonjour, je vais vous présenter une toute petite présentation sur le... attendez, je vais ouvrir... Est-ce que ça marche? Est-ce que ça marche? Ça marche pas. Ça marche pas. Ça marche pas. استنى تشوف استنى تشوف خرج استنى تشوف روح ايه دوا خلي هذوك اصبر شوف ايه ما البريزونطاتور اما خرجت من هي من الدايره بس يجي يستنى برك حتى يعدلها من هي. Un résultat d'une étude de recherche qui a concerné 545 patients algériens, 545 patients algériens durant la période la période de 2018-2024. Vous avez mon outline. Les cancers de la thyroïde, c'est un groupe hétérogène de cancers et ils sont différents par leur origine, leur incidence et leur létalité. Les cancers différenciés représentent plus de 90% des cancers thyroïdiens. La fréquence par ordre décroissant, les carcinomes papillaires, les folliculaires leucocytaires et les cancers peu différenciés. En général, le pronostic est bon avec une mortalité faible et stable. Sur le plan épidémiologique, nous constatons depuis une trentaine d'années une augmentation du nombre de cancers de la thyroïde, principalement dû au nombre de cancers papillaires et spécialement les cancers micropapillaires. La mortalité est stable, suggérant que le cancer de la thyroïde subisse un surtraitement et un surdiagnostic. Le but de l'étude est d'évaluer l'efficacité d'un traitement basé sur l'évaluation du risque initial chez une population algérienne adulte. Alors, le design de l'étude est une étude prospective observationnelle monocentrique sur 545 patients adultes de la période 2018-2024, tous ayant subi une thyroïdectomie avec une classification OMS, TNM et AJCC 8e édition et ATA 2015. Tous les patients ont subi un traitement à l'iode. Tous les patients ont subi une réponse initiale, évaluation de la réponse initiale à 6 mois et à 12 mois et une stratification dynamique durant tout le suivi. Les caractéristiques générales de la population, il s'agit d'une population en général féminine. Le moyen d'âge est de 44 ans avec des extrêmes de 18 à 80 ans. Le carcinome papillaire représente 87,5% et 72% des patients sont unifocaux et 80% sont unilatéraux. Sur le plan de la classification TNM, plus de 50% des patients sont classés PT1 et 25% PT2. 86% des patients sont classés N0 et 93% sont M0. 88% sont classés AGCC1 et 6,2% AGCC2, 0,4% AGCC3 et 5% AGCC4B. Sur le plan de la classification de l'American Thyroid Association 2015, 50% des patients sont classés bas risque, 31% risque intermédiaire et 18,5% haut risque. Le délai moyen de la prise en charge des patients a été modulé par le risque estimé par la classification ATA et le délai de prise en charge était progressivement de 13 mois pour les hauts risques et 23% pour les bas risques. L'activité initiale des patients est de 50%, de 53% des patients ont subi une activité entre 50 et 80 et 39% ont subi une activité de 100 millicuries et 3,7 entre 140 et 200 millicuries. L'évaluation de la réponse initiale au 6e mois, nous avions une excellente réponse à 61% et 19,7% de réponse incomplète. À 12 mois, les choses ont évolué un petit peu et en faveur de l'excellente réponse, dont le taux est à 73% et la réponse incomplète à 18%. Le suivi était de 58 mois avec des extrêmes allant de 17 à 71 mois. Au stade final, nous avions 82% d'excellentes réponses et 5,3% de persistance biochimique ou de la maladie, 7,3% de persistance structurelle de la maladie et une mortalité de 2,8%. Nous avions comparé l'efficacité des systèmes, les deux, l'ATA et la réponse initiale au traitement, à prédire les résultats finaux. Et nous remarquons que 100% des patients qui sont décédés proviennent des patients structurellement incomplètes. Et nous avons une progression des excellentes réponses de 14,8% pour les structurellement incomplètes à 99% des patients excellentes réponses initiales avec un p-value significatif. Vous avez la courbe de survie qui est statistiquement significative en fonction de la réponse initiale au 12e mois. Nous avions comparé les réponses initiales en fonction des prévisions de l'ATA. Et nous remarquons que la mortalité est partagée entre les hauts risques et les risques intermédiaires. Par contre, l'excellente réponse, on note une augmentation progressive de 39% pour les hauts risques et 93% pour le low risk. Et vous avez la courbe de survie ATA en fonction la courbe de survie en fonction de l'ATA. En fin de compte, les classifications diffèrent par leur objectif dans la prise en charge du cancer de la thyroïde. ATA et AGCC sont des classifications qui permettent de guider le traitement initial. La stratification dynamique, elle est importante pour guider le suivi ultérieur et ajuster le suivi ultérieur. Et je vous remercie.
Merci beaucoup, professeur Mansouri. J'appelle la deuxième communicante, Dr. Chetibi, for high scores, quiet bones, rethinking risk in prostate cancer.
هذه ايكون présenter direct une flash disk. Votre présentateur. Juste le temps que ça s'affiche.
Good afternoon, esteemed members of the jury, distinguished guests. My name is Chitibi Ines. I'm a second-year resident at the Department of Nuclear Medicine of Annaba. Today, I'm honored to present my work entitled High Scores, Quiet Bones, Rethinking Risk in Prostate Cancer. My presentation would be structured as follows. First, a brief background on prostate cancer. Then I would discuss the impact of bone scan on the management of prostate cancer, so I can after present in detail my study. Starting with some statistics, prostate cancer is the most common urological cancer in men worldwide, second leading cause of cancer-related death in men. More than 2,000 new cases have been reported in Algeria since early 2025, making it for sure a huge public health challenge. Histopathology, the most important thing to highlight in here for us is that bones are the most common site for metastases from prostate cancer. Once in bones, prostate cancer cells disturb the normal bone remodeling, shifting the balance toward excessive bone formation. That's why prostate cancer metastases are often osteoblastic. Once injected, the coupled technetium MDP will bind to hydroxyapatite crystals through a process called chemisorption at sites of active bone remodeling, including those of metastases. A quick look on a crucial anatomical structure called the Baston's plexus. It's a network of valvulus veins, allowing a bidirectional blood flow. It connects the venous system of the prostate with an internal vertebral veins, helping with the dissemination of prostate cancer cells to the skeleton. It's also important to mention that PSA can be elevated in several conditions other than prostate cancer, such as urinary infections, so we can easily say that PSA is characteristic of prostatic epithelium and not of prostate cancer. According to the Amico classification, high-risk patients are those with a PSA level higher than 20 nanogram per milliliter or a Gleason score greater than or equal to 8. These high-risk features are among the main indications for bone scan according to the guidelines of the French Association of Urology. According to the same association, the impact of bone scan on the treatment strategy is up to 15%, 11% of which are major changes from curative to palliative strategy. This slide shows the several levels of implication of bone scan in the management of prostate cancer. Another important impact of bone scan, but now on the survival rate, while the 5-year survival rate for local and regional prostate cancer is nearly 100%, it decreases dramatically to 37% for metastatic prostate cancer. Now, versus PET-CT, as a part of prospective study, prostate cancer patients underwent both a PSMA PET-CT and a bone scan at the Department of Nuclear Medicine of Turin. The results were that PSMA PET-CT led to a TNM upstaging in 45% of cases. Another retrospective study that included prostate cancer patients who received both bone scan and PSMA PET-CT within 3 months showed the well-known superiority of PET-CT. At this point, we may think that it's so obvious and easy to say that PET-CT is much better than bone scan. But on the other hand, we should not forget that bone scan is more available, less expensive, lower radiation dose, and decades of clinical use. That's why, till this day, bone scan remains the conventional imaging modality to detect skeletal metastases in prostate cancer patients. So overall, we have a very common cancer with high morbidity, high mortality, that is highly osteophilic, mostly osteoblastic, with well-established but standardized indications of bone scan in high-risk patients. On the other hand, we have a conventional imaging modality that has a huge impact on both treatment strategy and the survival rate. So our study aimed to evaluate the correlation between high PSA levels, high Gleason scores, and the absence of metastases on bone scans in high-risk prostate cancer patients. We performed a retrospective study that included newly diagnosed prostate cancer patients referring to Nuclear Medicine Department of ANABA from January 2022 to May 2025. 100 patients met the predefined criteria of inclusion with a mean age of 70.7 years. The study included 2 major groups of PSA levels and Gleason scores divided according to the D'Amico classification. For each group, we evaluated the results of bone scans. Bone scans were performed in our department using MDP labeled with technetium-99 metastable, administered intravenously at a dose ranging from 8 to 20 millicurie. A whole body planar imaging and SPECT CT acquisitions were performed 2 hours post-injection using a hybrid head dual gamma camera equipped with low-energy, high-resolution collimators. So this study validated the positive correlation between raising PSA levels, increasing Gleason scores, and positive bone scans. We can clearly see that as the PSA levels and Gleason scores increase, the proportion of positive bone scans increases as well. But it also revealed an unexpected significant proportion of negative bone scans among high-risk prostate cancer patients. Patients with PSA levels higher than 20 had an identical rate of positive and negative bone scans, which makes us question the relevance of bone scan indication in here. And even if patients with Gleason scores greater than or equal to 8 had a slightly higher rate of positive bone scan, a significant proportion still had negative results. The subdivision of high-risk patients into 2 additional ranges with a higher PSA cutoff, 60 instead of 20, helped find more significant difference. Patients with PSA levels between 20 and 60 have now a significant higher rate of negative bone scans, while patients with a PSA level higher than 60 have a significant higher rate of positive bone scans. At this stage of our study, we encountered an interesting paradox. This retrospective study talked about an 80-year-old high-risk patient who had a bone scan with no MDP-avid bone lesions, but a PET scan done 3 weeks earlier showed innumerable PSMA-avid skeletal metastases. So sometimes silence is not always absence. So, despite the well-established association between high PSA levels, aggressive Gleason scores, and metastatic bone scans, our study also revealed a significant proportion of negative bone scans in high-risk prostate cancer patients. Patients with PSA levels higher than 60 showed a higher association with bone metastases compared to those with PSA levels above the conventional cutoff, 20 nanograms per milliliter. To conclude, these findings may challenge the conventional expectations that high-risk features often align with bone metastases, maybe suggest a higher PSA cutoff, 60 nanograms per milliliter instead of 20, but they may also raise some key questions, like the potential limitation of bone scan in detecting early or indolent bone metastases, highlighting the need for further studies investigating false negative bone scans using more sensitive and specific imaging modalities, above all PSMA PET-CT. And thank you for your attention.
Merci beaucoup, Dr Chetibi, pour la présentation. Et je pense qu'on va faire une petite pause café et on va suivre par la suite. Coffee break for all of you. You have 50 minutes.
Thank you.
Great.
Thank you. Thank you. Très bien.
Non, 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 tu rien. Tu as dépassé un peu le temps, mais bien, c'est parce que tu fou.
Very good. I have a suggestion. Just look at the outcomes of those cases who have negative the survival and see whether you're actually depicting the benefits to a negative scan. So they don't have a no, with a bone scan. See the difference between those who have, let's say, high risk, let's say about 20, and those who have a positive, those who don't. And see whether there's a difference, because that would be the added value of why still using it. Otherwise, nobody will use it. And if you see a difference, it will be a high impact of journal because you've done it's very good. But just a suggestion. Thank you so much.
Jacques Barka, تروحي c'est bon. Un post café.
Bonjour.
Bonjour.
C'est une petite étude que vous avez fait dans le service, c'est ça? Oui, bah voilà. Ouais, bah écoutez, c'est la fiche.
بس سهلة. لا vous avez quatre communications, on va discuter, ils vont noter après les meilleures communications.
1, 2.
On reprend la séance des communications orales. Dr Belhoussine Tariq Zin, cervical cancer, lymphatic mapping and sentinel lymphadenectomy, systematic review.
Merci bien. Pour que ça passe à l'écran. Parfait. Bien.
Vous avez 6 minutes.
Oui, bon, soyez un peu indulgents, parce que, bon, comme pour les autres. Chers amis, j'ai le plaisir et l'honneur de vous présenter, avec le docteur Jean-Luc Urbain, une revue systématique de la littérature sur la valeur ajoutée du SPECT-CT pour la détection du ganglion sentinelle dans le cancer du col utérin. Comme vous le savez, le cancer du col utérin est un problème de santé publique. C'est le 2e cancer gynécologique dans le monde. Et c'est aussi un cancer lymphophile pour lequel le end-staging est une étape clé dans la prise en charge de la patiente. Les grandes sociétés internationales, européennes et américaines, ont révisé leur classification et ont incorporé la biopsie du ganglion sentinelle dans leurs guidelines. L'IANM et la SNM ont fortement recommandé une imagerie préopératoire et ont considéré le SPECT-CT comme clairement utile dans leurs guidelines conjoints de 2014. Nous avons réalisé une revue systématique de la littérature à partir de PubMed, Google et ResearchGate, une recherche exhaustive depuis le début jusqu'à mai 2025. Nous avons pu retrouver 29 articles correspondant à des études unicentriques et 2 articles correspondant à des études multicentriques. Ces études unicentriques ont été réalisées dans 14 pays, soit les 6 continents ou régions du monde, l'Europe, l'Asie, l'Amérique du Nord, la Russie, l'Afrique, et même l'Amérique du Sud pour l'étude multicentrique de l'AIEA. Pour ces études unicentriques, le SPECT-CT a permis une fusion d'images hardware, le plus souvent, software, SPECT plus CT MRI dans une étude, hardware plus software, SPECT-CT plus gadolinium MRI, hardware plus software, SPECT-CT plus SPO MRI avec fusion cognitive d'images. Il y avait 18 études prospectives, 9 études rétrospectives, une analyse rétrospective d'une étude prospective, et dans une étude, le design n'a pas été précisé. Au total, 1454 patientes ont été étudiées par SPECT-CT. Elles présentaient le plus souvent un stade précoce de la FIGO, 1A, 2A ou 1A, 1B1. Dans ces études unicentriques et multicentriques, des traceurs préopératoires ont été utilisés pour le SPECT-CT, les technétiums colloïdes habituels, pour l'IRM, le gadolinium ou le SPO, des traceurs intraopératoires comme le bleu de méthylène, également le vert de cyan indien dans certaines études, indocyanine green, et intéressant à noter, le traceur hybride fluorescent et technétium dans 2 études. Tous les types de SPECT-CT ont été utilisés dans ces études, en particulier la Hawkeye 4 et la Symbia T16. Le protocole SPECT-CT le plus fréquent était en 2 jours, c'est-à-dire 16 heures à 24 heures avant la chirurgie pour 17 études, mais aussi en 1 jour et 1 ou 2 jours parfois. Le taux de détection global du ganglion sentinelle sur 27 études par SPECT-CT est évalué à 92%, avec un nombre de ganglions sentinelles supérieur en SPECT-CT par rapport à l'imagerie planaire. Pour le taux de détection bilatéral, il était évalué en SPECT-CT à 70-71%, supérieur à l'imagerie planaire, 60 à 61%. Il est intéressant de noter que le traceur fluorescent seul ou combiné au protocole complet présentait un taux de détection nettement supérieur, 93,7%, 94 voire 100%. Le SPECT-CT a permis de détecter des ganglions sentinelles dans des localisations prédictibles ou typiques, mais aussi dans des localisations imprédictibles ou atypiques, comme vous pouvez le lire sur la dia. Le taux de détection de ganglions sentinelles métastatiques sur 27 études était évalué à 15 ou 16%, ce qui est conforme aux grandes cohortes de gynécologie oncologique. Pour la sensibilité et la valeur prédictive négative, selon qu'il y ait eu une détection unilatérale ou bilatérale du ganglion sentinelle en particulier, l'on avait pour la sensibilité une sensibilité de 90% ou 98%, pour la valeur prédictive négative de 93,5% ou 98,9%. Pour les deux études multicentriques avec le SPECT-CT, l'étude de l'AIEA, une étude prospective incluant 15 patients, et pour l'étude européenne multicentrique rétrospective, nous avons les mêmes résultats que pour les études unicentriques, à savoir que le taux de détection global du SPECT-CT est supérieur à l'imagerie planaire, mais que le traceur fluorescent présentait un taux de détection supérieur au SPECT-CT pour la détection bilatérale. En conclusion, mes chers amis, cette revue systématique de la littérature a pu montrer, premièrement, la valeur ajoutée du SPECT-CT comme imagerie hybride anatomique et fonctionnelle des ganglions sentinelles, le recours à une chirurgie minimalement invasive par laparoscopie ou le robotique, et aussi, point très important, un ultra-staging avec une pathologie sophistiquée des ganglions sentinelles avec des coupes serrées et l'immunohistochimie. Deuxièmement, une confirmation des revues précédentes d'il y a 10 ans déjà, de Hugendam, 2015, 8 études, de Collarino, 2016, 9 études. Nos résultats sur 29 études unicentriques, 1454 patients, retrouvent des résultats excellents pour la détection globale du ganglion sentinelle, la sensibilité et la valeur prédictive négative. Le SPECT-CT est supérieur à la lymphoscintigraphie planaire pour la détection globale du ganglion sentinelle, mais le SPECT-CT est suboptimal, inférieur au traceur fluorescent pour la détection bilatérale des ganglions sentinelles. Troisièmement, il y a des nouveautés, des innovations avec le traceur hybride, après l'imagerie hybride, le traceur à la fois fluorescent et technétier, une nouvelle indication potentielle pour la planification de la radiothérapie et la distribution des ganglions sentinelles, et en plus de la fusion hardware, la fusion hardware plus software, SPECT-CT IRM. Et aussi intéressant de noter que l'étude Senticol 3, une étude internationale randomisée devant inclure 900 patientes, a inclus dans son design une recommandation d'utiliser le SPECT-CT pour la détection du ganglion sentinelle. Je vous remercie pour votre attention.
Alors, on appelle Feriel Koudry for Pediatric Differentiated Thyroid Cancer, Experience of the Nuclear Medicine Department of Bebelwet Hospital.
Scandale. اللي مشغولتي احنا دبروا راسكم شكون فهمتي لا لا
كيقول لك انت
ضامي لو بيو وزي شيك
La deuxième fille.
Good evening, everybody. I'm Dr. Koudri, and I'm gonna review with you our experience at the Nuclear Medicine Department of Bablouad Hospital about the differentiated thyroid carcinoma in the pediatric population. So the DTC is the most frequent endocrine malignancy, but relatively rare in the pediatric population. The complex management of the pediatric DTC might be explained by the sparse and the heterogeneity of the population, the lack of studies, and the absence of actual dedicated guidelines until 2015. And the problem starts with the question, what is the age limit of pediatrics? And not surprisingly, the answer is not straightforward. Institutional definitions of pediatric are not pertinent. So we chose the Algerian and the World Health Organization definitions that included adolescents up to 19 years. We conducted a retrospective cohort study over a period of 21 years from 204 to June 2025 that included patients diagnosed with DTC at an age under 19 years and oriented at Bablouad's Nuclear Medicine Department for isotopic management. 98 patients were included over a total of 6,976, representing 1.4% of the total population. 5% patients didn't receive radioactive iodine therapy because lost to follow-up. The mean age at diagnosis is 14 years, and we reported a clear feminine predominance. Most patients came from the northern regions of Algeria, mostly from Algiers, Tizi Ouzou, Blida, and Borj Bararij. 6% patients had a personal history of malignant disease and 5% thyroiditis. Family thyroid pathology was reported benign in 34% cases and malignant in 9% cases. The most frequent circumstance of discovery was multinodular goiter and isolated thyroid nodule. Regarding the histology, papillary thyroid carcinoma was found in 99% cases. The classic and follicular subtypes were the most frequent, and only one case of NIFT was reported. 45% cases reported vascular invasion and 42% capsular invasion. As to the PTNM, tumor stage was classified or reclassified according to the 8th edition of the TNM classification to facilitate the comparison of the tumor. So we noted the predominance of T1, T2, and N1 stages, and only one case had a histologically proven metastasis. 99% patients underwent a total thyroidectomy, 87% in a single procedure, while 12% needed a completion surgery. 62% patients underwent a lymph node dissection, whereas 45% had a pre-surgical lymph node involvement. 53% had a histologically proven lymph node metastasis. Most lymph node dissections included the lateral compartment, and 7 reported cases of postoperative complications as dysphonia or hypocalcemia. 60% patients were classified as low risk according to the 88-2015 risk stratification. And regarding the radioactive iodine treatment, the mean initial activity was 3.35 gigabecquerel. Number of iodine administration ranged from 1 to 8 times, and an average cumulative activity of 13.29 gigabecquerel. Metastatic disease was found in 65% cases after initial treatment, and during follow-up, only one case of synchronous metastasis was reported. 29% patients had an excellent response to initial treatment according to the modified pediatric DRS, and the majority were in remission, 44%. So in our study, we observed the predominance of papillary thyroid carcinoma, notably the classic and follicular subtypes, the high rate of lymph node metastasis. Despite the high activities of radioactive iodine sometimes used, no case of pulmonary fibrosis was reported. The majority of patients showed an excellent response to initial treatment and remission during follow-up. Among the low-risk patients, 60% had an indeterminate or incomplete response to initial treatment, and 27% showed a persistent or recurrent disease, which led us to question the accountability of a possible genetic component. I conclude by saying that the DTC in pediatric population has a good global prognosis, needs a multidisciplinary management and lifelong follow-up. A cautious assessment of benefit-risk ratio is essential, notably concerning the radioactive iodine therapy. We can't treat children as many adults, so there is a need to set up dedicated guidelines and recommendations. And I finish with the emerging role of molecular biology and its promising future contribution in risk stratification and treatment. Thank you.
Thank you very much for respecting the time. So we call Fréjuste Agbouton for therapeutic desescalation in low-risk DTC towards personalized care.
Si c'est...
Kiff. Tac, rétrospective, elle est analytique. C'est pas un
C'est bon.
Bonjour à tous, je suis le docteur Agbouton Fréjuste. J'ai le plaisir de vous partager les résultats préliminaires de notre étude sur la désescalade thérapeutique dans les cancers, dans les carcinomes thyroïdiens différenciés de faible risque au CHU de Bab-el-Oued. Pour cette présentation, je commencerai par vous présenter, par contextualiser notre problématique, puis j'exposerai nos objectifs et notre méthodologie avant de partager nos résultats et d'ouvrir sur les perspectives. En introduction, nous dirons que les cancers différenciés de la thyroïde sont des cancers de très bon pronostic avec plus de 95% de suivi à 10 ans pour les formes localisées. On observe une augmentation de leur incidence, notamment en raison du surdiagnostic des microcarcinomes. Historiquement, la prise en charge reposait sur une thyroïdectomie totale, suivie d'une irathérapie exposant à des effets secondaires non négligeables. Les nouvelles recommandations renforcent la stratification précise du risque et l'adaptation ainsi que l'individualisation des traitements, de faibles activités et parfois une abstention thérapeutique. Les études estimables conduites en 2007 et 2012 en France, ayant pour objectif de comparer deux activités d'iode 131 et deux modes de préparation chez des patients à bas risque, ont clairement montré la non-infériorité des faibles risques, des faibles activités, et ce, quel que soit le mode de préparation, avait significativement moins d'effets secondaires pour les faibles activités. En Algérie, l'absence de tests moléculaires impose d'adapter cette désescalade sur la base des critères clinico-pathologiques. Fort de ces évidences, nous avons voulu évaluer si notre service pouvait implémenter efficacement cette stratégie de désescalade. Notre objectif principal était donc d'analyser l'efficacité de notre protocole adapté, tout en caractérisant précisément le profil de nos patients et en comparant les résultats selon les différentes activités utilisées au fil des années. Pour répondre à cette question, nous avons mené une étude mixte, rétrospective jusqu'en 2024 et prospective depuis septembre 2024, couvrant actuellement 235 patients traités par thyroïdectomie totale et irathérapie en 2005 et 2025. Les critères d'inclusion reposaient sur la classification ATA 2015 des faibles risques. Le sevrage hormonal reste notre méthode par défaut, utilisée dans 86% des cas. La TSH recombinante n'est réservée qu'aux patients n'atteignant pas un TSH satisfaisant après sevrage, optimisant ainsi son utilisation. Concernant les activités, nous avons progressivement diminué au fil des années, 100 millicuries jusqu'en 2015, puis 50 jusqu'en 2023 et enfin 30 millicuries depuis septembre 2024. L'évaluation actuelle repose principalement sur l'obtention d'une ablation complète, notamment une TG non stimulée inférieure à 1 nanogramme par millilitre, des anticorps anti-TG négatifs, une échographie cervicale normale, une absence de fixation pathologique à la scintigraphie. Dans certains cas, lorsque disponible, la TG stimulée et la scintigraphie post-thérapeutique étaient aussi prises en compte. Passons maintenant à nos résultats. Notre population présente un âge médian de 51 ans, avec une nette prédominance féminine à 87%. Les circonstances de découverte sont dominées par les tuméfactions cervicales, et par les découvertes fortuites, notamment à l'échographie, avec un âge médian de découverte autour de 48 ans. Sur le plan histologique, nous retrouvons 68% de carcinomes papillaires classiques et 23% de sous-types vésiculaires. Près de la moitié des tumeurs sont classées T1A et la multifocalité concerne près d'un tiers de nos patients. Concernant la chirurgie, tous nos patients ont bénéficié d'une thyroïdectomie totale réalisée en un temps dans 90% des cas. Le curage ganglionnaire a été pratiqué chez 23% des patients. Nous notons un taux de complications remarquablement bas à 4,3%. Un point encourageant est la réduction progressive du délai entre la chirurgie et l'irathérapie. D'une médiane de 14 mois avant 2015, nous sommes passés à 7 mois actuellement. La tolérance immédiate au traitement est excellente avec seulement 6,4% de sialadénite. Cette diapositive compare l'efficacité des 3 activités utilisées. 94,4% de succès avec 30 millicuries, 93,6% avec 50 et 94,1% avec 100, avec une absence de différence significative. On note un taux de récidive global très faible à 3,4%, soit seulement 8 patients sur 235. Ces récidives sont principalement ganglionnaires. Nos résultats préliminaires suggèrent que les faibles activités sont non inférieures pour l'ablation. L'approche sauvage d'abord avec recours sélectif à la TSH recombinante apparaît comme une stratégie pragmatique, efficace et économiquement adaptée. Enfin, malgré l'absence de biologie moléculaire, une sélection rigoureuse reposant sur les critères clinico-pathologiques classiques demeure pertinente. Nous devons néanmoins reconnaître les limites de ce travail préliminaire. Cette analyse reste préliminaire et basée sur un échantillon non exhaustif avec un risque de biais de sélection et une hétérogénéité temporelle. L'absence de données moléculaires constitue une limite supplémentaire. Nos perspectives concernent la poursuite de la collecte pour une analyse exhaustive, l'évaluation prospective de l'abstention thérapeutique, une analyse coût-efficacité de la désescalade dans le contexte algérien, ainsi que le développement d'un registre national des cancers thyroïdiens. L'objectif est également d'identifier des facteurs clinico-pathologiques prédictifs malgré l'absence de biologie moléculaire. En conclusion, nous dirons que la désescalade à 30 millicuries s'avère efficace pour les carcinomes thyroïdiens différenciés à faible risque au CHU de Babloued. Une adaptation des recommandations ATA 2025 reste possible sans biologie moléculaire grâce à une sélection stricte. L'évaluation de l'abstention thérapeutique chez des patients ultra sélectionnés est déjà en cours dans notre service. Si confirmé, ces résultats pourraient soutenir une adoption plus large de la désescalade thérapeutique en Algérie. Voilà nos sources. Nous vous remercions pour l'attention.
Merci beaucoup pour le respect du temps. Thank you for respecting time. And we call Raqiya Ghanam for PET-CT FDG prosthetic and endocarditis toward improved diagnosis detection.
On n'a pas pu venir. Donc.
She's not present.
Non, enregistré.
Ah, okay. She's recorded. Under 75. Under 75.
To present our work at this conference. I deeply regret not being able to attend, but I am very pleased to share with you our study entitled 18 FDG PET-CT.
On a donc les résidents là, c'est le temps.
CT and prosthetic endocarditis towards improved diagnostic detection.
Ça marche pas? Comment on fait?
Our present
C'est en zap. Je crois pas.
C'est tout.
Ah.
C'est marrant.
Hein? Il n'y a plus? Okay, I have finished. So, thank you very much for your presence. And now the closing ceremony. Après, il y a quoi? De clôture.
De clôture.
Il y a quoi?
On fait les mêmes, c'est la même.
C'est la même chose.
So sorry to make you waiting. We will start with the closing ceremony, and we have just small cadeau, small gifts. Yes, to our guests. We thank them so much to make all this path to come here and to make this conference possible. So we call Professor Abbas Alawi and Dr. Ghadban. So This trophy is an Arabic gold painting, hand painting, traditional, with the name of each guest.
It's been a pleasure to be here, and I really appreciate your kindness to invite me to come to your country and I meet my brothers and sisters in your country. Thank you so much for all your kindness. This is one of my joys in academic life, is exactly doing what I've done during the past few days. Just like get to know so many of you, listen to your talks, and see that your country is doing extremely well, and anything I can do to help you, please let me know.
Next guest, Professor Estrada, and the trophy will be given by Dr. Millah. Professor Estrada. It's handwritten, yes, with gold. Next, Professor Shi, and the trophy given by Dr. Ghadban. Next one, Professor Labji. And the trophy given by Mr. Millah, Dr. Millah.
You really know how to work with people. Thank you. I can be sure to.
Next one, Professor Giovanella, and the trophy will be given by Mr. Gitoum, President of the Algiers Center of Nuclear, who is hosting us here.
Thank you very much. It was a great pleasure, great interactions, great honor to know a pillar of nuclear medicine and many other clients. And so I hope this is the first time, but not the last in Algiers. Thank you very much.
Next one, Professor Zaidi, also given by Mr. Gitoum. Next one, Professor Flamen. And the trophy by Professor Amimour, ICON chair and president-elect of the association. Next one, Professor Asadi, also by Professor Amimour. Next one, Professor Pierre-Yves Marie, with Dr. Radban, president of the association. Next one, Professor Khalaf Aysar, also by Dr. Radban. Professor Dadgar, Habibullah, given by Mr. Millah, Commissioner.
Thank you so much. It's a great gift. Thank you so much for your invitation. We'll be dismissed here. We can more preparation in this. I think thank you so much. Thank you.
Bismillah. Bismillah. Next one, Dr. Jilbani, also by Mr. Millah. Next one, Dr. Girnu, given by Mr. Millah. Mr. Gitu, sorry.
Merci à toute l'organisation, cette super équipe. Beaucoup de plaisir à partager avec vous.
Next one, Professor Shatibi, we have his daughter here. And it will be given by Mr. Gitu. Next one, Dr. Khalasi. Dr. Khalasi Toutawi. Badis Rahal. Yes. So next one. Next one, Mr. Shinoufi. So Mr. Millah will receive it for him by Dr. Rabban. Next one, Dr. Uthman. By Dr. Ghadban. And we finish with Professor Amimour, Chair of the AICON, President-elect of the association, and it will be served by the actual President of the association. Now we will pass to the best poster, best oral communication, and best oral communication for residents. So Dr. Omaru Osman, he is the laureate of the best poster communication.
C'est le prix qu'Edadra. Meilleure communication. Meilleure communication.
Next one is the laureate of the best oral communication. It has been named in homage to Mrs. Kedadra, who were working in the Ministry of Health and given a lot to health in Algeria. So the laureate of the best oral communication is Dr. Feryal Koudri. And the prize will be given by Mr. Maleh, the commissioner.
La photo. Vas-y. La photo.
So, and she is also the laureate of the best oral presentation for residents, as she is a resident, and the prize will be given by Professor Amimour. The prize of the best oral resident communication is a fully funded participation for an international congress. And of course, you saw this announcement for our Congress for the next year. It will take place between 20 and 21 November, inshallah. So, closing word with Dr. Ghadban, President of the Algerian Association of Nuclear Medicine.
Bismillah ar-Rahman ar-Rahim, wassalatu wassalam ala ashraf al-mursaleen. Ladies and gentlemen, esteemed colleagues, as we close this second edition of Algiers International Conference of Nuclear Medicine 2025, allow me to express my deepest gratitude to the Atomic Energy Commissioner, to the Algiers Nuclear Research Center, and the local authorities for their strong support. I want to extend a special and heartfelt thank you to all the speakers and experts. Your presence, your time, and your commitment honor this Congress and enriches our collective understanding. Your contribution remind us that Congress in nuclear medicine to build on cooperation that transcends borders. I also want to warmly thank the organizers, whose dedication and precision have made this event possible, as well as our sponsors, whose support ensures that scientific progress and collaboration can flourish. Your contributions are essential to the advancement of our field. Your work strengthens our ability to diagnose earlier, treat more precisely, and offer every patient, wherever they live, a fair chance to better health. Thank you for your dedication, your vision, and your service to patients. I hereby declare this Congress closed, and I look forward to seeing you all the next edition. Thank you.